Good morning, everyone. After a very exciting day on day one, where we focused on rheumatological aspects and basic translational sciences in sarcoidosis, we now kick off the core clinical subjects, so to say. So today is a jam-packed day in which we'll have pulmonologists and other specialists of other specialties also tuning in with their take on sarcoidosis, clinical features management, and one exciting session in the afternoon, which is focused entirely on our most common clinical dilemma of how to differentiate between tuberculosis and sarcoidosis. So without much ado, we'll start off the first session. The first session for today is on pulmonology. For this session, I would like to welcome our moderators, Dr. Ashfaq Hassan, who is the professor of pulmonology at OIC and Deccan Medical Sciences, and Dr. Vishwanath Gella, who is the director of the pulmonology services at AIG Hospital. Over to you, sir.
Very good morning, everyone. Welcome you all to the second day session of Sarcoidosis Summit. We had interesting sessions on basic research sessions and rheumatological presentations yesterday, and today will be dedicated for the other systemic manifestations. We start off the second session now. There's a slight change in the second session. Dr. Randeep Guleria, who was supposed to present the first talk, is not able to make it to our conference because of some unavoidable commitments. In his place, Dr. Valliyappan Muthu will be speaking to us on the pulmonary phenotypes of sarcoidosis. And to introduce Dr. Valliyappan is an young and dynamic pulmonologist who is working as an assistant professor at Chandigarh. And I would sincerely thank him for accepting our invitation to talk on this pulmonary phenotypes just a couple of days ago. I think it would be impossible for anyone to talk on this exhaustive topic with a given time of 2 or 3 days, but he has agreed to do that, and I hope he will be able to deliver some sense in this pulmonary phenotypes of sarcoidosis. And he has done a lot of work on pulmonary infectious diseases, especially mucormycosis. One of his recent papers has been published in CDC Atlanta's official journal, Emerging Infectious Diseases. And he has got more than 30 indexed publications in very good international and national journals, actually. And I invite him to deliver his talk on pulmonary phenotypes of sarcoidosis. Welcome, Vali. Can you unmute your mic, Valliyappan? Please unmute your mic.
Yes, sir. Yes, sir. Yeah, hope I'm audible right now. Thank you, sir, for the kind introduction. So, I'm here to discuss on the pulmonary phenotypes in sarcoidosis. So, this is an evolving field to begin with. So, yeah, the first one is, what is a phenotype? A phenotype is the observable physical properties of an organism, and these include the organism's appearance, development, and behavior. The phenotype is determined by the genotype, which is the composition of genes that each organism carries and the environmental influence upon these genes. So this is the biological definition of a phenotype. So I would like to highlight few things which are important here. The observable properties determined by the genetic composition and influenced by the environment. So this holds true even for a disease like sarcoidosis. So we are trying to look at observable properties in sarcoidosis, which are determined by the genes and modified by the environmental factors. In a nutshell, the people with a similar genetic composition might have a different phenotype, depending on the environmental influences beared upon them. Similarly, people residing in the same environment, exposed to the same environmental factors, might develop a different phenotype depending on their composition of the genetic material. So this is the crux behind how the phenotype works. So then coming to the important category, why do we need to phenotype? So towards the left of the screen, we see a cluster of different colors. So that is how disease like sarcoidosis, which is an umbrella term for a heterogeneous group of diseases. So we lump together under the umbrella of sarcoidosis, cutaneous sarcoidosis, ocular, pulmonary, and different forms of pulmonary. So our job is to make them into clearly distinguishable groups which are homogeneous, so that the diagnostic modalities and the therapeutic modalities can be guided to each of these phenotypes in an appropriate manner. For example, A simple Lofgren syndrome, lymph nodal fever, lymph node and fever might be extremely different from a hypercalcemia or a vision-threatening sarcoidosis. So now that we know a phenotype is required, so how should an ideal phenotype be? It must be easy to identify. It must be consistent in classifying the subpopulations of the disease. And most importantly, it should have either a diagnostic, therapeutic, or prognostic implication. So, where are we with regards to phenotypes in sarcoidosis? Sarcoidosis, we do not have well-defined phenotypes based on either the risk factors or the genetic factors, which are very clearly defined. So it's a multi-gene disease. So we do not have a single causative gene. So we do not have a clear phenotype based on the genetic factors or the genetic predisposition. So primarily, the current data is limited to the phenotyping based on demography, such as the difference of sarcoidosis in terms of its behavior in different age groups, different sex, the racial factors, and as we commonly know, the different organ of involvement and the severity based phenotyping. And the last but the most important one is whether it requires treatment or not. If a treatment required, what kind of treatment is required. So a brief overview of what has been told about the phenotyping of sarcoidosis. Some of these phenotypes are restricted only to pulmonary, while others are general. For example, the acute and subacute onset of disease in sarcoidosis, these two have been shown to be slightly different from each other, and they are recognizable groups. For example, the acute onset ones are generally younger age group, female, have a better lung function, and have a different symptom profile. That is, they predominantly have systemic symptoms and less of cough and dyspnea. And more importantly, they are short-lasting disease and might not even relapse or recur again. The second category of phenotyping, which we all know, is based on the organ involvement, pulmonary, extrapulmonary versus ocular. In a large multi-center study, it was shown that the need for therapy was distinctly different between the three categories. Nearly 3/4 of the ocular sarcoidosis required treatment, whereas pulmonary required in about 2/3, whereas the extrapulmonary required treatment in only 1/3 of the patients. So, and as you all know, the pulmonary and non-pulmonary have obvious differences in the diagnostic modality which we are going to use. And the last category, which is the Lofgren versus non-Lofgrens, the Lofgren syndrome kind of presentation typically is associated with a better prognosis, short lasting, and they have a overall better long-term outcome. So, as I said, genetic associations are not very clear in sarcoidosis, but still there has been some progress, particularly in the last decade. So there are HLA associations which have been described, which have been either protective or associated with sarcoidosis. And few of them are important in prognosticating. For example, if a patient with sarcoidosis is identified to have this DQB or DRB10301, which are all seen in some Caucasian population, they have been shown to have a good prognosis, acute and onset, and have been shown to be protective against sarcoidosis. Similarly, certain other genes are associated with more severe disease. But this is not consistent throughout the globe, and that needs to be taken into account. So, this table beautifully summarizes the progress which have been made in the last decade. As I told you, there are multiple single center and multiple center studies which have tried to phenotype sarcoidosis either based on one or two parameters, say a chest radiograph or a PET CT or a composite of multiple factors. For example, the earliest one, the SCADing classification, is the classical paper which was published in 1961, which was based on chest radiograph alone. In contrast, the more recent multi-center studies, the last 5, have been based on cluster analysis. They have taken into account many clinical features and tried to classify it into various phenotypes based on a statistical modeling. The largest one has identified several clusters and correlated them with genetic profile. And the most commonly used ones are treatment guided. For example, severe versus non-severe, sarcoidosis, the acute versus chronic, acute versus relapsing, severe versus non-severe. So this table gives a brief overview that we have not made significant progress in terms of the risk factors or the etiology, and the phenotypes have been so far restricted to the need for treatment, the severity of disease, and the extent to which the treatment needs to be guided. So, coming to the most important question, is subtyping of the pulmonary phenotypes required or not? Yes, it is absolutely required because pulmonary site of involvement and a thoracic sarcoidosis is the most common to be involved. Despite a sizable proportion being milder disease, pulmonary sarcoidosis still contributes to the major morbidity and mortality and a significant burden on healthcare. So I would just describe few of the phenotyping which have been described in detail. For example, this was the review of 136 cases of intrathoracic sarcoidosis published way back in 5-6 decades back. And here, briefly they classified it into 4 stages. The first one to the top left is the lymphadenopathy. The second one is stage 2 lymphadenopathy with pulmonary infiltrates, and the third one is infiltrates alone. The fourth one is fibrosis. So what was done here was these patients were followed up for the next 5 years, and we can see how the phenotyping has helped. And the phenotyping was based on this prognosis. The one which had only lymphadenopathy, at the end of 5 years, there was no death attributable to sarcoidosis and no severe symptoms attributed to sarcoidosis. Whereas the fibrotic kind of sarcoidosis had death in a sizable proportion and severe disease was seen in nearly one half of these patients. So that is how the prognostication was made based on this classification. This indirectly tells us the ones who are in stage 1 are unlikely to progress over the next 5 years. So that is how this was important. However, this still remained imperfect because this was done in an era where computer tomography and other sophisticated investigation are not there, and more evidence has accumulated over time. But still, for a large proportion, this staging has relevance even today, while more evidence is being accumulated with that. So, coming next, this is the most recent cluster analysis based on a study of 594 patients, including 29 clinical parameters and a statistical modeling. So, despite trying to find out clusters, finally the authors could arrive at 2 basic clusters. Those 6 have been mentioned. These have been grouped into 2 major clusters. The 1, 2, and 3 are the less severe disease. The 4, 5, and 6 are the more severe disease. This graph shows that the FEV1 and the FVC, that is the lung functions, decline with the clusters identified, and it is more bad in the severe clusters. And these clusters are 2 distinct ones, and they affect the prognosis as well as the treatment which needs to be offered. So the important phenotype or the subclassification of pulmonary sarcoidosis is an advanced pulmonary sarcoidosis. This constitutes to only 10% of the pulmonary sarcoidosis. However, these are the most severe group of people who require hospitalization and treatment like lung transplantation or rehabilitation. So this category is also not homogeneous. It includes extensive fibrosis, a UIP-like pattern, which on biopsy reveals granuloma or fibrosis along with granuloma. The second category is bronchitis and fibrocavity disease. The third category and fourth category are like complications of pulmonary sarcoidosis, which manifest as advanced pulmonary sarcoidosis. That is chronic pulmonary aspergillosis and pulmonary hypertension. So this advanced pulmonary sarcoidosis, identifying them has relevance since they are associated with poor survival, and a pulmonary rehabilitation or lung transplantation may be required in this group of people. So like I have said, the phenotyping currently of pulmonary disease has boiled down to guiding our therapy. So this was the recent Delphi consensus based on the expert opinions from several experts in managing sarcoidosis globally. So here they concluded that the pulmonary function testing was an important parameter. This graph shows the confidence with which the experts recommended the treatment. So the asymptomatic ones with pulmonary function being very good, the experts felt that the treatment is not required based on the existing evidence. Whereas the symptomatic ones and those who have a FVC which is affected are at the extreme corner, and most experts felt the need for the treatment. Similarly, imaging has been used as a guide to therapy. So here again, it has been categorized into asymptomatic and symptomatic people. The SCADing 3 and 4 are felt to be the ones who require more treatment, and the ones with fibrosis are those who require treatment for a longer duration. That was the opinion. So I'm not going into the details of the management, but here again, I would like you to focus on the three major phenotypes identified for the pulmonary: the acute or chronic type based on the presentation, the chronic and the advanced type, which would guide the further treatment. So the acute or chronic, either ways, the initial treatment would be corticosteroids. Whether the add-on therapy should be continued, how long, and how should it be modified, depending on whether the patient falls into the chronic phenotype or the advanced phenotype. So, coming to the final slides, is there an ideal phenotypic classification in sarcoidosis? Unfortunately, so far it is not there. So why has it been difficult? So as I have been discussing so long, there are multiple genes involved. Unlike a single gene disease like cystic fibrosis, even cystic fibrosis has multiple phenotypes, as we all know. And there are several environmental factors which fluctuate and modulate the course of sarcoidosis. More importantly, we currently do not have any specific treatment options, even if we classify them into various subphenotypes. So these are the limitations. Nevertheless, identifying biomarkers and homogeneous groups are essential for future trials. It's an evolving field, and more data and extensive research is required. Thank you.
Thank you very much, Dr. Valiappan. Today, we are all moving towards personalized medicine, and personalized medicine relies heavily on phenotyping. Now, in certain diseases like asthma, phenotypes have benefited us tremendously. In COPD, we have so many phenotypes, limited treatment options, so we don't know what to do with it. But in sarcoidosis, we have always found it difficult to come to terms with the phenotypes and what to do with them. But thank you so much for putting it together and telling us the state of the art. Now, I will move on to the next speaker. We will take the questions right at the end. So, Dr. Valiappan, if you could please stay online till the end of the session when we'll be taking the questions together. So, it's my great pleasure to introduce Dr. B.K. Shastri, who's the Chief of Cardiology Services at the Care Institute of Medical Sciences, where he has worked for the last couple of decades. And he is a true academician. He is an authority on pulmonary artery hypertension and on valvular heart diseases. And of course, he has been my colleague for many, many years in the past. So he will be speaking on pulmonary artery hypertension in sarcoidosis, which is a topic of immense importance. I hand it over to Dr. Shastri at this point.
Good morning, everyone. Thank you, Dr. Ashfaq, for the kind introduction. I thank the organizers for giving me this opportunity. Though I see a lot of patients with pulmonary hypertension, I should say sarcoidosis is very uncommon. Pulmonary hypertension patients coming to me. Probably most of the patients are not so sick as to develop severe pulmonary hypertension. Now, coming to the topic, pulmonary hypertension is defined as mean pulmonary artery pressure more than 20 millimeters. Earlier it used to be 25, now it is changed to 20 millimeters. Depending on where exactly the pulmonary hypertension is generated within the pulmonary vascular tree, it can be classified as pre-capillary pulmonary hypertension, isolated post-capillary pulmonary hypertension, or combined pre- and post-capillary hypertension. If the pulmonary hypertension is generated proximal to the pulmonary capillaries, because of the pulmonary arterial and arterial pathology, it is pre-capillary. Here the mean pulmonary artery pressure is more than 20, vent pressure is less than 15, and PVR is more than 2 wood units. Whereas, when the pulmonary hypertension is generated post-capillary, that is after the capillaries in the venules and the left heart, it's called post-capillary, and the mean pulmonary artery pressure is more than 20. Because of the the venous pressure problems, pulmonary artery bed pressure will be more than 15 and PVR will be less than 2 Wood units. Some patients will have combination of pre and post capillary with mean pulmonary artery pressure more than 20, wedge pressure more than 15 and PVR more than 2. So this group of patients is called combined pre and post capillary pulmonary hypertension. This understanding is important to have a good insight into the pathophysiology of pulmonary hypertension sarcoidosis. Now, based on the etiology, natural history, pathogenesis, response to treatment, WHO has initially classified pulmonary hypertension 1978 into 5 groups. Group 1 is the common idiopathic pulmonary artery hypertension, drug-induced HIV, connective tissue disease, etc. Group 2 is predominantly due to left heart disease. Group 3 is due to lung disease. Group 4 is the obstruction in the pulmonary arteries either due to thrombi or tumors, most commonly thromboembolic pulmonary hypertension group 4. And group 5 is due to miscellaneous causes or unidentified or multifactorial mechanisms. And sarcoidosis does not belong to group 3, it belongs to group 5. As we see, the pathogenesis of pulmonary hypertension in sarcoidosis is multifactorial, more than lung parenchyma alone. And about coming to the incidence of the pulmonary hypertension, SAPH refers to pulmonary sarcoidosis and pulmonary hypertension. This varies from center to center depending on the kind of patients in which it is studied. In all patients attending the clinic, the incidence is low as low as 5%, whereas patients referred for evaluation of dyspnea, it goes up to almost 15 to 70%, and patients being listed for transplantation, it goes to more than 70%. And where we bothered, once the pulmonary hypertension sets in, the mortality, morbidity increase significantly, and 1 year mortality, 3 year mortality, 5 year mortality here, based on the different authors. Here you can see different color codes. 1 year mortality is the 84%, 3 year is about 71, and 5 year mortality is about 58.5%. Now, what are the mechanism of pulmonary hypertension genesis in sarcoidosis? As I mentioned, there can be multiple ways. The vascular disease or interstitial lung disease, and we'll see more. The vascular disease is a pan-vasculitis in these patients in the arterial and arterioles and also venules. This can cause pathogenic pulmonary hypertension. The granulomatous involvement of the vascular involvement, the granulomas being in the lymphatics next to the arteries and veins, the vascular involvement can cause the pulmonary arterial and arteriolar and venular compression. It can behave like veno-occlusive disease because of the same mechanism. And some patients develop thromboembolic phenomena, and that leads to pulmonary embolism as the mechanism for pulmonary hypertension. And coming to parenchymal lung disease due to granuloma and fibrosis is the obvious cause for pulmonary hypertension in the majority of patients. In addition, the lymph nodes in the hilum and mediastinum can cause compression and cause the fibrosic mediastinitis and lead to obstruction of the pulmonary vasculature and sarcoidosis. The extrapulmonary, the most common ventricular systolic and diastolic dysfunction, we know it can cause heart failure and pulmonary hypertension, post-capillary pulmonary hypertension. A good number of these patients have sleep apnea syndrome. Liver is involved in pulmonary hypertension is an uncommon cause of pulmonary hypertension sarcoidosis. That's how the pulmonary hypertension genesis is multifactorial, and that's why it's grouped in 5. And it's important to identify mechanism in each patient. But then careful right heart catheterization is required and treatment is based on that. And when do you suspect pulmonary hypertension in sarcoid patients? If the patient has persistent dyspnea and worsening functional class in spite of anti-inflammatory therapy with steroids and other drugs, if the 6-minute walk distance is less than 300 meters and or there has been a fall in 20% from baseline, a desaturation occurs after the test, NT-proBNP levels are elevated. If there is more than 20% fibrosis on HRCT test, evidence of pH on imaging, increased pulmonary artery diameter will come to it. RV dilatation on CT and RV dysfunction on MRI. If the FVC is less than 60% predicted or DLCO less than 50% predicted or 15% decrease from the previous this one, and FVC to DLCO ratio more than 1.6. And now screening is encouraged to identify patients with sarcoidosis pulmonary hypertension to possibly change the trajectory, because if you diagnose early, possibly, we don't know for sure, but the disease progression may be altered. And when the pulmonary hypertension in the patients listed for transplant, lung transplant, 70% of these patients have pulmonary hypertension. And diagnosis of pulmonary hypertension in sarcoid patients increases the indication for lung transplant. Lung transplantation mortality is not altered by presence of pulmonary hypertension, though there may be increased morbidity. When do you suspect? And the base on imaging, if the pulmonary artery diameter is more than 29 millimeters, it suggests pulmonary hypertension, main pulmonary artery. If the pulmonary artery to ciliary artery diameter is more than 1, either index to the body surface area. Segmental artery to bronchus ratio more than 1:1, 3 or 4 lobes. Evidence of parenchymal disease, PVOD, and pulmonary capillary hemangiomatosis, all these things can be picked up on HRCT and they suggest the possibility of pulmonary hypertension. Now, what are the indications for echocardiography? It boils down to when you suspect pulmonary hypertension in these patients, you go for echocardiographic imaging. The same things are repeated here, like 6-minute walk distance less than 300, fall in 6-minute walk distance, or desaturation, higher NT-proBNP levels, pulmonary fibrosis. All those things will make you suspect and go for pulmonary hypertension. Echocardiography. One word about echocardiography here. People, both cardiologists, echocardiographers, pulmonologists, physicians, everybody goes by TR jet velocity and estimated right ventricular systolic pressure. There is more to echocardiography than looking at the TR jet velocity. These are the echocardiographic signs of pulmonary hypertension. They may be in the ventricles, pulmonary artery, or inferior vena cava and right atrium. The ventricle, right ventricle is dilated, the interventricular septum is flattened, pulmonary arteries are dilated with decreased acceleration time, and inferior vena cava is plethoric with right atrial dilatation. These signs should also be looked at. Now, if the person has got less than 2.8 meters TR jet velocity and none of these signs are present, then the pulmonary hypertension can be ruled out. Whereas, if the patient has got more than 3.5 meters TR jet velocity, then you can safely say pulmonary hypertension is present. But in between 2.8 to 3.5 meters TR jet velocity, one has to look at the other signs of pulmonary hypertension to conclude whether pulmonary hypertension is there or not. This graph is little complex to understand immediately, but this basically says echocardiographic measurements and pulmonary artery catheterization measured pulmonary pressures vary widely. So, right heart catheterization remains a gold standard in the diagnosis of pulmonary hypertension. Echocardiography estimates, whereas right heart catheterization measures. Echocardiography may be accurate, but it's not precise. A precise is repeated measurements will give the same value. Whereas right heart catheterization, you get consistent values. Echocardiography, you may not get it. So there are problems with echocardiography. So echocardiography can be used as screening method, but not necessary to not correct to diagnose pulmonary hypertension. And when you do the right heart catheterization for sarcoid patients, you have to be case by case selection is to be made. It is important because in sarcoidosis there is a left ventricular involvement, there can be the venular involvement, there can be the thromboembolic phenomena, portopulmonary hypertension, etc. So it's very important to make a precise diagnosis of whether it's a pre-capillary, post-capillary, or combined pre and post-capillary. So only these measurements of pulmonary artery wedge pressure (PVR) can be obtained only by echocardiography. The pulmonary artery wedge pressure and PVR can be measured only by right heart catheterization and not by echocardiography. And if there is a problem, sometimes it is there in measuring pulmonary artery wedge pressure. One can look at the LVDP, and in patients where you suspect diastolic dysfunction, one can give fluid challenge. And to decide about pH-specific therapy before transplantation, one has to do the right heart catheterization. And if you find predominant precapillary hypertension and it correlates with the concordant parenchymal disease, you use a pH related to the parenchymal diagnosis, pH related to the parenchymal disease. Suppose the patient has predominant post-capillary pulmonary hypertension and you look at the left heart disease. Suppose the patient has combined pre and post-capillary hypertension. In addition to this one, you have to look at other disorders. You should consider extrinsic compressions of portal hypertension and uncorrected obstructive sleep apnea and thromboembolic pH. The pulmonary hypertension, some of you are familiar, this is a standard picture. Various pathways to treat pulmonary hypertension: endothelial pathway, prostacyclin and nitric oxide pathway. We have got ambrisentan, bosentan and macitentan in endothelial pathway. Treatment available in India also. Prostacyclin pathway, epoprostenol, treprostinil, iloprost not available in India, but Serexpag is available. They involve the prostacyclin pathway. Nitric oxide pathway includes sildenafil, tadalafil and deroxyquat. These are the various drugs used in the treatment of pulmonary hypertension. Now, what have been the studies shown? The studies are small studies, few studies, very surrogate endpoints are there, no standard clinical outcomes are identified or endpoints. Look at the number of patients studied. In the epoprostenol or prostanoid study, 12 patients. In the endocrine receptor antagonist patients, 6 to 23 patients. Only the one double-blind controlled placebo-controlled trial, and the surrogates are hemodynamics and 6-minute walk test. The quality of life is improved in one of the studies. So basically, these studies, these small uncontrolled retrospective observational studies of various kinds, do not give us confidence to give the treatment of the pulmonary vasodilators in our patients without hesitation. They are not of proven efficacy. Similarly, sildenafil, tadalafil, small studies, 12 patients. Hemodynamics improved, 6-minute walk distance, no change. No significant change in 6-minute walk test or quality of life. However, Riosiport is one study, 16 patients, double-blind placebo controlled. To clinical worsening and 6-minute walk test significantly improved, but the numbers do not give us combination. So the retrospective studies also showed that hemodynamics and 6-minute walk test improved in some study when you give combined therapy. It has been shown from that when the patient has got improvement in NT-proBNP with any of these pulmonary vasodilator therapy, probably the patient is getting benefits. Now, what is the algorithm to treat the patients? You give oxygen and diuretics, treat underlying inflammation and sarcoidosis. We give glucocorticoids and antimetabolites, and evaluate for pulmonary artery stenosis and bidirectional compression of the chest imaging. So, if the patient has got pulmonary artery compression, extensive compression, sometimes the stent has been beneficial. If the patient has got thromboembolic pulmonary hypertension, either pulmonary endarterectomy or pulmonary artery stenting has been found to be beneficial. And coming to of course, obstructive sleep apnea has to be treated as per standard treatment. And coming to specific pulmonary vasodilator, consider all treatments case by case basis. Intravenous, benign prostacyclines, endocrine receptor antagonists, PDE5 inhibitors, and Riosiport. If the patient has got response to therapy, that's good. You follow with NT-proBNP or 6-minute walk test and quality of life. Or echocardiography again is not a very satisfactory method to follow the response. It can be done by experts and it has been done diligently. A routine echocardiographic evaluation of the pulmonary artery pressures is not a good means of following response to treatment. If the patient doesn't respond to the anti-inflammatory therapy or pulmonary vasodilators, then look at the FVC. If the FVC is less than 50%, probably lung transplant has to be considered. If the FVC is more than 50% predicted, give combination therapy. If no response, probably one has to go for consider lung transplant. So what is the future? Multi-center trials in defined phenotypes. As I mentioned, pre, post, and combined pre and post capillary pulmonary hypertensions. They have to be identified and with the distinct clinically relevant endpoints there. Hemodynamics is surrogate endpoint. It's not a good endpoint. The good endpoints are time to clinical worsening or mortality or even quality of life is good enough. There should be relevant clinical endpoints should be there, and such kind of multi-center trials are required for future. Thank you.
Thank you very much, Dr. Shastri sir, for your exhaustive talk on this pulmonary arterial hypertension. It's less often recognized, especially in patients with sarcoidosis. You have clearly told us why to suspect pulmonary hypertension in patients with sarcoidosis. If there are any questions, we would be taking these questions and answer at the end of this session. And we will now go with the third talk. I take pleasure in introducing the third speaker for our today's session. He is Dr. Karan Madan. He is an additional professor at All India Institute of Medical Sciences, Pulmonary and Medicine, Critical Care Department. And he has keen interest in rigid bronchoscopy and interventional pulmonology, and he is the first one to have started the rigid bronchoscopy registry in India when he was a fellow at PGIM at Chandigarh. Later on, he went on to become a faculty at All India Institute of Medical Sciences and has been a recipient of Lung India Award in 2014 and 19. And he is currently the assistant editor of the Lung India Journal, which is also the National Journal of the Pulmonologists. And he has numerous publications in international and national journals, more than 250 plus publications in the index journals. And with this brief introduction, I would request the AV team to present his pre-recorded talk. Dr. Karan Madan, start.
A very good morning to all of you. I would like to thank my dear friend Vishwanath for having invited me to speak on this topic. And I will be briefly speaking about how do you establish the diagnosis of pulmonary sarcoidosis. So, sarcoidosis is a multisystem disease, as we all know. The cause is not known, and it is characterized by non-necrotizing granulomas in the tissue samples. We need to exclude our diagnosis before we label the diagnosis of sarcoidosis. And it is a very frequent indication for evaluation of mediastinal lymphadenopathy in India. There is a geographical variability in disease presentation, outcomes, and the prevalence of organ involvement. From Western Hemisphere data, most patients are younger, and there is a female predominance. But from the Indian studies, what we see is that the onset is a little older, usually in the 4th or 5th decade. The gender distribution may be equal, or there's a slight male predominance. The acute presentations of sarcoidosis like Lofgren syndrome are quite uncommon in the Indian setting. The clinical presentation is variable. The type of organ involvement determines the clinical presentation, and the intrathoracic disease is the commonest. Many patients may have an extrathoracic involvement of various sites like the eye, skin, the severe phenotypes like the cardiac or the neurosarcoidosis. And it's important to note that although these involvements are possible, most of the patients do not have an organ-threatening or a life-threatening manifestation, and they respond well to treatment. We recently published our cohort experience of around 327 patients of sarcoidosis from India, and we believe this is an important work because after the advent of the newer diagnostic modalities which have really revolutionized the sarcoidosis diagnosis, this is the only large cohort study from India on this subject as of now. If you see the symptoms, we found that a majority of our cohort patients were symptomatic, and among the symptoms, it were the cough, breathlessness, fatigue, weight loss, and fever, which were the most important symptoms. The other symptoms which were there included, chest pain. Many patients complain of a dull, non-specific chest ache. And if other organ systems are involved, they would have visual or skin changes. Hemoptysis also we found, which is an unusual finding, but it was present in nearly 5% of our patients. We found a significantly higher incidence of extrapulmonary involvement. And the extrapulmonary involvement is important because the more you look for it and you have a specific focus towards finding it, you will get more patients with extrapulmonary disease. So we found nearly half of our patients had some form of an extrapulmonary involvement, and these included the commoner being the extrathoracic lymph node enlargement, eye involvement with various manifestations, skin involvement, splenic involvement, liver involvement, and other organ system involvement may also be present. The staging of pulmonary sarcoidosis chest radiographs is by the classical SCADINS definition, with stages 0 to 4, in which stage 1 is a bilateral hilar enlargement alone, and stage 2 with a concurrent lung involvement. Stage 3 disease meaning where you have only lung infiltrates without a hilar enlargement. What we observed was that a majority of our patients were in the stage 1 or a stage 2 disease. The CT thorax usually shows a homogeneous or a multi-station lymph node involvement, and CT is also useful, but it can allow you to see the extent of pulmonary fibrosis and a non-invasive assessment of pulmonary artery hypertension also. Once the lung parenchyma is involved, it is usually characterized by a perilymphatic involvement, wherein you see peribronchovascular or fistral nodules, which are in the subpleural and the interlocular predominant locations. In our cohort, there was a prevalence of mediastinal lymph node enlargement on CT scans. We also observed a non-homogeneous lymph node appearance in nearly 6% of our patients, and lung parenchymal involvement was seen in 70% of our cohort. If you come to establishing a definitive diagnosis, it usually requires the integration of clinical, radiological, and pathological findings. the bronchoscopic approaches are the cornerstone to the diagnosis in a majority of patients. The other accessible sites which may be biopsied include the skin, the peripheral lymph node or the conjunctiva, and infrequently liver, pleura, and intra-abdominal lymph nodes may also be involved. The recent guidelines from the ATS, they indicate that lymph node biopsy may be avoided in patients with a typical finding or presentation of sarcoidosis. Now, it's important to note that these patients are from a very low TB prevalence setting. In the TB prevalence settings, I would not entirely agree to not proceeding with the biopsy because there is a close overlap between tuberculosis and sarcoidosis in our setting. In our unpublished experience of more than 100 patients of mediastinal TB, we found that many of them may have non-necrotizing granulomas on a tissue sample, and also the CT findings of homogeneous lymph nodes may also may be present in TB. So I think there's an overlap. More data on this needs to be generated. That is why if you don't take a route of performing a biopsy, the patients must be kept under a close clinical observation and follow-up. But I would prefer proceeding with the biopsy investigation in nearly all your patients. In our cohort, we found that nearly 90% were tuberculin negative. A small fraction of patients may have tuberculin reactivity. Serum ACE levels are not diagnostic in isolation. An elevated ACE may support your diagnosis, but a normal serum angiotensin converting enzyme level does not exclude the diagnosis of sarcoidosis. Regarding these spirometric findings, many patients may have airway involvement, symptoms like wheezing, or obstructive pattern on spirometry. But in previous studies, we feel that there is an overestimate of obstructive defect. This may be, a referral bias or more severe patients being diagnosed or included in the cohorts. But we found a fairly low prevalence of obstructive defect on spirometry, and obstructive defect is not common. Mostly patients would have either a normal or a restrictive pattern. So now coming to how do you get the samples in patients with pulmonary sarcoid or intrathoracic involvement. So these may be divided mostly into the bronchoscopic approaches, which may be lymph node aspiration modalities, a lung biopsy modalities, or a bronchoalveolar lavage. Among the lymph node aspiration modalities, what you have is a conventional transbronchial needle aspiration and the endobronchial ultrasound or an endoscopic ultrasound guided modalities, which allow you to sample the mediastinal lymph nodes. So we'll discuss them one by one. So on the left, the cartoon shows you a conventional transbronchial needle aspiration, wherein using a routine fiber optic or a video bronchoscope, using a conventional 19 gauge or a 21 gauge needle, a puncture is made on the sites of anatomical where you anatomically know the lymph nodes are located. So in this case, you see this is a puncture being made from subcarinal lymph node. So usually subcarinal and the right paratracheal lymph nodes are amenable to a conventional TBNA. This modality had been in use till the advent of EBUS, but now with the advent of EBUS TBNA, this is fallen out of favor. The yield of conventional TBNA is variable, and in isolation, it may have a varying yield from 6% to I think up to 60 to 70%. So now mostly the diagnosis is centered on EBUS centered or an endobronchial ultrasound centered approach. The right cartoon shows you what EBUS means. This means the use of a dedicated bronchoscope, which has an ultrasound transducer at its tip, and it can allow real-time needle aspiration of mediastinal lymph nodes. The conventional approach is to use this EBUS scope through the trachea, but in certain instances, you can also use an esophageal approach using the same ultrasound bronchoscope. So this modality, once you put the EBUS scope through the esophagus to sample nodes, is called as EUS-BFNA. And this is somewhat like the gastroenterologist approach, what they use, but the gastroenterologists use a larger EUS-FNA scope. So essentially meaning that you target the mediastinal lymph nodes using the tracheal or the esophageal approach to get the tissue diagnosis. Then there are lung or bronchial biopsy modalities. Before the advent of endosonography, the bronchoscopic diagnosis was predominantly centered on these conventional modalities. And these include, if you see the cartoon on the left side, shows you an endobronchial biopsy, wherein you take a mucosal bite from the bronchial divisions or sites of endobronchial granularity. And on the right, which you see is actually once you pass your forceps beyond bronchoscopic visualization and you try to take an alveolar sample or a lung biopsy sample, that is called a transbronchial lung biopsy. It is important to note that these are important because even if you see a normal lung parenchyma, the lung biopsy or a TBLB may show you granulomas in patients with sarcoidosis. However, doing a transbronchial lung biopsy has its own issues. It's a relatively safe modality, but does carry a risk of pneumothorax and bleeding. So what do you do during a bronchoscopic approach? Say your patient has both lymph nodes, it has lung parenchymal involvement. So recent evidence supports that you should use a combination of lymph node aspiration along with endobronchial and transbronchial biopsy to optimize the diagnostic yield. So we have these two major papers. One was published in Chest a few years back, and one was from our center, in which we demonstrated that if you do all the three procedures, including a lymph node along with a lung and a mucosal biopsy, it optimizes the diagnostic yield. In case you have a rapid on-site evaluation, a cytopathologist is available with you. At the time you're doing a lymph node aspirate, if you see characteristic non-necrotizing granulomas, the endobronchial biopsy or a TBLB may be avoidable in many patients. But strong data to avoid support this practice is not there and is required. Regarding the BAL CD4 CD8 lymphocyte ratio, it may support a diagnosis, but in the Indian setting, to my knowledge, this is seldom performed, and its utility in TB endemic settings has not been studied in detail. A newer biopsy modality from the lung is a lung cryobiopsy, but its utility in the diagnostic algorithm of sarcoidosis is unclear. So what we've observed is that the diagnostic yield of EBUS or EUS may be up to 80%, and the yield of transbronchial biopsy is nearly 50%. One important thing to note is that you may get necrotizing granulomatous inflammation in sarcoidosis also. In TB endemic settings, in presence of other findings supportive of TB, these patients are usually treated as tuberculosis. But an isolated prevalence of necrotizing granulomas with the presence of all other characteristic features of sarcoid, this is a decision in which you need to integrate all the clinical, radiological, and pathological findings and proceed with the management. So I'd like to conclude my talk here. Sarcoidosis is a very common cause of mediastinal lymphadenopathy in TB endemic countries also. The clinical presentation is varied. Many patients may be asymptomatic. A diagnosis requires a careful interpretation of your clinical, radiological, and tissue biopsy findings. One should make an aggressive effort to approach biopsy diagnosis in TB endemic settings because surprises are not infrequent, and you might get a tuberculosis diagnosis, even microbial data in which you are thinking a patient is characteristic sarcoid. So due to this close differential diagnosis of mediastinal TB, I think a close integration of all the findings are important. Thank you very much.
So, thank you, Dr. Karan, for a wonderful talk. I request you to please stay online because there are going to be some very, very interesting questions at the end of the session, especially for your talk. Now, for a talk that I have personally been looking forward to since yesterday, I would like to introduce Dr. Raghav Rao, who is consultant pulmonologist right here at the AIG. And he has been doing focused work not only on ILD but also with the rigid bronchoscope. So he will be talking on the current treatment landscape in sarcoidosis, which we all have been looking forward to. Dr. Raghav.
A very good morning. I would like to really thank you all for giving me this opportunity. Topic for me would basically be the treatment landscape of pulmonary sarcoidosis. Landscape is basically what we are aware of, what our eyes are really seeing, and within the limit of our horizon. The same thing when we apply to the treatment modality with sarcoidosis, probably I feel what we know is very limited at the tip of iceberg. Treatment for sarcoidosis again has been very debated since the beginning of its discovery way back in 1860s. The indications for treating with glucocorticoids, when to start them, the duration to continue them, monitor, and we really do not even know if they alter the treatment course. Presentation is again very variable, which has already been described by my previous speakers here. So the indications to treat glucocorticoids is a basically trade-off between what we are trying to minimize, a disability or mortality from sarcoidosis, and impairment in quality of life associated with sarcoidosis, to the side effects which we might encounter on treating with glucocorticoids. Morbidities and disability of quality of life may sometimes be much more than what actually sarcoidosis is doing to a patient. So there's a very thin line where we need to really understand the indications for treating sarcoidosis. Again, this has been just spoken about, the scattering staging, wherein we are able to appreciate like there's a significant spontaneous resolution in group stage 1 and stage 2 compared to stage 3 and stage 4. Again, this was a very important paper probably published way back in 96, wherein individuals who have been incidentally detected to have sarcoidosis on chest radiograph were observed again at 6 months later period, and at 6 months those who were still having persistent radiographic abnormalities have been divided into 2 groups: those who have been treated with glucocorticoids and those who have just been treated as and when needed. And here what we can actually notice is at a follow-up of 5 years, there was only 5% improvement in vital capacity in those people who were actually treated with glucocorticoids. And this was at the expense of these patients having significant side effects in almost 2/3. This was another prospective trial of around 215 patients of recent onset sarcoidosis, wherein the glucocorticoid therapy within first 6 months, who received glucocorticoid therapy in first 6 months, and they were followed up for 2 years. If you really notice, those who were not initially on treatment with glucocorticoids, only 8% of them were actually needing treatment at the end of 2 years, compared to those who were initially on systemic therapy, nearly 47% of them were needing treatment. So these probably the pitfall of this, wherein people argue, is like those who were on systemic therapy were those who probably are in the high risk group and needed treatment and ended up needing treatment. The other side of argument is something to state like these steroids would basically impair the body's innate immunity to fight the putative antigen. So to put into things, pulmonary sarcoidosis, we need to divide them into, understand them. There are certain group of individuals who really don't need treatment with steroids, certain people who are into high risk who need treatment with steroids to prevent end organ damage, to prevent the quality of life being impaired. Now, the issue with this classification is basically we need to identify who these high risk group are. This high risk group have been extrapolated from the large cohort studies which we have from the Great Britain, United States, and the French cohorts, wherein reduced lung function, people with severe pulmonary fibrosis and precapillary pulmonary hypertension have been shown to have increased mortality. And objectively, these were assessed by composite physiological index of being more than 40 or HRCT thorax, wherein fibrosis was shown to be more than 20%, or a precapillary pulmonary hypertension. These had an independent odds risk of mortality of nearly 3 to 4%. So people with we definitely need to initiate treatment with glucocorticoids, and low risk group, they can just be observed or advised symptomatic treatment. Then we need to also have a strong line between understanding what this intermediate risk is from high risk. Intermediate risk is basically more patient oriented, wherein we need to understand the quality of life patient has, dyspnea, chest pain, cough, muscle malaise or fatigue which the patient is experiencing, leading to loss of quality of life. Here again, the guidelines are not really very clear. We need to sit with the patient and understand and explain to him and take a combined decision if we are really treating them. So indication to start glucocorticoids is basically two-pronged: to have a relief in symptoms and also prevent potentially disabling respiratory impairment, even if they are not going to completely cure the disease. So once we start to initiate the treatment, next big question is the dose of glucocorticoids we use for pulmonary sarcoidosis. The dose has been traditionally described to vary from 10 to 80 mg, 1 mg per kg body weight. But of late, we are all aware probably like 20 to 40 mg of prednisolone equivalent dose is quite sufficient to treat. But still, we do come across people being treated with high and higher doses. These are basically expert opinions and case reports, or sometimes symptom guided, or organ involvement like other extrapulmonary organs when they are involved, ocular, renal, or cardiac, wherein higher dose of steroids may be used. So once the decision to start steroids is initiated, the next question is how long to continue, how to taper them. Tapering, basically once we initiate, we need to continue these glucocorticoids for at least 4 to 6 weeks and then reassess clinically and infer if the patient has stabilized, if not improved, and if he is at least stabilized, we would like to continue it and taper slowly and then again there are different protocols within of the tapering doses, like 5 mg every 4 weeks or 5 mg 2 weeks, and we try to reach the least possible dose of around 10 mg of equivalent prednisolone dose. If there is no improvement at 4 to 6 weeks after initiation of glucocorticoids, we just try to continue them for another 4 to 6 weeks before trying to escalate therapy. Maintenance dose which we try to attain is basically 10 milligrams of prednisolone for at least 3 months before saying a person is really not responding to glucocorticoids. And in this process of tapering, if we encounter relapses, we try to go back to the previous most effective dose and continue for 4 to 6 weeks and then again reattempt tapering. The duration of therapy, once we try to taper, is the least effective duration has been shown to be 3 to 6 months. Again, shorter duration of glucocorticoid therapy, we may encounter people having frequent relapses. Relapses do range from the range of 14 to 75% in 5 years of treating. People do end up having recurrent relapses, and then maybe we need to just move on to second line agents. And labeling a person refractory to glucocorticoids is, again, we need to understand it can be because of progression of disease, which is again an equivalent dose of prednisolone to 10 mg for 3 months. More often, we also encounter people who are really not able to tolerate the side effects because of glucocorticoids, or the need for us to use glucocorticoid sparing agents, as we are just not able to go down to a lower dose of glucocorticoids with the side effects the patient experiences. So before labeling, we also need to understand that patients who are refractory to glucocorticoids are actually compliant with the treatment. Very often do we encounter that patients are very reluctant to take these, and glucocorticoids may not help us really when a person really has an end-stage fibrosis. To discriminate an end-stage fibrosis from active pulmonary involvement in sarcoidosis might be quite difficult, and here probably the role of PET in pulmonary sarcoidosis would come up in future. For patients with refractory glucocorticoids, the agents which are generally looked upon to are methotrexate, azathioprine, leflunomide, TNF antagonists, and other less commonly used ones are mycophenolate, cyclophosphamide, rituximab, JAK kinase inhibitors, and corticotropin repositories. The highest experience with steroid sparing agents has been with methotrexate for pulmonary sarcoidosis. The initial dose which we try to use is probably 7.5 to 10 mg a week along with folic acid, and gradually try to escalate it to reach a dose of 15 mg or 20 mg if the patient is tolerating it. The tolerability, again, we need to understand we can't use methotrexate and leflunomide in people who are having advanced renal failure. So the side effects are limited by nausea, hepatotoxicity for methotrexate and leflunomide. The next most common used agent is azathioprine as a steroid sparing agent, and least experience that we have is with mycophenolate in sarcoidosis. And methotrexate efficacy in people who are actually progressing with glucocorticoids has been shown to be 40 to 60%. The utility of methotrexate is basically it would help us to taper the dose of glucocorticoids, and of course few studies have been shown wherein like FEV1 vital capacity have improved. The DLCO improving by 1.2% really doesn't make a clinical point for us. And when we try to use these steroid sparing agents, we often encounter people having higher infections. Upfront combination therapy again has been very limited. There's only one study wherein people use methotrexate and leflunomide in an open label study with pulmonary and ocular sarcoidosis. It was probably tolerated and was quite effective. So when we are able to use methotrexate, and if somebody is really not able to respond to methotrexate, the next agents which we often use are TNF antagonists. Infliximab is much more commonly used than adalimumab. Influximab, we have 2 double-blind placebo-controlled trials, the largest with 138 patients, wherein a placebo was compared to infliximab dose of 3 mg per kg to 5 mg per kg and assessed at 24 weeks and 52 weeks. Mean increase in FVC was just 3% again. And if you actually notice the graph, the most benefited patients here again were those who are having severe disease, as we can appreciate with a lower FVC or a higher SGRQ score, and those who have been diagnosed in early stage of a disease. Again, there have been data wherein people have showed like infliximab might be more effective when people have peripheral leukopenia. The role of other agents in treating sarcoidosis, the role of antifibrotics is an extrapolation from inbuilt trial, wherein there was only 10% of the people who were actually having sarcoidosis. Ultimately, if they really don't respond, final option would be a lung transplant. The topic of pulmonary hypertension we have just gone through by Dr. Shastri sir. Again, I would just like to reiterate here that all the treatment outcomes are limited by very small number of patients which we have, and patient-oriented outcomes are quite small. The only one, as pointed out, was from the Riociguat trial, wherein time to clinical worsening was not there in those who received Riociguat. 6-minute walk distance was significantly better in only one patient in that trial. So in a nutshell, to understand the treatment of pulmonary sarcoidosis, we need to basically group them into low risk, intermediate risk, and high risk. Low risk, we may just observe and initiate the need of treatment when need as it happens. In high risk group, we go about with glucocorticoids upfront and then reassess them. If they have a good clinical response, we can just come down on the dose of glucocorticoids. If they're not responding or we're not able to come down on the dose of glucocorticoids, we move on to second line agents with methotrexate. Again, try to taper the glucocorticoid dose. These intermediate risk group, they need a combined decision with the patient, understanding quality of life and treatment outcomes. Further, when people really do not respond to methotrexate, we try to treat them with infliximab. Other agents which have been studied are basically rituximab, JAK kinase inhibitors, and corticotropin repositories. So at the end of this treatment landscape, what we clearly can say is not everyone needs a glucocorticoid therapy. Early initiation may lead to relapses. Second line agents are effective in 40 to 60%. And we do find benefit probably with third line agent biologics, TNF antagonists, and sarcoid-associated pulmonary hypertension is multifactorial. What we can probably come to a consensus with expert opinion for retrospective trials is glucocorticoids dose of 20 to 40 mg to begin with, tapering them, and need to assess steroid sparing agents and maintenance therapy. What we still don't have an answer is probably to you when we need to consider an upfront therapy in pulmonary sarcoidosis, role of other agents like rituximab, JAK kinase inhibitors, role of antifibrotics in sarcoidosis, and endpoints. All of the endpoints which we need to really treat for should be patient-oriented endpoints, and role of PET to understand if this pulmonary sarcoidosis is an active or an end-stage fibrosis. Yeah, thank you.
Thank you very much, Raghav. Actually, this has created a lot of interest, and there will be obviously so many questions at the end of it. And I know most of your talk is focused on the pulmonary sarcoidosis, and all the audience should note that the treatment indications would also depend upon the other concomitant organ involvement, so which we would be taking in the discussion during the discussion. We would be going up with the interesting case discussions. I would request Dr. Sujay to be online. Dr. Sujay is from the team of Pulmonary Medicine Department at All India Institute of Medical Sciences. He has two interesting cases, and then later in this session I would be presenting one case of interesting sarcoidosis case. Can I request the AV team to present the just small? Shall we go ahead with the questions for this? Okay, so then there's a small request actually from the faculty side as well actually. So we would take up the questions upfront now and then go with the interesting case discussions later after the Q&A sessions. So to open the session for the Q&A, I would like to start with a couple of comments actually regarding one is the comment on Dr. Karan's talk actually. So Dr. Karan has mentioned in his talk that if transbronchial lung biopsy, especially in the pulmonary sarcoidosis, if the presentation of sarcoidosis, if transbronchial lung biopsy and endobronchial biopsy are added to the EBUS or the EUS guided TBNA from the lymph node, it will lead to an additional diagnostic yield of 25 to 30%. There are often people who would say they have done an EBUS or an EUS guided FNAC from the lymph nodes and it came negative. So please remember that if you add at the same setting, if you would add transbronchial lung biopsy, that would add to an additional diagnostic yield. That is one thing. And he has made an important point about necrotizing sarcoid granulomas. That is one thing which you need to keep in mind. But the most important thing is most often we would end up starting these patients on treatment and then clinically follow them. They are not responding, then would start them on steroids if the patient is not improving. And regarding the comment on Dr. Raghav's talk is, so much of his talk is dependent on the evidence from the pulmonary sarcoidosis trials actually. As there has been a lot of debate on adding an upfront steroid sparing agent when you diagnose a patient. So in pulmonary sarcoidosis, generally the response to treatment is very good. And then we would be able to stay with steroids in most patients actually. Dr. Raghav's talk has clearly shown that in whichever patient there was an early steroid usage, the relapses were more common. So, but however, if there is a concomitant other organ involvement like a renal sarcoidosis, neurological sarcoidosis, cardiac sarcoidosis, in these patients we know that obviously the duration of the treatment would be much greater, and it would be prudent to add an upfront steroid sparing agent from the beginning. And there would be a lot of I think comments on this from the senior faculty here. And with this, I would like to ask Dr. Ashwak Hasan also to give his comments on these three talks.
Yeah, that's exactly something that I was also wondering about, because today it has been the practice across all specialties to be proactive with the second agent. And obviously it has two benefits, or rather three benefits. First of all, it kind of straight away enables us to reduce the steroid dose, reduce the side effect potential. Secondly, it introduces a fresh angle from which the treatment can be approached. And obviously, you have kind of a lot of data from other conditions in which the other agents have been used, non-steroid agents have been used. So that is actually very, very important, and I think Vishwanath has rightly raised the point. The second thing, of course, is how to choose between, let us say, MMF and methotrexate. Apart from the side effect profile, where you avoid certain drugs and certain comorbids like renal or whatever it is, how would you anticipate that this condition responds better to one or the other? So that's another thing that we could start. So we could start the questions from the floor at this point of time. And then we could, if you have any questions, first for the pulmonary phenotypes of sarcoidosis, we could go talk by talk.
Dr. Valliyappan, are you online? Dr. B.K. Shastri, sir. Sir, you are muted, sir. Shastri, sir.
So, any questions for Dr. Shastri on pulmonary artery hypertension in sarcoidosis?
Dr. Madhuri has a question.
Good morning, sir. I'm Dr. Madhuri, rheumatologist here at AIG. So, while we have discussed about the role of immunosuppression in the pulmonary management, and you have spoken about the role of all the known agents like the nitric oxide and the bosentan and all that, what would you say is the role of immunosuppression, say cyclophosphamide or methylphenidate or any other agent in the management of pulmonary hypertension, specifically in sarcoidosis, though I know the caseload is low.
Shastri, sir, you are muted, sir. Actually, you are not audible. Can you unmute yourself?
I am unmuted now.
Yeah, now we can hear you.
Okay, sorry about it. I don't know. Fine. The question is about the immunosuppressive therapy as for pulmonary hypertension. See, as I mentioned, pulmonary hypertension, the most important cause is the granuloma and inflammation, perivascular inflammation, vasculitis, and granuloma encasing the vessels. So, and also pulmonary parenchyma. So, there is a role for anti-inflammatory therapy, whether steroids or methotrexate or MMF, whatever. So, that is the and in additionally, pulmonary vasculitis we give to these patients when the pulmonary hypertension develops.
I have a follow-up question. How would you monitor the response to therapy in these patients?
The best way is look at NT-proBNP. There is a paper from Cleveland which said that the patients who benefit from NT-proBNP, they show the clinical response in terms of the quality of life or morbidity mortality. So if you start these patients, have a baseline NT-proBNP and see, and if you are looking at the echocardiography, just don't go by RV systolic function. Look at the RV function parameters like eccentricity index, like the TAPC, TAPC, then TAPC by acceleration time ratio, so on and so forth. So these are the two important measures. Of course, 6-minute walk test and clinical function class, requirement for oxygen, all these are equally important.
Woodman's ProBNP is a 6-minute walk test and the clinical parameters.
I have two comments rather than questions. When pulmonologists treat patients with sarcoidosis, if the ECG is abnormal, please get a cardiac. The simple thing is what you pass off as a right bundle branch block. It has a 8-fold higher incidence of death over the next decade in these patients. So vesicular blocks and bundle branch blocks, what is relatively benign, may be the only indication that there is a cardiac involvement. Now, clinical cardiac involvement is less than 5%, but postmortem indicates the involvement is close to 30%, 25 to 30%. So a simple screening tool would be a bedside ECG and echo. And if these things are abnormal, I would suggest you get it. The second is more of a question. What is the sensitivity of using gallium as an isotope in terms of picking? Because you need a very high resolution to pick up lung inflammation in contrast to cardiac inflammation. So, has there been any studies comparing?
So actually, yesterday we were discussing the same thing with our nuclear medicine HOD, Dr. Sunita actually. I think now a lot of people are moving towards gallium PET from the FDG PET because FDG PET, because the myocardium has a very high uptake of glucose actually. In all the patients, there would be myocardial uptake which is present on the FDG. So to really see whether this is cardiac inflammation which is going on or not, you give a high fat diet for 2 days and then do the PET CT scan actually. However, that is not practical in most patients. But whereas this gallium does not have this problem, actually, you can do upfront gallium PET CT scan in most patients with sarcoidosis. The cost would be somewhere around 30,000. So I think the studies are also there. Good evidence is there, which has got in ahead with almost the equal efficacy like the FDG PET, gallium PET.
No, I was not referring to cardiac. Suppose you do a gallium and there is a pulmonary arterial uptake. Do you see pulmonary arterial uptake? Do you see a parenchymal uptake in the? I don't know. Does it indicate that you need to start immunosuppression early on rather than pulmonary vasodilators? The question that Dr. Madhuri was asking, when there's an active inflammation, can you pick it up? Because you don't have any biomarkers. Can you pick it up by imaging?
So I think the Raghav, you can also take this actually. It would also work on the same principle like FDG PET. So if there is an increased metabolic activity, obviously in the gallium also, I think there should be increased uptake.
Recently, there have been at least 4 or 5 studies wherein PET has been shown to be better, wherein we can assess if the pulmonary involvement is actually end-stage fibrosis or an active pulmonary involvement. Coming to vascular uptake, I really not aware of it, but for pulmonary sarcoidosis, PET has a sensitivity of around 70 to 80% that I came across.
So FDG versus gallium also, I think that is one of
Gallium, I'm not aware.
Yeah, Vishwanath, once I discussed with nuclear medicine people, they said PET is more sensitive than gallium. And at least in one patient, we could pick up pulmonary vascular uptake. But one patient doesn't make any sense. I mean, you have to do a series of cases to look at the vascular.
Yes, sir. Now they have combined gallium and PET together. They are doing gallium PET actually. That's
When I
what
said FDG PET, when I said PET,
FDG PET and the gallium PET actually. That's what.
combined, probably. Maybe better. I know.
Yes.
Any questions from the floors?
Now, taking Narasimhan's point further, it is not only RBBB, even a splintered QRS, small potentials outside the QRS complex. So many non-specific findings can be there. So I think it is just, if you think anything is abnormal, probably you should take a cardiologist consultation and further evaluation of the cardiac.
Yes. The pertinent point.
I'm Dr. Sharachandra Malik from KIMS. I completely agree with Dr. Hassan regarding upfront disease modifying drugs, because sarcoid is basically a systemic disease. So what I have observed is whenever we use upfront DMARDs along with steroids, they quickly go into remission. Probably after 6 months, you can venture to stop the steroid altogether. And the relapse rate is very, very minimal. And also, I request to the floor is because the systemic disease, whenever you say sarcoid, always use the facility from the in-house rheumatology. So basically, as we all know, it needs a good teamwork, and we can achieve good results with that. I request you.
Sir, how long would you continue the steroid sparing agent generally in your practice?
What I do is usually, nowadays for any autoimmune disease, we don't use 1 milligram per kg. So I use 0.3 to 0.5 milligrams per kg steroid along with upfront. Most commonly, I use methotrexate for sarcoid. First month, I use 0.3 to 0.5 milligrams. Second month onwards, I quickly taper because I'm afraid of steroid-related side effects. And in the third month, probably between 5 to 10 milligrams. At the end of third month, probably 5 milligrams. I continue for the next 6 months. If I'm very comfortable that patient is in remission, probably I would stop the steroid altogether and continue to use oral DMARD for 2 to 3 years. Then I think about stopping the DMARDs.
So thank you very much, sir.
Thank you, sir.
One very, very last question, which I myself, is Dr. Karan online, please?
No, I think he must be traveling. He's there.
Oh, okay, that's fine. So I'll just put it across instead to Dr. Raghav, if we can, because I think we touched upon this briefly yesterday. There is a patient in which the diagnosis is not clear. There is lymphadenopathy, and let us say we've done the sampling of the lymph node, and along with some non-caseating or minimally caseating granulomata, we have also discovered mycobacterial DNA. I mean, how would we go about it? Would you automatically presume it is tuberculosis, or would you presume that the sarcoidosis is a sequel of a inactive tuberculosis in the past? Just I know nobody has the answers, but you've done the research.
Probably we spoke about it yesterday. Probably I would take into consideration how the a patient would present to a clinic also. Keep them under close observation. Generally, as the classical teaching, we were taught a tuberculosis patient is more febrile, is more sick as compared to a sarcoidosis patient. Keeping a holistic thing, I would generally approach treating them. Considering again, I might go about treating them with sarcoidosis or steroids upfront if they really indicate it. If a patient is able to follow up, maybe we can just keep them under close follow-up and see if it's actually tuberculosis or something. Probably it's an eternal fight, I think.
Thank you.
And one more question. I would just like to know, sir, I couldn't find any real data to use upfront DMARDs for pulmonary sarcoid.
If you ask any rheumatologist, I don't know about the publications. If you know any rheumatologist, all the rheumatologists, we always use upfront DMARDs and excellent results. We always do that. Yeah, there's actually two things in my mind. Publish this and also come up with the guidelines. Probably I have 70 plus sarcoids in my department. Probably one mortality. That's what we're going to present here because it's a late presentation. This afternoon. All of them are doing quite well. So probably we can present our Indian series on sarcoid and come up with the guidelines. The guidelines should, the current guidelines says DMARD should be the second line, but I would say it should be the first line. Then only patients do well, and then we feel happy about that.
Yeah, for the sake of the audience, I would to put it the area of upfront is the significant experience of the senior colleagues. Actually, we need more data on this, and probably this is where we can initiate and study actually. And we would go to the next session, next topic in this session, that is the interesting case presentations. And I would request the AB team to project the first case. Dr. Sujay.
Hi, yes, I'm here.
Yeah.
Shall I share my screen?
So I think they will be project. Since you haven't pre-recorded session available as well, I will request. Can you play the Dr. PPT?
Okay.
Sir, he's going. Sujay, go ahead and share the screen.
Yeah, okay, I'll just share the screen. I just modified the presentation. Is my screen visible to everyone?
Yeah, it's visible and you're audible. Thank you.
Good morning, everyone. I'm Sujay. I'm a senior resident in the Department of Pulmonary Medicine at AIMS New Delhi, and I'll be presenting one case for today's clinical discussion. So, the case is a 35-year-old male resident of comorbidities. He presented to a private practitioner in August 2017 with complaints of fever for 1 month, which was low grade with evening rise. There was cough with scant greenish expectoration for 1 month, loss of appetite, loss of weight of around 2 kilograms for 1 month, and MMRC grade 1 dyspnea. Recent investigations conducted showed that the CBC was essentially normal. At this time, the sputum AFB, bacterial culture, and gene expert were negative. MANTO was negative, and serum ACE was 35, which was within the upper limit of normal for that lab. They did a chest X-ray, where we can see bilateral hilar prominence and also some right patracheal prominence in the chest X-ray. Following this, they did a CT scan. In the CT scan, we can see mediastinal lymphadenopathy that is quite prevalent, and some of these nodes also show some amount of heterogeneity where there might be some necrosis. Continuing with the mediastinal window, we can see that the right hilar node is quite hypodense, and there's also causing some compression and collapse of the underlying lung. Looking at the lung window at this time, apart from the collapse, the lung window was not really remarkable for any special characteristics. So at this time, considering the necrotizing mediastinal lymphadenopathy, the patient was started on empirical ATT on clinical radiological basis. And despite receiving 1 month of therapy, there was persistence of fever, loss of weight of around 2 kilograms. So he consulted another practitioner and he underwent an EBUS there. So the EBUS at the second practitioner, basically they had done a EBUS TBNA, where the AFB, gene expert, and the MJET cultures were negative. The cytology at this time was inconclusive, and the biopsy showed epithelioid cell granuloma with no caseous necrosis in the subcarinal node and focal necrosis in the paratracheal node. They had also done a BAL. The BAL, AFB, gene expert, the MJET bacterial and fungal cultures at this time were negative, and the cytology was inconclusive. The CD4 to CD8 ratio in BAL was raised beyond the upper limit. A transbronchial lung biopsy at this time showed ill-defined epithelioid cell granuloma without caseous necrosis, and an endobronchial lung biopsy, there was no granuloma seen at this time. So, considering the mediastinal necrotic lymphadenopathy, the ATT was continued, and he was given a full course of about 8 months from August 2017 to March 2018. Because he also found, there were also some epithelioid cell granulomas on the transbronchial lung biopsy with essentially normal lung parenchyma on the lung window. With a suspicion of coexistent sarcoid, he was started on prednisolone as well from October 2017, and this was continued till about February 2018. And at this time, the steroids were tapered, and by the time he had come to February 2018, he was receiving about 5 milligrams of prednisolone. So this was the initial chest X-ray that we just saw showing the lymphadenopathy, and this is the follow-up scan in February 2018, which showed that there is some resolution or some reduction in the size at least. Following this, by March 2018, the patient's ATT had been stopped, and after the steroids had been tapered, the steroids were stopped as well. And then he presented to us in July 2018 with low-grade fever for 2 months, dry cough for 2 months, and again weight loss of about 5 kilograms for 2 months. He had already had some repeat imaging that was done, and this was done in June 2018. At this time, the chest X-ray showed a new pleural effusion on the right side, and as we can see, the mediastinal window on the right, we can see that the nodes, there was some reduction in the size of the node, but there was this new right-sided pleural effusion. Coming to the, continuing with the mediastinal window, we can see that the hilar node that was initially there is also reduced, but this persistence of this right new effusion that is there. And now the lung window is showing some perilymphatic nodules as well, on only on the right side, that is unilaterally. So looking at the investigations, we actually did an ultrasound and we found a gross right side pleural effusion, which we had tapped. And this tap was lymphocytic. The ADA was 31 with a high protein of 5.6, and the gene expert from this fluid was negative. So we had a clinical dilemma. Basically, we had a 35-year-old male who presented with mediastinal lymphadenopathy, who underwent EBUS showing an epithelioid cell granuloma. He received ATT and steroids for about 6 months, and with initial clinical improvement, and now he presented with pleural effusion. So our possibilities were tuberculosis, sarcoidosis, and very lower down we had lymphoma. So for TB, we had necrotizing granulomatous inflammation and the presence of a pleural effusion, which is more common in tuberculosis. But on the other hand, we had no microbiological evidence till now, and no significant radiological improvement despite a full course of ATT. For sarcoidosis, there was a response to steroids, although ATT was going on at the same time. And now there is this new parenchymal involvement with perilymphatic nodules, although it is unilateral, which is quite uncommon. And as a con, we have the rarity of pleural effusion in sarcoidosis and radiological worsening despite steroids, although it must be kept in mind that the steroids were tapered at this point of time and later stopped as well. Lymphoma, actually for lymphoma, we have a lymphadenopathy and pleural effusion, but we did not have any evidence of any atypical cells, or even the cytology was negative so far. So we went ahead with further laboratory investigation. The serum ACE was 30, which was within the normal limit of our lab. Was not elevated. The ECG at this time was normal. Skin examination did not show any skin lesions, and ophthalmological evaluation did not show any evidence of uveitis or tuberculomas. The HIV was non-reactive. So we did an EBUS TBNA in July 2018, and we took 3 passes from the subcarinal node and 3 passes from the right interlobar lymph node. And at this time, the stain for AFB is negative, and the lymph node aspirate for gene expert was also negative. So following this, we actually, to diagnose the pleural effusion, we did a semi-rigid thoracoscopy, where we can see that the pleura was actually lined with these nodular whitish plaque-like lesions, and we took multiple biopsies from the same. And even from this biopsy in the pleura, the gene expert was negative. So this is just us taking the forceps biopsy in the pleura. So following this, we did a histopathology, and the histopathology actually showed epithelioid cell granulomas from the pleural biopsy. And following this, an AFP stain of the pleural biopsy was also negative. So we landed up with the final diagnosis of sarcoidosis with pleural, pulmonary, and lymph node involvement. We started the patient on steroids again, prednisolone 40 milligrams from September 2018, again tapered over 6 months and stopped after 1 year. The patient symptomatically improved. He had no constitutional symptoms. He had initial weight gain with improved appetite, and his serum AS levels had also come down to 6. So September 2018, we did a repeat chest X-ray, which now shows the complete resolution of this right pleural effusion. and the nodes have completely disappeared. And the ultrasound also shows that there is no evidence of pleural effusion in this case. So having discussed this case, I just want to put forward some points for discussion. I think Karan sir would have already spoken about this regarding the importance we place on necrosis in patients with granulomatous lymphadenitis in a TB endemic setting. The second would be the role of thoracoscopy in the diagnosis of pleural effusion, especially in such cases where we're trying to differentiate between sarcoid and TB, where in this case drug-resistant TB might have been a possibility. So in an aim to get a microbiological evidence. The next point would be pleural effusion in sarcoidosis. How common is it, and what are the possible clinical and biochemical markers that aid diagnosis or even exclude the diagnosis in such cases? And in our case, we had seen that the lymph nodes actually did not completely reduce with ATT and steroids, and we attributed this to the likely due to the interaction between rifampicin and prednisolone, where rifampicin would reduce the efficacy of prednisolone because of the enzyme induction. So this may lead to a suspicion of drug-resistant tuberculosis because there would not be a complete response in such cases. So how do we overcome this issue in our daily practice? Because many patients would be getting ATT and steroids, maybe from other centers, or even we might give such patients such dual therapy. So I just wanted someone to clarify these points for me so we could discuss on this.
Very interesting case, Sujay, actually. Just wanted to know about the second agent. When you have done thoracoscopic pleural biopsy, what was the agent which you have used? We probably missed it, actually.
Sir, sorry?
What was the treatment you started after the pleural biopsy was done in the granuloma?
We restarted the patient on steroids. He improved on that, and then he had complete clinical response. So we stopped the therapy also, and he's been following up. And since then, he's been asymptomatic as of now.
So second time when you did thoracoscopic pleural biopsy, you have altogether stopped the anti-tubercular treatment and given only steroids, or the ATT was also continued for some time?
Only steroids, sir.
Only steroids. Oh, that's quite interesting, actually.
Yes.
Because having a pleural effusion and then diagnosing it as pleural sarcoidosis is very, very rare in the clinical scenario. In fact, I would remember from Dr. Dheeraj Gupta's textbook a table on differentiating TB versus sarcoidosis. In fact, it would say that pleural effusion, if it's there, we would probably give more weightage to the diagnosis of tuberculosis there rather than sarcoidosis. Here, you have stopped ATT and given only steroid after documenting the granulomas. That's a quite an interesting case, actually, of pleural involvement of sarcoidosis. That also confirms that it's an autoimmune process. Yeah, Sujay, can you please?
Actually, outside itself, he had received ATT for 8 months, and he had come after the ATT was stopped with worsening. And he had also received steroids with the ATT. So when he came with this worsening, we were actually not very sure because ATT was stopped and now he had this pleural effusion, whether is it drug-resistant TB or whether the steroids did not have an appropriate effect, and that led to a flare-up of sarcoidosis. So that was actually an issue in this case for us. So we actually went ahead with only steroids because we had no microbiological evidence. The AFB gene expert in the pleural biopsies, lymph nodes came out to be negative repeatedly. The manto was again negative, although that's possible it is possible in sarcoidosis. So that's why we just went ahead with steroids at this point of time.
So Dr. Sujay, thank you very much for your presentation. I'm Dr. Ashfaq Hassan. I'm also co-chairing this session. Now you've put some very, very interesting thought-provoking questions there. And I would, can you flash your slide, please? The last one that is there.
AB team, can you project the last slide? Last slide of Dr. Sujay.
So the thing, meantime, the thing that actually gave us an insight into the sarcoidosis was the distribution of the lymphadenopathy, the absence of caseation in the granulomata, which you've done it almost twice, and the absence of the mycobacterial DNA from the sample. Now, it's extremely interesting because many of the patients in the recent past have been getting a combination of steroid and rifampicin, and we, in very, very few instances, had we to really consider an interaction between rifampicin and steroid as a cause of failure. So either this is an one-off case, or maybe we have not been looking keenly enough at the interactions. The other thing, of course, that adds to the thing is that pleural effusions are certainly remarkable in this kind of a situation. So in that context, at least one of your questions was about thoracoscopy, and we have actually begun to be more and more proactive regarding this, because the pleural fluid doesn't lend itself to excellent investigation. So if you have greater information, if you need greater information, we have to be a little bit more proactive about thoracoscopy, and that's one lesson that we have learned over time.
Right.
One more question was there.
Thoracoscopy and I think there is a question from
Yeah,
Dr.
Sujay.
Praveen, our infectious disease specialist.
Sujay, this is Praveen here.
Yes,
First
sir.
thing is, I agree with the rifampicin interacting with Visalone. The problem is the interaction is, if you see the PKPD studies, it will decrease the level of prednisolone by something 20 to 80%. So if your patient is someone who is just having a reduction in level by 20%, you might not have a very clinically significant difference in response. But if your prednisolone levels are falling by 80-100%, probably that might not respond, as you said. This interaction is again very important in the cardiac sarcoidosis patients, where they will be on something like amiodarone, and rifampicin will completely knock out amiodarone. Patient will be in VT storm, and one of the reasons was patient is on rifampicin along with amiodarone. Besides this, I want to put two questions. Have you ever thought of diagnosis of histoplasmosis in this case, given that patient is having similar presentation? Well, which should be one of your differentials. You have done a lot of biopsies, with every time it is gene expert negative. And second question is, have you considered doing the gene expert ultra protection compared to expert?
No, at this time we actually did not do a gene expert ultra for this patient. And histoplasma, second time when he actually came to us in July, he had this perilymphatic nodules, and he also had this, the distribution of lymphadenopathy was quite significant. So we had considered sarcoidosis only. That's why we started the patient on steroids.
That's a pertinent point. In 2018, actually, Gene Expert Ultra was not available to actually. Maybe the histoplasma is one thing we would have considered before starting treatment. But however, now you have the complete case scenario where the patient has responded only to steroid. Actually, if it is histoplasmosis, probably wouldn't have responded actually. So probably looking by everything in response to treatment, it's an unusual case of pleural sarcoidosis. Thank you very much, Sujay, for presenting this case.
Thank you so much.
So I invite Dr. Vishwanath now, and he will be presenting one very, very interesting case.
A very good morning, all. So I would be presenting this interesting case of 41-year-old male patient who presented with breathlessness to us actually. It was a 41-year-old male. I've seen him first in April 2014, and he was symptomatic for 4 months prior to the presentation. He had dry cough. He did not report any breathlessness. He complained of dryness of mouth and dryness of eye. And there was redness of eyes, and also blurring of vision was there. And he was in case of hypothyroidism. In the past, he was non-smoker. And clinical examination, except for the eye redness, nothing was significant. S2 was loud, and the cardiovascular examination. And ECG showed there was an T-wave inversions in V1 to V3. And echocardiogram showed severe pulmonary arterial hypertension with a high SP pressures. And the LV function and the RV functions were very good. And as a part of our evaluation for the pulmonary arterial hypertension, we have done an CT pulmonary angio to rule out chronic pulmonary thromboembolism, which is a potentially reversible and treatable cause of pulmonary arterial hypertension. In the CT pulmonary angio, there was only dilated main and the branch pulmonary arteries. Mediastinal lymphadenopathy was seen to our surprise, and the parenchyma was normal, totally normal. So that means there was no evidence of interstitial lung disease or parenchymal disease like emphysema, and there was no evidence of chronic embolism. So doing an CT pulmonary angio would give an idea about the entire lung parenchyma and also the pulmonary vasculature. As you can see in the chest X-ray here, there is enlarged enlargement of the hilar both on the right as well as the left side. And if you go to the CT scans, actually you can see that there is a bulky mediastinal lymphadenopathy. This is the you're able to see there. Yeah. So this is the bulky mediastinal lymphadenopathy. This is the ascending aorta and the descending aorta. You can see that there is an left paratracheal and aortopulmonary lymph node. There is a bulky lymph nodal mass, and again there is a left hilar lymphadenopathy. And as you can see in the subsequent images here, there is a large subcarinal lymphadenopathy where I'm pointing here actually. And in view of this bulky mediastinal lymphadenopathy, we thought we should consider an HIV as a differential diagnosis, and we did all the common workup which have to be done. One of the differentials for us was sarcoid-associated pulmonary hypertension. This was my first case of sarcoid-associated PH, because most of the pulmonary hypertension we have seen in the past were associated with interstitial lung disease. However, in this patient there was no interstitial lung disease. One of the differentials considered was HIV-associated PH with some kind of infection going on, and PAH because of HIV, and other differential was sarcoid-associated PAH. In the blood investigations, there was mildly raised calcium, there was low vitamin D, leukocytosis and thrombocytosis were there. There was a raised TSH actually. We had modified his dose of thyronum, and he had mildly increased alkaline phosphatase, and in the ultrasound abdomen there was a prominent portal vein which was suggestive of a congestive portal gastropathy or hepatopathy actually. And the spirometry as expected was normal, because the lung parenchyma was normal, the spirometry was normal. Vital capacity was 3.77 liter, and the 6-minute walk distance was 420 meters. So with this thing actually in mind, actually with the differential diagnosis which I have mentioned to you now, should we go ahead with sampling or not? Because one of the studies from which was published in Chest way back in 2013 or 14 mentioned that around 18 to 20% of patients with idiopathic pulmonary arterial hypertension have associated mediastinal lymphadenopathy. Ideally, if the lymph node in the mediastinum is more than 1 centimeter, that is when we would consider a lymph node to be significant. But remember that because of congestion in patients with heart failure, left heart failure or right heart failure, or patients with PAH, 18 to 20% can have mediastinal lymph nodes. So in these patients with pulmonary arterial hypertension, you should try to sample these lymph nodes when they are more than 2 centimeters in size, rather than sampling them when they are just more than 1 centimeter in size. So the literature available to us, actually, we have went ahead with the EBUS guided lymph node aspiration from the all the available lymph nodes. As you can see, this is the left paratracheal lymph node, the aorta and the pulmonary artery. The lymph node is extending between the area between the aorta and pulmonary artery, and this is the aspiration needle which is going into the left paratracheal lymph node. And we could aspirate even the right paratracheal lymph nodes and the subcarinal lymph nodes in these patients. And once the histopathology was available to us, to whatever clinically we were suspecting, the results were consistent with our pretest probability. The patient had non-caseating compact granulomas. The AFB stain was negative. Gene expert was negative for Mycobacterium tuberculosis, and the cultures were negative for Mycobacterium tuberculosis. And the ACE levels were 2 times raised than the lower limit of the normal. MON2 was non-reactive. And we also took multiple other consults. We had multi-disciplinary team discussions with the cardiologist, eye, rheumatologist, and also the gastroenterologist for the pertinent, relevant clinical issues. The issue now which would come here is a lot of people would say, because in patients with paucibacillary tuberculosis, all these gene expert or cultures can be negative. That is one argument which can come when we are discussing with many of the experts. But you should remember that clinical presentation is always consistent. It's not only the gene expert cultures which are negative. A presentation of pulmonary arterial hypertension is unusual in patients with tuberculosis. Unless they have a destroyed lung parenchyma, fibrosis and bronchiectasis, PAH would not occur in patients with tuberculosis. So with this in mind, actually we have made a diagnosis of sarcoidosis, which is involving the lymph nodes and causing pulmonary arterial hypertension with a functional class of 1. And here, please remember that the pulmonary arterial hypertension has occurred in the absence of interstitial lung disease. There is mild hypercalcemia, uveitis, and also the optic neuritis. This patient also has as I presented in the clinical presentation, with hypothyroidism and vitamin D deficiency. In view of his life-threatening, like a vision-threatening optic neuritis, after discussion with the ophthalmologist, we had to initiate this patient on pulse doses of methylprednisolone, followed by 1 milligram per kg of steroid prednisolone, and this patient, in view of a life-threatening presentation and the need for an prolonged immunosuppression, this patient was started on upfront steroid-sparing agent of methotrexate, oral methotrexate, started at 7.5 and increased to 20 milligrams per week with a close monitoring. And coming to the discussion of this case, the reason for choosing this case is that this kind of presentation of pulmonary arterial hypertension is sarcoidosis is less common, and there has been a detailed document on in European Respiratory Review recently on the pulmonary arterial hypertension in patients with sarcoidosis. Mostly it would present with ILD. However, 5% of the patients can have pulmonary arterial hypertension in the absence of any significant lung involvement, and the incidence of sarcoid-associated pulmonary hypertension is also different in different studies. So the cause for pulmonary arterial hypertension is because of various reasons in sarcoidosis. This is important. The reason is because there was one question from the Dr. Madhuri, rheumatologist, on whether to consider enhanced immunosuppression or not. So that would depend upon the cause of pulmonary arterial hypertension. Suppose if a patient with advanced lung parenchymal disease and is coming with severe pulmonary arterial hypertension, probably you would be doing more harm by giving more immunosuppression. So there would be role of PET in this kind of patients. So if the patient's disease, if we feel, is because of the vasculitis or granulomatous vascular involvement or because of the active parenchymal involvement, these patients would benefit from the steroid. And if the patient's pulmonary arterial hypertension in sarcoidosis is because of thromboembolism, these patients would benefit from the anticoagulation. So identifying and pinpointing the specific cause of pulmonary arterial hypertension in sarcoidosis is important. That would help us in deciding whether we would go for advanced immunosuppression or whether we would go with only with antifibrotics or whether you would go with anticoagulation or only patients like pulmonary vasodilators therapies which have been discussed in Dr. Shastri's talk. So in this case, I would like to highlight that all the mediastinal lymph nodes in patients with pulmonary arterial hypertension need not be sampled. Only with lymph nodes which are more than 2 centimeters in size need to be sampled. Identify the specific cause of PAH, which would help us in identifying the treatment options. And around 20% of the patients can have PAH without underlying lung disease actually. And one thing we should remember is if you have a patient who is having worsening of clinical symptoms and worsening of 6-minute walk distance without a fall in the vital capacity. So that is when you need to consider a diagnosis of sarcoid-associated pulmonary hypertension and evaluate for the cause. And this has also been dealt as to when we should consider doing an 2D echocardiogram. So with this few points of discussion, I would like to thank everyone for an kind listening. And I'd like to take any 1 or 2 questions as per the time.
Thank you, Dr. Vishwanath. Excellent presentation and quick couple of questions. We are running short of time. Dr. Narasimhan.
What is the DLCO in this patient? So that would have told us that there is a vascular involvement. There is no evidence of restriction, no evidence of obstruction. DLCO alone drops. Distinctly elevated PAH. Should have thought of a vascular involvement.
Yeah. So, Dr. Vishwanath, what was the oxygenation in this particular patient? I mean,
at presentation he was on normal room air and he did not complain of breathlessness actually.
Okay, so
only when he subsequently changed to WHO functional class 2, then we considered
so basically you had pulmonary artery hypertension, the absence of hypoxia. In other words, you had to look for something like some mechanistic, In this case, just wanted to know, did you consider alkaline phosphatase, raised alkaline phosphatase as a major clue for something like a surrogate for granulomatous disease, or?
So in this patient, mainly the clinical presentation and the non-caseating granulomas, which on the biopsies were the ones which we made us consider sarcoidosis, because the alkaline phosphatase was less than 2 times elevated. I would consider more than 2 times elevation of alkaline phosphatase as a significant thing.
And what about the collagen profile, Dr. Vishwanath?
Collagen profile was negative actually.
2 grams at all?
Collagen profile, ANA profile was negative.
So thank you. So if there one more question, please.
I would just like to know if there is any significant lymph nodal compression of the vasculature, pulmonary artery.
So
the
that was
on the right side. Just want to know.
So I think in this patient, though the lymphadenopathy was bulky and the scroll of the CT window, actually, we did not find significant compression with the lymph nodes. There was only significant lymphadenopathy, actually.
So thank you. I'll wind up with one last comment, because if you have something like an ocular and a cardiac going together, nowadays a new phenotype called OCCC phenotype, where they are postulating that the problem is coming through the neural network innovation of various organs. So that's very interesting, maybe food for thought. I thank you very much for the case presentation, and I think we are overshot the time. We'll move on to the next session.
Yeah, thank you very much, sir.
Thank you.
Thank you, Dr. Ashwak and Dr. Vishwanath, for moderating the session, and we thank all our speakers also for their wonderful talks. Thank our audience for their engagement in the session. In the interest of time, we do not have an official tea break. Our tea is being served outside. Please pick the least interesting session for you and have a quick 10-minute break when you can. I now invite the moderators for the next session, Dr. P.N. Rao and Dr. Dinakar. Thank you, sirs, for coming to us. Professor P.N. Rao is the head of hepatology department here at AIG. Sir needs no introduction, but apart from his many things, I would just like to say, sir is a wonderful orator, and any session he moderates is always a pleasure to be a part of. Dr. Dinakar is the consultant chief at Sunshine Hospitals, Internal Medicine, and he also is the managing director of GYD Medical Center. We request you, sirs, to start off the next session. The next session is the great masquerader of all time, sarcoidosis. Here we'll be inviting clinicians to speak on their organ involvement specifically in sarcoidosis. Thank you, sir.
Thank you. Thank you very much, Dr. Madhuri. Well, we have 3 sessions today, and then GI, gastrointestinal sarcoidosis, and neurological, and then renal. But your ERS 2021 have ignored except the cardiac, the neurology here, right? We've been put into the backlist, and they are not considered, and believe me, 251 pages by the ERS 2021, and they have conveniently excluded GI, hepatology, and then other things, and included small fiber neuropathy, right? Okay, and fatigue, right? Which is important to know about the fatigue, because even liver disease will have a fatigue. So, but they have considered this, and I would like you, you all know, you must be knowing already, but the Lung India June 2022, there's an excellent editorial, and this is not for us, for other non-pulmonologists and then rheumatologists, excellent, and brought out some of the differences of how differentiation between the tuberculosis and this, and the All India Institute has recently published the large data about 279. With this, I would like to call upon Dr. Anand Kulkarni. Anand Kulkarni is with us, in the hepatology department, but anything I would say about him would be biased, but believe me, he is a papier machine, right? He produces the papers like this, and then scientific trials, and then he is an expert in the analysis, and then systematic analysis. And after he has come, our publication rate from our department has gone up remarkably, and we have been put into both the national and the international arena because of him. Over to you, Dr.
Thanks a lot for the kind introduction, sir. Very kind of you. I'm actually thankful to AIG and the support of hepatology department and Dr. P. and Dr. D. N. Reddy. I would like to start my talk with thanking Dr. Narasimhan, Dr. Vishwanath, Dr. Ashfaq, Dr. Madhuri, who have conducted this seminar. Very interesting topic. I had to go through a lot of articles, very rare in India for us, for GI, for hepatologists. Although quite common for a pulmonology, actually there is almost 80% involvement of the liver, but usually ignored. I will be touching upon the incidence, the involvement of the organs, esophagus, stomach, intestine, pancreas, liver, and then we'll conclude the talk. We all know that sarcoid is a multi-system disorder. Anything from head to toe. It is caused by non-caseating. The known etiology is actually not known as far as I understand from my knowledge, and it is characterized by non-caseating granulomas. It can involve anything from oral cavity to colon. And GI sarcoidosis, luminal sarcoidosis is very less common. 2% symptomatic, 10% asymptomatic. Pancreatic, very, very rare. They may present with malignancies or something like masses. Liver involvement is very common. Asymptomatic is seen in up to 80% of the individuals. If you have the previous case was discussed that there is elevation in alkaline phosphatase.
symptomatic only in 20% of the patients. Esophagus was first, the involvement was described in 1948. Most often they have symptoms because there is involvement of the esophagus. You need to digest the food. There is, the commonest symptom is dysphagia. Others can be there like pain, abdomen, weight loss, odonophagia, and hoarseness of voice, and dysphonia or anemia. All the GI tract involvement, it is only 14% of the involvement of the esophagus, which is common. The next commonest organ is actually stomach, which is more commoner than esophagus. The mechanism of involvement of the esophagus is through intrinsic mechanism or the extrinsic. Intrinsic, where the granulomas may get deposited in the mucosa or the submucosa or the muscularis and then produce dysphagia. The most common area for granulomas to be accumulated is in cricopharynx, where they produce the dysphagia and can be diagnosed with barium swallow. Indirect mechanism, there is lymphadenopathy in this. The lymph nodes can cause extrinsic compression. There might be fistulas. Neurological involvement can again cause dysphagia in these patients and can present like something similar to achalasia. Diagnosis, we do an endoscopy for every patient. That's very easy for us. We find some nodules. The nodules can have that granulomas, which is diagnostic of esophageal sarcoidosis. Barium swallow can show that there is some obstruction, and that can help again to diagnose esophageal sarcoid. Manometry to assess the motility, and CT or lymph nodes, which is very common, commonly done for every patient. If the patient has persistent dysphagia, then we look for lymph nodes. This is the approach what we do. So basically, it's a combination of all. History matters a lot because extra GI involvement is more commoner than GI involvement. They will be having 80% of them will be having some pulmonary involvement or some pulmonary symptoms. Treatment again is steroids, glucocorticoids, and muscular. If there is muscular infiltration, we do myotomy. Cricopharynx, we do surgical myotomy. Esophagus, we do endoscopically itself. Stomach is the commonest site. 50% of all the GI involvement is because of the stomach. That's first described in Schaumann in 1936. It is usually a part of multisystem involvement. Only 10% have isolated gastric sarcoidosis. How can it present? If there is diffuse involvement, they can have pain, anemia, and weight loss. They can have ulcers. This is in around 20%. They can have pain and bleed. In around 10%, they will be having pyloric stenosis if there is infiltration of this granulomas over there. And almost 10% will have asymptomatic polyps, more usually single than multiple. Diagnosis again is endoscopy, which can show ulcers or the polyps or the scars of after ulcers. And sometimes it can also make colitis plastica, that is the malignancy. If you do a biopsy, probably then we'll be able to pick up the granulomas. Biopsy is very important for all these patients. Problem with biopsy in our case is we do a superficial biopsy. So in-depth, deeper biopsies will help us diagnose the gastric sarcoid. Glucocorticoids, they very well respond to glucocorticoids, PPIs, and PPIs are prescribed right and left for every patient. Probably if the patient is responding to a PPI, he may as well be having not just gastritis, it might be sarcoid as well. But only response to sarcoid, PPIs is only 7 to 10%. They don't respond, not everyone responds to PPI. But glucocorticoids plus PPI, the response rate is almost 80%. Small bowel involvement is the least common of all. It contributes to almost 70% of the GI involvement. There was a case series of almost 238 patients with 300 plus GI organ involvement. Duodenum was the commonest organ. Duodenum, they had polyps, they had ulcers. Diffuse duodenal involvement can also cause obstruction of the duodenum. Common symptoms, again, pain, diarrhea, and bleed. Biopsy is definitive for the required for the definitive diagnosis, and treatment includes glucocorticoids. Large bowel sarcoidosis, sigmoid colon is the one is commonly involved. If you do a sigmoid biopsy in this patient, you might find asymptomatic granulomas in them. And symptoms are usually related to the GI bowel symptoms like pain, diarrhea, weight loss, iron deficiency, anemia, and severe constipation. Problem with sarcoid is hypercalcemia can also cause constipation. So be aware that if the patient has hypercalcemia, please treat it because he might be having constipation of that. Constipation because of the hypercalcemia itself. Diagnosis is through biopsy again. Do a good biopsy, but usually a GI colonic involvement usually ends in a surgical treatment rather than a medical treatment. They usually don't respond to the treatment. Basic reason for this is the difficulty in diagnosis of colonic sarcoid. There are multiple differential diagnoses and the poor response to glucocorticoids, which makes them only amenable treatment as surgery. Appendix is also seen. 3% of them can present acute appendicitis. There is diffuse involvement of the appendix. They can have perforation as well, and that surgery is the treatment of choice. Rectal disease, usually part of multi-system disorder, and rarely can also present as rectal mass. Why we struggle with sarcoid is basically we have list of differential diagnosis. We have from head to toe, we have everything from esophagus. For everything there is 10 to 15 differential diagnoses. That's the reason we actually probably missing some earlier sarcoidosis. We don't know, probably we are missing sarcoidosis. In the search of diagnosis, we end up with only 3. One is irritable bowel syndrome, which is also called inflammatory bowel disease, and tuberculosis. Sarcoid less often, but this is a chart for us actually, not for I know all pulmonologists are very well versed with this. Basically, for differentiating IBD from sarcoid, we need extra GI organ involvement. There should be something like either lung or lymph nodes or the uveitis or cardiac involvement or neurologic, which is commoner with sarcoidosis, which is not seen with our IBD patients or IBS patients. Biopsy can also help us diagnose sarcoid. This is basically for us GI specialists, not for you guys. You are all well versed with this. And lastly, the important thing what I would say in sarcoid, one important point is spontaneous segregation. We recently had a patient 3 months back presented with elevated alkaline phosphatase GGT, advised for biopsy, not willing. We just prescribed him ursodeoxycholic acid. Now is absolutely okay. He has responded to that treatment and is not willing for any other investigations. He had hypercalcemia, he had elevated ACE levels. That's one tricky thing about the sarcoid, that GI especially they regress spontaneously. Pancreatic is very rare for us. Pancreatic head mass, which was diagnosed through endoscopic ultrasound and biopsy demonstration and very well responded to steroids. Coming to the last organ involvement and the most important for us, that is, if you see, these are all the studies published till date. The initial studies, the ACCESS study, 736 pages. There is symptomatic hepatic involvement in only 11 to 20% of the individuals. That's the published very rare, not done actually nowadays, but autopsy report says that almost 80% of them have granulomas. So hepatic granulomas are very common, but symptomatic hepatic sarcoid is only in 20% of the patients. Prevalence is around 20% of them had hepatic granuloma. The sarcoidosis is also hepatic sarcoid is more common in males. Symptomatic, they can have varied symptoms, just simple hepatomegaly. Abdominal pain is also common, and non-specific symptoms can also. That is, presenting as jaundice and pruritus, as sarcoid patient presenting to us is only seen in very rarely, that is 7% of the individuals. Cirrhosis, again very rare, only 6 to 10%. Unless you are giving them methotrexate, they may end up with us for cirrhosis early. Presentation, again, the alkaline elevation in alkaline phosphate is very common, that is seen in almost 90% of the individuals. AST elevation, ALT elevation in 50 to 60%, and synthetic function is very well preserved till last. MRI is most sensitive investigation for us. It reveals that low intensity hepatic are usually located in the periportal area, and they present with non-cirrhotic portal hypertension. They have lymphadenopathy, they can have chest involvement as well. Biopsy again remains the gold standard for us. If we do a biopsy, we will find granulomas and some other asteroid bodies and human bodies, but rarely seen as per in our experience. For sarcoid, for us it is a mimicker. Any patient with granuloma in the liver, first differential diagnosis in Asia, the most common cause is tuberculosis. Worldwide, it is primary biliary cholangitis or previously known as primary biliary cirrhosis. But sarcoid is one upcoming differential diagnosis for us or against the tuberculosis. The reason for this being it can affect any part of the liver. There is again direct dissection by the granuloma itself. There can be accompanying which can lead to damage to the hepatic parenchyma and presentation as hepatitis. Or there can be a fibrous reaction from the body leading to formation of the fibrosis or cirrhosis. The compressive effect of the granuloma itself can also cause something called as non-cirrhotic portal hypertension, or if it involves the hepatic venules, present as Budd-Chiari syndrome. So it can present as Hepatic injury, it can present as cholestatic injury because of the involuntary bile duct. There can be something called as vanishing, one of the differential diagnoses of vanishing bile duct syndrome. Nodular regenerative hyperplasia, if it involves the hepatic venules, then it can present as Butt-Child syndrome and cirrhosis. Recently, Dr. Vishwanath and I had discussion about one of the cases where the patient had HCG cirrhosis, hypertension. He had persistent cough. We thought it is probably infection. We tried to evaluate for reports till date that sarcoidosis can lead to HCC. The sarcoidosis then progress into cirrhosis, then HCC. But the prognosis of these patients are very dismal. This one study from ILBS published almost 22 cases where they had hepatic sarcoidosis presenting as portal hypertension. Most of them had non-cirrhotic portal hypertension. Had present 90% of them had elevation in alkaline phosphatase and GGT, and they were incidentally diagnosed to have sarcoidosis on liver biopsy. This is the approach. The problem with hepatic sarcoidosis is if the elevation is more than, some say two times, some say 3 times. If it is more than 3 times, start them on treatment. After biopsy, if the biopsy demonstrates there is the granulomas, ursodeoxycholic acid, which is right, left, and prescribed by everybody. If you start a patient ursodeoxycholic acid, there is good benefit for these patients, and they respond to this just ursodeoxycholic acid. They did not require steroids. They require steroids if they are not responding to ursodeoxycholic acid. The enzymes are normal, then keep monitoring their LFTs. Since they are already on methotrexate, then I do know that everyone tests for LFT. Be vigilant for development of fibrosis in such patients. The prognosis remains good. Cirrhosis is quite uncommon. To conclude, GI involvement is common in sarcoid. Stomach is the most common organ. There is diffuse stomach involvement and can also present sometimes with protein-losing enteropathy. Biopsy, ACE levels, and other organ involvement are clues towards the sarcoidosis. Hepatic involvement actually commoner than thought, but more data is needed on the treatment aspect, when to treat and how to treat these patients. Thank you.
Thank you, Dr. Anand. We'll go for the question and answers hours a little bit later. You can just sit in the audience. Well, then 2 people which I must acknowledge whom I traveled with. One when I was in Medicity. One is Dr. Ashfaq Hassan. We had a wonderful association there. By that time itself, he has written 2 books. Are still writing the books. He has already written 2 books on pulmonology. And another is Dr. Dinkar, who is our co-chair. And he is a real balanced internal medicine specialist. I would say balanced. You use the word with them. There may be many. Balanced in the sense that, where to stop the investigation, where to ask for investigation. And in these days of telescopic visions of all the specialists, this species is a rare species actually in this one. And whenever I need, even today, whenever I need, I still go back to him. Any difficult cases, I just send him and then take his opinion. Right. Over to you, Dr.
Thank you, Dr. P. N. Rao, for those very kind words, which I don't deserve. At this, I would like to take this opportunity to thank AIG and Dr. Narasimhan in particular. I think this summit was long overdue. Ideally, it should have been done by physicians who are lazy people. That's why we became physicians. Pulmonologists are busy doing interventions and sleep medicine, so it fell in the lap of Dr. Narasimhan to do it. But thank you for putting it all together. I know it was a Herculean task, remote presentations, etc. And one other point of coincidence is that you'll see a lot of people with their footprints in PGH Chandigarh, because this was one of the famous diagnoses for all our clinico-pathological conferences. It looks like TB, but it is probably fungal, it's sarcoid, or it's something, but it's not TB. So it's going to be sarcoid, Wegener's, histoplasmosis, like that. So we were sort of sensitized to, making a diagnosis of sarcoid during our early PG training itself. But yeah, now we know this is the era of evidence-based, and histopath is still the gold standard. And that background, I request Dr. P. N. Rao, who is also from PGI, to make some interesting case presentation.
Thank you very much. I am an intruder, actually. I did not send this earlier, the case, because it was written in such a small letters there, I missed it, this one. And I said that it's okay, it doesn't matter, Then Dr. Madhuri said, keeping in view of my age and also giving privilege as a chairperson, okay, sir, you can go ahead with it, right? So that's the reason why I am an intruder here. And these were the days, this is quite a very old data, not a data, case capsule, At that time, we were getting introduced to sarcoidosis, We never used to think of sarcoidosis in the liver in those days. And therefore, the investigations you must read not as on today, but as on that day, right? And this presentation, I would just make it. This is a 62 years female. She was a known diabetic, hypertensive. In fact, she was admitted for a laparoscopic cholecystectomy for a symptomatic gallstones. But then, as a preoperative evaluation, they found that there's AST and then ALT were elevated, and here the ALT was elevated more than the AST. And she was HbS positive also. And as usual, whenever laparoscopic cholecystectomy, anesthetist will put a brake there because the enzymes are elevated. They said that you solve the problem, then only I can give the anesthesia for her. And here we have a HbS positive was there, and therefore naturally it is useful thinkers that whether it is a reactivation of a hepatitis B virus at this stage. Then in between she had another investigation which I put a question mark, which I thought it was not relevant. Then on the April 2008, again the enzymes were elevated and the AST, ALT was more than the AST. Usual investigations were done, and endosonography did not reveal any, obviously in any gallbladder stones, before operation, if enzymes are elevated, it's mandatory to do US and then see that there are no stones in the CBD. And that was done, and this was investigated for AST and then ALT elevation for further investigated. DNA was that made our job simple, but that made it complicated also actually. That the DNA was negative. Then at that point of time, with this elevation, the DNA should have been high had there been any reactivation. So in essence, she was an inactive carrier, and therefore that was out. But still we had to do explanation as to why the ALT AST elevation was there to pave way for a successful laparoscopic cholecystectomy. Then we did an autoimmune workup. Asthma was positive. I don't remember what is the dilution at that stage. ANA was 1 in 20 positive. That's not sufficient. And then it has to be 1 in 80 or 1 in more than 1 in 100. Sufficient. AMA was negative. LKM was negative as usual. IgG was not done or not available at that time. And there was no history of indigenous or any other drugs, because one of the things which I always consider unexplained ALT-AST elevation is the DILI. At this point of a time, we did make a diagnosis of autoimmune hepatitis because of an prevalent basis of an ANA having ruled out other causes of this one. And we started her on the steroids and then in the tapering doses. Steroids were started on the date on which is mentioned here, and then you can see that there has been a very dramatic response to the steroids. It came down to 10 and then 18, 12, and then it remained like that. That solved the problem for the laparoscopic cholecystectomy for the surgeon. And then we confirm what we thought was really autoimmune hepatitis. We requested them to do a biopsy. At the time of the laparoscopy, you can do a biopsy. You actually should have done the biopsy earlier itself, but because of we thought it's an autoimmune hepatitis, we started, and the response was there. Within 1 week, they dropped, and therefore we thought that was indeed an autoimmune hepatitis. And we do some kind of a scoring for the autoimmune hepatitis here with the treatment with the steroids. It comes under a probable diagnosis. And then laparoscopic liver biopsy has shown completely different thing. They was not autoimmune hepatitis. It was granulomas were there, non-caseating granulomas were there, Gill-Nielsen stain was negative, and this was a case of a hepatic sarcoidosis. And no wonder it has responded to the steroids. Autoimmune hepatitis response, and it also responds. Then we put it again for the scoring system. After the biopsy, if there are granuloma, they will get a -3 points, and therefore suddenly it dropped that this is not autoimmune hepatitis at all. This was sarcoidosis masquerading as an autoimmune hepatitis. And in view of the steroid responsiveness, and there was no evidence of autoimmune hepatitis in the biopsy, we thought that it was a sarcoidosis. And then, of course, we went ahead with the HRCT test, Dr. Vishwanath, they're all angry with us because we do US but not an EBUS for them. And US again, for this just to prove the point that it is, there are mediastinal lymph nodes were there, and lo and behold, and then you had the sarcoidosis there itself. And further follow-up, we lost for the follow-up. We really do not know the natural history in this particular patient. So, as Anand has already told, the protein manifestations are there. This is one of the cases which have opened our eyes that you must do a biopsy in such cases, without resorting. Fortunately, she responded because the treatment has been the same thing. And thank you very much. I will join as a chairperson.
At this stage of the particular session, since the GI part is over, can I invite some questions from the audience?
So that we can relieve Dr. Anand for his OP and then other.
One other case which came.
Only thing is, I was just wondering, we get often, an unexplained alkaline phosphatase and unexplained GGT. All ruled out, no alcoholism, no this one, and 80% are asymptomatic. I wonder whether they are. Unfortunately, this is not a disseminated sarcoidosis, is very rare, about only 10% of them. Amyloidosis, wherever amyloidosis is there, you say rectal biopsy and then gingival biopsy. Your diagnosis is made.
Exactly in that context of that combination of unexplained elevation of alkaline phosphatase and GGT, we had also done some biopsies. Non-cascading granulomas, some of them turned out to be brucellosis. Of course, we had that subsequent confirmation by IgM, IgG tests, but something to keep in mind if somebody rural background and the usual animal exposure, etc. Dr. Ashwak.
So thank you, Dr. P.N. Rao. And this is about the ERS guidelines, which you so love. Now the thing is, suppose you had done this biopsy on any other specimen within the GI tract. Maybe it will be the gallbladder or even the intestine, and you found the non-caseating granulomata there. How important is the absence or the presence of a second organ? Because to diagnose sarcoidosis, you need a second organ in a presentation that is compatible. You need not biopsy it. But how many times would you make a diagnosis of sarcoidosis directly based on non-caseating granulomata without, in the absence of other second organ?
Anyway, in our limited experience about the hepatic, we had about 10 to 15 cases so far. The HRCT helps us. Somehow or other, mediastinal lymph nodes are positive in these cases.
That's my question. In the absence of any second organ, obvious second organ involvement, would you still pursue a diagnosis of sarcoidosis in contradiction to the ERS guidelines, or would you kind of, say it is something else?
I don't, and since there are no genetic or ISA markers in these cases, if you excluded all the other causes, just like sometimes we give steroids for this one, if it's been enzyme elevations are there, if no other organ is involved, if you excluded all the other causes, if a biopsy shows that is a non-caseating granuloma, then we will consider this as a sarcoidosis. If there is no drug history, mainly drug history can have a granuloma, and the brucella is negative, which is said that there is no, then we'll put them to the steroids and then see the response. Response is usually excellent in these people.
Sir, my question is a non-gastroenterologist. So should we take 2 times elevation of alkaline phosphatase is significant? What is the cutoff?
No. Actually, these 2 times, 3 times has come with a pregnancy and the other causes. Actually, any elevation is, it has to be taken. If you ruled out a bone, that of course you do by GGT, you will know that if both the alkaline phosphate GGT are elevated, it has to be liver. If a GGT is not elevated, only alkaline phosphatase, you must rule out, of course, pregnancy, and also you have to rule fasting. Otherwise, intestinal alkaline phosphatase will come. When unexplained alkaline phosphatase, if it's not a fasting one, do again once fasting, and then you have to see. Otherwise, as far as I am concerned, the elevation, the 2 to 3 has come for actually PBC, primary sclerosing cholangitis. How much you must treat has to reduce after the treatment. So for us, for me, any elevation we have to investigate.
Okay. The case which I presented, it was 150 and the cutoff was 120 actually. That gastroenterologist which we were consulted at that time said that it would not be so much significant. That is the reason why I asked. And the second question is on biopsy. So suppose there is unexplained alkaline phosphatase elevation. Would you do liver biopsy in all the cases? Or in Anand, one of the
Yes,
slides
yes.
mentioned that it's less than 3 times elevation observe and more than 3 times elevation of alkaline phosphatase, go for a biopsy. What is the consensus on that? Like, would you do a biopsy on every patient with alkaline phosphatase elevation?
And if it is a persistent elevation of the alkaline phosphatase, and if there are any symptoms are there, if the patient is any kind of a symptoms, even a simple symptom like a fatigue and then symptoms are there, then I would go for a biopsy. And then while waiting, you will know, what happened 3 months, whether it's going to increase or whether it's going to be static.
Yeah, thank you, sir.
Sorry, Anand, I am sorry, I should not, I am taken away mic, this one, please.
Elevated 2 times, then we are more cautious that and we extensively investigate. Less than 2 times, we tend to follow them up and ask for the other histories as well. As sir said, fasting is required for them. 2 times at least to check for liver test. And liver biopsy, if it doesn't show only pure hepatic sarcoid, what we have encountered is we see elevated calcium and AC levels, then we treat the patient. And the patient usually presents only alkaline phosphatase DGT elevation. And the panel for us is elevated ALP GGT, check for LDH, check for calcium, check for AC levels, we get a rectal biopsy. If all these LDH for lymphomas, AC levels for sarcoid, rectal biopsy for amyloid. If these three, this is the first thing what we do when we see elevation in ALP GGT, apart from MRCP.
So regarding the same thing, alkaline phosphatase, it is basically all we know, it's an acute phase reactant. Whenever there are raised inflammatory markers, alkaline phosphatase is one among them, it will raise. We do see that in all rheumatological conditions, whenever you see high ESR CRP, alkaline phosphatase elevation would be there. It need not be there all the time, but for us, it is one of the acute phase reactants, like ferritin.
You repeat it and then acute inflammatory markers will not be there in the next time, they would be, then it will become normal.
With that, we will go on to the next topic, that is neurological sarcoidosis. Will be presented by Dr. Mulidhar Reddy. He is a consultant neurologist from the Department of Neurology Care Hospital, Banjara Hills. His areas of interest are neuromuscular and neuroimmunological disorders, stroke and cerebrovascular disorders, vascular and neuromuscular ultrasound. Among his achievements, he was best outgoing student in MBBS, Sam GP Moses Gold Medal in DNB General Medicine in year 2010. He also had Best Paper Award in Stroke at IAN 2021. And he is also involved in several clinical trials, notably the DOAC, CVT, Sprint India, etc. I request Dr. Mulidhar to make his presentation.
Thank you for kind introduction, sir. At the outset, I would like to thank Dr. Narasimhan sir, Madhuri and Dr. Muttaya, who has invited me to deliver in this lecture. So my outline would be most of things, pathogenesis, drugs must have been a repetition. I would like to just concentrate mainly on the clinical features. So the outline of the talk would be to pose these questions and answer these questions. How common is the neurosarcoidosis? And how does it establish in the nervous system? How does it actually spread to the nervous system? What parts of the nervous system are usually involved? And how does it present? What are the clinical features? And what are the mimickers? Some of the mimickers were discussed in the previous talks also. What are the diagnostic criteria and how to treat? And leave you with a brief take-home message. So how common is sarcoidosis? Sarcoidosis, actually, there are not a lot of literature in the Indian literature. Recently in 2022, there was a big paper. The true burden of sarcoidosis in India is not actually clearly known. There is just OPD based studies where in Calcutta, actually, there were around 10 to 12 cases per 10,000 registrations, and in New Delhi, it was 61.2. per 1 lakh new cases in New Delhi. This is actually the basic literature that we have from India. Out of these sarcoidosis patients, how common is neurosarcoidosis? Actually, there are various series, retrospective series and some prospective series and some OPD-based studies. It was shown that actually there is a wide variation. The variation is ranges from 5 to 34% of the systemic sarcoidosis patient had neurological manifestation. And indeed, the neurosarcoidosis patients, around 15% of the patients, in their initial presentation only will be neurosarcoidosis, and eventually within 5 years they usually develop other manifestations. So isolated neurosarcoidosis is also known, and if it is involved, actually the multi-axial involvement is very common. So coming to Indian data, this is the latest series which is published in Lung Indian Journal. So as you can see here, this is a very big series. Out of this series, the neurological sarcoidosis was shown to be around 4.3%. So this counts to around 5% of the patients will have neurological involvement who have lung involvement. So how does it establish in brain? So this is the routine pathogenesis. I'll just sum it up very briefly. There are some infective and also non-infective triggers. Infective triggers usually tuberculosis and propionibacterium, which are actually described in sarcoid. Actually, these antigens from these things, they actually are presented to the MHC cells, and they are presented to the T helper cells, and we get a Th1 response. The Th1 response, we get interferon gamma and also IL-2, IL-12 from the macrophages and the granuloma. This is actually self-perpetuating. There is a positive feedback and there will be granuloma start increasing. So the mechanism is actually the sarcoidosis first spreads to the meninges. From the meninges, it goes to the vessels and it goes into the parenchyma through the Virchow-Robin spaces. The exudates, they extend through the Virchow-Robin spaces to the parenchyma, and from there onto the cranial nerves and other things. There is actually something called a perineural spread also, which recently just now sir has actually told. Perineural, there is a hypothesis that from the sinonasal sarcoidosis through the perineural spread, like fungal infections, it can spread to the brain too. So what are the parts of neuraxis involved? So neuraxis can be again divided into central nervous system and peripheral nervous system. In the central nervous system, the dura mater is involved in some proportion of patients, which I am going to show in the next subsequent slides. Leptomeninges are also commonly involved. Cranial nerves are very commonly involved. This is actually the commonest manifestation which everybody knows. The hypothalamo-pituitary mechanism, like I told in previous slide, from the sinonasal, it can spread to the perineural, spread to the pituitary and the hypothalamus. It can spread to brain parenchyma. There will be white matter changes. They appear as ischemic changes sometimes, and it can form actually nodular kind of features too. It can cause myelitis, various forms of myelitis, and cauda equina. It is in the roots. And in the peripheral nervous system, it can involve the nerve roots. It can involve the peripheral nerve, and it can involve the muscle. So there are a lot of various varied manifestations all along the neuraxis which are involved. I'll concentrate mainly on the clinical manifestations because the diagnostics and also the treatment is almost same like rest of the organs. So these are various parts, these are various series or retrospective series which have been published in the literature, and these are the proportions of various, and we have some Indian literature too. There are two series of two studies which have been done, one from the North India and from South India. Actually, they were published recently in our National Academy journals. So these are the various proportions of the patients: optic neuritis, myelopathy, facial nerve palsy, external ophthalmoplegia. Some patients have ataxia, seizures, encephalopathy, bulbar palsy due to various cranial nerves, peripheral neuropathy. And this is another study from the CMC, which has been published in 2020, which shows actually a lot of cranial nerves and what are manifestations which I have told. So cranial nerves. So the most common presentation is the facial nerve. It can be unilateral or it can be bilateral. It is very easy. We just pass it off as a Bell's palsy. The mechanism why actually the facial palsy is involved is it could be directly granulomatous infiltration into the nerve, or it could be because of the parotitis, what we call Hereford syndrome. So optic nerve, usually the Bell's palsy, the facial palsy is usually self-limiting and they will have very good prognosis. Unlike the optic neuropathy, due to sarcoidosis, it won't have so good recovery and good prognosis. The optic nerve usually presents with field defects because the optic nerve is because of the infiltration and the hypothalamus and the mass lesions compressing on the chiasma. They will have various kinds of scotomas, junctional scotomas and anopic defects. And the third nerve, which is more commonly involved, is the eighth nerve. The eighth nerve can have both the vestibular component and also the auditory component. The patients can have vertigo and also hearing loss. So all these patients, all the nerves, they can be unilateral or bilateral. They can be simultaneous involvement. There can be synchronous involvement. In addition to this, there could be bulbar. These are the most common cranial nerves involved. Bulbar nerves and other nerves also, extraocular nerves also can be involved. And these are all involved because of the sarcoid infiltration of the granulomas. So that is about the cranial nerves. Next, coming to the meningeal disease, as I'm showing here, whenever I say meningeal disease, there is something called as dura mater, pia mater, and arachnoid matter. Pia mater and arachnoid matter are called as leptomeninges. Dura mater is called as pachymeninges. On the MRI, whenever we see anything on the surface which is very thick and not entering into the sulcus, the enhancement not entering into the sulcus, it is called as pachymeningitis or only dural involvement. Whenever it is going into the sulci as it is shown here, it is actually the leptomeningitis. So meningeal disease, actually it can be both leptomeningitis and also pachymeningitis. There are 3 to 4 types of meningitis which we have to consider in patients with sarcoidosis. It could be aseptic meningitis, which will have very good prognosis. Usually we get to know when patients have other organ involvement and they actually ask us to do CSF and we see some cellular pleocytosis. Usually they have very good prognosis. Some patients present with chronic headaches, like we find like cryptococcal meningitis, like something like that kind of presentation. They will have chronic persistent meningitis. And there is another type of meningitis, like mass lesions. They appear like meningiomas. The dura mater will be so much thick and it appears like a mass. We are going to parade one case also later in the segment of interesting case discussions of that sort. And there are various other clinical presentations too. Hydrocephalus. Hydrocephalus is because of the raised ICP. It can be because of various reasons. So it is usually present in 5 to 38%. It can be communicating, non-communicating hydrocephalus. Non-communicating because of the granulomas, communicating because of the exudates secondary to meningitis. And usually this hydrocephalus can have a chronic course, and usually patients like optic nerve will have very poor prognosis. Headache could be because of the same reasons almost. And seizures also could be because of the same reasons. Sarcoid vasculitis is also very well known. It can cause arteriopathy and vasculitis. And some patients, they can have cardiac involvement and embolic strokes also. Such patients can have seizures too. And patients are also, it is almost like SLE. Neuropsychiatric sarcoidosis is also well known. It is actually called as parasarcoidosis. They are actually not direct involvement. It is the other manifestations. They can have depression, psychosis, mood disorders, and other things. So now coming to the hypothalamo-pituitary dysfunction, as we have discussed earlier, hypothalamo-pituitary can be affected by the perineural spread directly into the areas. There could be hypothalamic involvement. Hypothalamic is a seat of lot of functions. So when the satiety center could be involved, they can have morbid obesity, temperature variations, and all those things. When the anterior pituitary is involved, there could be amenorrhea, galactorrhea, hyperprolactinemia, and posterior pituitary diabetes. Usually posterior pituitary is most common involvement which usually they manifest. Then myeloradiculopathy, there are a lot of, this is another common presentation. It is usually seen in around quarter of the patients, myeloradiculopathy. The mechanisms, it is same like as we classically teach you what are the mechanisms of TB affection in spinal cord. There will be a lot of variations. It could be because of the infiltration of the spinal cord, meninges, it could be extradural involvement, or it could be compression of the spinal cord directly, or it could be just a simple transverse myelitis too. The pattern of myelitis, LETM is the most common, longitudinally extensive transverse myelitis, and the short tumefactive myelitis. And the radiological hallmark, actually whenever we see LETM, we see for some hallmarks to actually differential diagnosis. One of the hallmarks is actually called trident sign. I would show here trident sign. As you can see here, this is actually the dorsal cord, this is the ventral cord. Along with the meninges, as you can see, there is something called as a trishul sign. This is what is called as trident sign. This trident sign is very pathognomonic and radiologically pathognomonic of neurosarcoidosis. Next, peripheral nervous system involvement. Peripheral neuropathy can be there. and myopathy can be there. Usually the common type of peripheral neuropathy is a symmetric axonal polyneuropathy, but there can be mononeuropathies multiplex too. It could be usually subacute to chronic course. Sensory involvement will be more than the motor involvement. And as sir has already discussed, there is some evidence that small fiber neuropathy is also associated with sarcoidosis. So again, myopathy, there are various types of myopathies. It could be nodular sarcoid myopathy, where the patients will be very indolent course. They won't have any symptoms. When you palpate, there could be some nodules, or when you do the muscle ultrasound, there could be some nodules. Or acute myositis, it is almost similar to inflammatory myopathy. When we do the biopsy, we see the granulomas and infiltrates. And chronic myopathy, which is very slowly progressive, like IBMs also can be. These are all the various kinds of presentations. So, so these are all the various aspects of the presentations. Now, always a differential diagnosis. So, sarcoid is always a diagnosis of exclusion, even by the criteria laid down by the consortium in 2018. So, alternative causes have to be always ruled out before labeling it short of biopsy, to at least label it as a probable diagnosis. So infective causes, fungal, tuberculosis, we have to rule out. Inflammatory causes, demyelinating, multiple sclerosis. There is a saying that if anterior compartment is involved, it is most likely to be sarcoid. If posterior compartment is involved with similar kind of lesions in the dissemination in time and space, it could be most likely a sarcoidosis. Neoplastic lymphomatous, which may respond partly to steroids. Carcinomatosis also, like dissemination in time and space, we have to actually rule it out. These are the various clinical pictures. So it is a clumsy slide. What are all the investigations we have to do? I am just outlining. So there is a diagnostic criteria. Previous diagnostic criteria were also there, but they were not validated. This is the latest 2018 diagnostic criteria, consortium diagnostic criteria. This came in JAMA. Actually, we divide into definite, probable, and possible neurosarcoidosis. Definite sarcoidosis should have the clinical presentation which is typical, along with the biopsy features from a cranial structure. If we cannot actually do a cranial structure biopsy, if the clinical presentation is very typical and we get evidence from the extracranial structure, then it is a probable sarcoidosis. Then short of all these things will be a possible sarcoidosis. But all the diagnostic criteria, it is a very strict rule that we rule out all the other alternative explanation. Treatment, I'll just rush through this because the treatment is almost similar to other organs also. It is actually to goal to reduce and prevent the organ damage. If there is very mild, like facial palsy, the treatment itself is not necessary. We can just leave it. And interdisciplinary approach is necessary to coordinate when there is other multi-system organ disease also. There are no randomized trials till now. Only treatment is largely based on the expert opinions and observations from the case series. And these are all the various treatment agents. Right now, there are novel agents. There are some research going on JAK-STAT inhibitors also, but these are all the various drugs. The first line drugs always will be steroids. Short of that, we will give a steroid sparing agent, usually methotrexate. It has been shown that methotrexate will have more better outcome when compared to mycophenolate. So usually either we give methotrexate or azathioprine, usually reserve mycophenolate in resistant cases. Monitoring and outcome, usually if there are clinical features, we usually monitor clinically. If there are MRI features, we actually repeat the MRI after 2 to 4 months. MRI resolution may be more quicker than the clinical resolution. There could be a clinical lag. Clinical outcome, however, depends upon the site of involvement. Like I said before, facial palsy will have a best recovery chances, whereas optic neuropathy, they will have not so good recovery. Similarly, patients who have actually peripheral nerve disease will not have so good recovery. Patients with hydrocephalus will not have so good recovery. So this myelopathy also may not have so good recovery with the medication. So that's all. This is a brief thing. Take home message will be actually neurosarcoidosis. We have to suspect when the patient has these clinical features. One thing is whenever the patient presents with cranial neuropathy, simultaneous or synchronous facial palsy, or optic neuropathy, or any other bilateral eighth nerve, usually eighth nerve is another one. And myelopathy, usually subacute to chronic myelopathy, myeloradiculopathy presentations, even cauda equina syndromes, which are indolent course, we have to suspect sarcoidosis. And peripheral neuropathy, which can present with subacute polyradicular neuropathy. And meningeal disease, usually hypertrophic pachymeningitis or leptomeningitis, sometimes we have to consider. So we have to always do a rigorous exclusion of the alternative diagnosis, which is actually a must before actually ruling out. Isolated neurosarcoidosis is not uncommon. Around 15% of the patients can have only isolated neurosarcoidosis without any extrinsic organ involvement. That's all. Thank you.
Thank you, Dr. Mulidhar, for that extensive review. And as you have repeatedly highlighted, it is more of a diagnosis of exclusion after having diligently ruled out other causes along the entire neuro axis. Then we could come to the conclusion of neurosarcoid. In the interest of time, maybe we'll just have one question, or I've been prompted to go to the next session. Okay. Thank you, Dr. Murali.
Thank you, sir. Thank you.
Next talk will be by Dr. Rekha Palagu, who is a nephrologist at AIG, and she will be speaking to us on renal manifestations of sarcoidosis.
I think after the session tomorrow onwards, we think everything is sarcoid only for next 1 week.
Correct.
Then when it required, we forget about that. Over to you, Dr. Rekha. She is our consultant nephrologist here. Tell us about the renal sarcoidosis.
Good afternoon, everybody. I think we are almost getting to the lunchtime. I thank all the organizers for giving me this opportunity. So we'll just briefly go through the renal sarcoidosis part. So I'll just start with a case scenario. So we had a 50-year-old male with known diabetes and hypertension who presented to us with pancreatitis. And during the evaluation for pancreatitis, we found out that he had hypercalcemia. And his creatinine was 7.5 on admission. The urine was showing to 1 plus albumin with a protein creatinine ratio of 1.6. So calcium level was 15.5. So at the time, our differentials were mainly, we were thinking in terms of, given the age and high calcium levels, we were thinking of multiple myeloma and possible malignancy as the causes. So when we worked him up, basically, initially we hyperparathyroidism is also a cause. So we first sent the PTH levels, which came back low, which were 37, and 25 hydroxyvitamin D was within normal limits. We also sent a 125 hydroxyvitamin D, which came back high, but this almost took us more than 10 days to get the report. ACE levels were also sent, which were high, like 220. So we did an ultrasound for the workup for AKI. Kidneys were normal, there was no calculi, and CT chest we did, which showed mediastinal lymphadenopathy. So because of the lymphadenopathy, hypercalcemia, AKI, so we underwent with a whole body PET, which showed lymph nodes basically above and below the diaphragm, which was highly suggestive of granulomatous disease. And our myeloma workup turned out to be negative. So he underwent EBUS, which of the mediastinal lymph node, which basically showed non-necrotizing granulomatous lesions, which were more consistent with sarcoid. And then we kind of did workup for TB, mainly by Gene Expert and Montu, which were negative. So we treated him for hypercalcemia, at the same time started him on oral steroids at 1 mg per kg. So at that time, we noted a significant improvement in AKI. His creatinine was gradually improving. So renal biopsy was withheld. So we discharged him with a creatinine of 3.4, and later on follow-up OPD visit. At 1 month, his creatinine has improved to 1.5. So with that, these are the objectives I would like to go through: the epidemiology, renal manifestations, diagnostic workup, and treatment of renal sarcoid. So epidemiology, as you can see, we all know that by now that sarcoid involves from head to toe, but renal sarcoid prevalence is as per the ACCESS study, which was done in 1999, where it had almost more than 700 patients. The prevalence was around 0.7%. So, but the prevalence all over the studies have been ranging from 1 to 50%. The age of onset is around 4 to 5th decade of life. And although sarcoid is more common in females than males, renal sarcoid is more common in males. And hypercalcemia is noted in almost 10 to 20% of the patients. And without hypercalcemia, you can also notice hypercalciuria, which is almost 30%. So these are the different types of renal manifestations. So the most common is the interstitial nephritis. So it can be associated with granulomas or without granulomas. And there are some associations with glomerulonephritis. So very rare case reports and case series have been described where there is biopsy proven IgA nephropathy and membranous glomerulonephritis, which is associated with sarcoid. Since it's a short series, it's mostly thought to be an association rather than a causation. And in membranous nephropathy, idiopathic membranous nephropathy, generally we have anti-PLA2R receptor antibodies, which we use them as a diagnostic for idiopathic membranous. But it's interesting to note that membranous nephropathy with sarcoid can also have anti-PLA2R receptor antibodies. And the third type of presentation is hypercalcemia or hypercalciuria, which can lead to nephrolithiasis or nephrocalcinosis. And the rare manifestations are mainly AA amyloidosis, and amyloid can also present as a renal mass, which can cause obstructive uropathy and hydronephrosis. So going to the interstitial nephritis, as you can see in the biopsy on the left side, this is a renal biopsy which shows basically diffuse interstitial inflammation, and on the high power you can see that there is a granuloma with multinucleated epithelioid cells. So these patients mainly present with systemic symptoms. As sir has pointed earlier, it's mainly they come with fatigue, fever, and weight loss. And the other most common other presentation is they have elevated serum creatinine, and this will be the reason to come to the nephrologist and undergo further evaluation. And our evaluation mainly starts with a simple complete urine examination, where generally it's a benign sediment unless there is glomerular involvement. So they present with mild proteinuria, which is in the subnephrotic range. Sterile pyuria can be noted, and microscopic hematuria can be noted. So followed which it's more in the consists with the tubulointerstitial disease. So when the etiology is unknown, we can proceed with the renal biopsy, which shows the findings of interstitial nephritis. And sometimes granulomas can be seen, especially when there is advanced chronic disease. We see numerous granulomas. If it is an early disease, we may not see granulomas, and it can present mainly as just only as tubulointerstitial nephritis without granulomas. So at this time, we have to look into the differential diagnosis of other causes of granulomatous nephritis. So as you can see, the list is extensive here. So it involves mainly the most common differential is drug-induced, where a number of antibiotics or anti-inflammatory agents, diuretics, these medications can cause granulomatous interstitial nephritis. But in drug-induced, generally the granulomas are not numerous, and they are more seen in the corticomedullary junction, whereas in the sarcoidosis, the granulomas are more in the cortex. And the granulomas are more defined in sarcoidosis, whereas in drug-induced interstitial nephritis, the granulomas are not very well formed and the borders are hazy. But these are not classical findings, but these are some tips which can be used to try to differentiate between these two. And infectious causes, as we know, Mycobacterium tuberculosis is one of the major causes, and there in infections you can mainly see necrosis in the granulomas. And other systemic diseases such as SLE, Sjogren's, IgG4 disease, they all present with interstitial nephritis, sometimes associated with granulomas. So we reviewed our data at AIG Hospitals, where we have almost 1,490 cases of biopsies done in the past few years. And out of these, we had 63 cases of only interstitial nephritis. And as per our data, we have 5 patients who had granulomatous interstitial nephritis and non-granulomatous interstitial nephritis. A total of 7 cases, which comes to 0.5% of sarcoidosis in our patients. Coming to hypercalcemia and hypercalciuria. So as we know the pathophysiology, mainly there is macrophage activation, which causes interleukins, and TNF alpha activation, which can cause activation of the or hydroxylation of the 25 vitamin D, which will cause 125 hydroxy vitamin D to increase in the granulomas, which will cause increased absorption of the calcium and phosphorus from the small intestine, which will cause hypercalcemia. Sometimes hypercalcemia may not be present, and we can see only hypercalciuria, which can be noted by 24-hour urine calcium. So the 24-hour urine calcium can be more than 250 to 300 milligrams per deciliter per day, which makes a diagnosis of hypercalciuria.
and this can cause nephrolithiasis and obstructive uropathy. So in cases where you have sarcoidosis causing the hypercalcemia, PTH levels will be low and 25 hydroxy levels will be normal. 125 hydroxy vitamin D levels will be high, but there are cases where 125 hydroxy vitamin D levels have been reported to be normal. In these conditions, it has been thought that PTH related peptide, which can be produced by the granulomas, is the cause for the hypercalcemia. So hypercalcemia can cause kidney injury by different mechanisms. First is there will be a drop in the GFR by direct renal vasoconstriction. There will be constriction of the renal efferent arteriole, so which causes a decrease in GFR, and there can be inhibition of the sodium potassium ATPase of the renal tubules, which will cause acute tubular injury, and prolonged hypercalciuria will cause nephrolithiasis, which can cause obstructive uropathy, and hypercalcemia also will cause ADH inhibition. So there will be polyuria, which will cause dehydration, and hypercalcemia can also cause vomiting and nausea, which can lead to dehydration. So all these mechanisms contribute to kidney injury. So these are few slides which show the nephrolithiasis. The prevalence range is from 3 to 14%, and predominantly it's calcium oxalate stones, and rarely calcium phosphate stones are also noted. So diffuse nephrocalcinosis in the right side, which can cause irreversible CKD. And these are biopsy slides where we can see calcium deposition. In the left side is the von Kosa stain, where there is calcification in the tubular lumens and the basement membrane. And the right side you can see there is diffuse inflammation in the interstitium, and the tubules have the infiltration of the tubules have the calcium, which causes nephrocalcinosis. So how do we work up for the renal sarcoid? Basically, we get the routine urine investigations and also the serum calcium and serum creatinine. So if all these levels are normal, then basically we can rule out renal sarcoidosis. If there is an elevated creatinine or a decrease in GFR, or proteinuria is high along with leukocytes or erythrocytes in the urine, then kidney biopsy will try to give us the answer. So either it can present as interstitial nephritis, or rarely glomerular nephritis can also be involved. So if there is hypercalcemia, then we actually do a kidney ultrasound, which shows either nephrocalcinosis or nephrolithiasis. If the typical findings are not present, and you have the other findings of elevated creatinine, kidney biopsy can be done to diagnose sarcoidosis. So what are the treatment options? Basically, the first line of therapy, as in other areas of sarcoid, is corticosteroids. So we use prednisone. And second line of therapy will be immunosuppressants, and third line will be TNF alpha inhibitors. So corticosteroids are the first line of therapy. They are more effective, they are rapidly acting, and they are easily available. For renal alone, we can start the dose from 0.5 to 1 milligram per kg per day, and 4 to 6 weeks of therapy is given, and based on the response, the therapy can be slowly tapered to a maintenance dose of 5 to 10 mg per day, and the duration of treatment can be prolonged even up to 2 years. So we have very limited data on the treatment of sarcoid. Most the literature comes to mainly to case series or retrospective studies, which involved 47 study involved renal sarcoid, where only outcome of 47 patients have been looked into, and this was a French study which was done in 2022. Sorry, it was done in 2019. And based on this, as you can see, there are patients have been classified into different stages of CKD. And stage 4 CKD and stage 5 CKD, as you can see, these are the patients who have improved after 1 month of therapy. So that is a significant response to corticosteroids at 1 month. And this actually translated to 1 year of follow-up, where there was an improvement even after 1 year of follow-up. And the second figure shows mainly the eGFR at presentation. Here they have divided the patients into 3 groups, F1, F2, F3, based on the renal biopsy scores of the interstitial fibrosis. F1 being the least and F3 being the severe fibrosis. So people who were treated, who had F1, responded well to therapy with an improvement in GFR at 1 year and 18 months of follow-up, whereas patients who had F3, disease which shows that there is severe interstitial fibrosis, they had poor response at the end of follow-up. And this is another study, this is also a retrospective study, which was an Italian study. It included, it followed 39 patients who were having renal sarcoidosis, and all of them were treated with corticosteroids. And 50% of them showed a complete recovery at the end of 1 year. Actually, one response after 1 month of therapy actually correlated with recovery at 1 year. So people who had acute onset and who had hypercalcemia at the time of diagnosis had better recovery. And as mentioned before, as the previous study, patients who had severe interstitial fibrosis had a poor, it was a negative predictor and had poor outcomes. So the other drugs which are used for for refractory renal sarcoid, which we define as somebody who doesn't either respond to steroids or who develop relapse after tapering dose of steroids, are mainly azathioprine and mycophenolate has been used. Azathioprine can be used at a maintenance dose of 2 milligrams per kg and mycophenolate at 1 gram twice a day. And other refractory renal sarcoid can also be treated with TNF inhibitors such as Influximab, adalimumab, but the data is very limited on renal sarcoid for these patients. So prognosis is mainly dependent upon four major factors. One is serum creatinine levels at the time of diagnosis. So higher the creatinine, the chances for recovery might be less. And the next is histological type of renal sarcoidosis. If there are more granulomas, severe granulomas, then the chances for improvement might be less than non-granulomatous disease. And the degree of tubulointerstitial disease, severe tubulointerstitial disease, recovery might be less compared to people who present early on. And the most important thing is people who respond to the therapy within 1 month. So 1 month of therapy with steroids, if the response is good, that translates to long-term outcomes. So we have data, limited data on kidney transplantation again, because overall renal sarcoid is also not a common presentation. So there is one study which was done in 2010, which was published by CJ. It's also a French study where it included 18 patients who underwent renal transplant, and they followed the patients for 42 months where there was a good graft survival of 94%, but there was a good relapse, both renal and extrarenal during the course of follow-up of these patients. 27% had both renal and extrarenal, whereas 17% had only renal recurrence. So post-transplant, we have to keep in mind that it could be recurrence of the disease and not only rejection of the graft. So the take-home message is renal sarcoid is rare by itself, but it generally presents in association with other organs, mainly the pulmonary involvement, and it's a granulomatous inflammation of the renal parenchyma. Presentation mainly includes hypercalcemia, AKI, and chronic kidney disease. Diagnosis is mainly by renal biopsy, and it has to be correlated with extrarenal manifestations. And there is good response to steroids. And if any patient goes to end-stage renal disease, renal transplant can be considered as an option with close monitoring. Thank you.
Thank you, Dr. Rekha, again for a very lucid presentation. Again, emphasis on histopathological diagnosis with the background of a high index of suspicion. Again, running short of time, it's time to move to the next session. We'll take questions probably after the interesting case presentations. Next session will be on dermatological manifestations of sarcoidosis by Dr. Ashwini from AIG Hospital. In fact, dermatology, skin being the largest organ, we cannot forget about sarcoid involving the skin. And myriad of presentations, request Dr. Ashwini to go ahead with the talk.
Good afternoon, everyone. I am here to present regarding sarcoidosis of skin. Sarcoidosis is a systemic granulomatous disease characterized by formation of sarcoidal granulomas in skin and various organs. Other than skin, it involves other internal organs like lungs, lymph nodes, bones, eyes, myocardium, central nervous system, kidney, spleen, liver, parotid glands, etc. Epidemiology, 80% of the cases are seen in whites, mostly Denmark and Sweden, and African descents of US. It is peak age group involvement is in the 30s. Women are more commonly involved than men. Symptoms, signs and symptoms. It may remain asymptomatic or it may present with prodromal symptoms along with some skin manifestation in the initial stage. It is a great mimicker as it involves all the primary morphologies of skin like papules, macules, plaques, nodules, etc. Two categories. It is broadly divided into two categories, specific and non-specific. Specific means the histopathologically it is a sarcoidal granuloma, or non-specific means it is a reactive pattern or no granulomas. Clinical features. Coming to clinical features, most common presentation will be papular form, which is predominantly seen over the face, periorbital and perioral areas. And the color of the lesions will be yellowish to violaceous. Violaceous as seen in lupus pernio. On diascopy, that is on pressure with a glass slide, there may be yellowish brown discoloration, which is also called apple jelly appearance. It is not diagnostic for sarcoidosis. It is also seen in lupus vulgaris or in granuloma annulare also. Other than papular forms, small nodular types can be seen over the extensor aspects of the limbs, and large nodules can be seen predominantly on the face, hands and trunks. These are the photographs showing papular lesions over the periorbital and perioral areas. These are the papules coalescence to form plaques. And this is the diascopy picture upon pressure showing yellowish discoloration because of the underlying granulomas. Next, coming to the annular forms, which are rare, there may be central clearing and peripheral spreading like in tinea infections, which is most common in face, forehead and neck. Erythema nodosum, it can be a common presentation along with hilar lymphadenopathy in Lofgren syndrome with painful erythematous nodules seen over the lower limbs, shins, knees, ankles, etc. Lupus pernio, it is rare presentation, commonly seen in elderly age group, but it causes deformities, so it should be differentiated. It can be, it is a misnomer because it is not related to lupus vulgaris or to any cold injury. It is commonly seen in older patients. It presents with infiltrated violaceous nodules and plaques over the tips of the nose, cheeks, ears, fingers, hands and toes. On ear lobes, it can be progressive to form massive, which are also called turkey ears. Plaques and subcutaneous nodules may accompany lupus pernio. There is a risk of nasal septum damage and perforation. These are the lesions of an elderly female showing lesions of lupus pernio mimicking rosacea. And this is an infiltrated plaque over the nose. Lupus pernio of the digits. Maculopapular and erythematous forms. These are transient prodromal maculopapular eruptions seen in the early stages of sarcoid. These are ill-defined patches or mildly scaly, and it may be associated with parotid swelling and hepatosplenomegaly. These are the confluent scaly macules. Nodular forms, which are more than 5 mm in size, and they are red or yellowish red or may be violaceous to purple. At the center there may be a depression or changes like telangiectasia or atrophic patches, which are predominantly seen over the proximal limbs, trunk and face. These are the nodular lesions seen over the upper back. These are the micropapillar lesions of sarcoidosis mimicking folliculitis. And these are the block type of lesions seen over the middle of the upper back. Coming to scar sarcoidosis, this scar forming sarcoid reactivating into sarcoidosis may be a cutaneous clue of diagnosis. There may be, this may form sarcoid after eruptions of erythema nodosum or along with association with pulmonary changes or systemic disease, or after inoculation like vaccination or tattooing, etc. Subcutaneous sarcoidosis. Rarely it can present over the digits like tender or painless persistent nodules, most often on the extremities in a middle-aged woman. There can be association with underlying cystic bone lesions. On histopathology, there may be the nodular granulomas inside in the septum or in the fat lobules replacing the lobules. Unusual forms of sarcoidosis are alopecia, atrophic forms, erythrodermic sarcoidosis, hypopigmentation, ichthyosiform sarcoidosis. These are the hypopigmented patches and the erythrodermic form of sarcoidosis. Lichenoid forms are also seen, and psoriasiform, pseudotumoral forms are also seen. Coming to mucosal involvement, nasals in mucosa can be involved in lupus pernio cases, which affects the nasal sinuses, which can cause epistaxis, nasal crusting, and even sinus bone involvement. Nodules can also be seen over the tongue and buccal mucosa, palate, larynx, and tongue. Muculitz syndrome, which involves mucosal lesions along with glands like bilateral lacrimal glands, bilateral parotid, sublingual, and submaxillary glands, salivary glands.
Ashwin, you have 1 more minute to go. 1 minute you have to.
Nail involvement is also seen, but is very rare. Nail plate discoloration and nail matrix can also be involved. These are the various syndromes seen in sarcoid associated with sarcoidosis, and the investigations are to screen for screening tuberculosis and other systemic involvements. Along with that, skin biopsy, mucosal biopsy, and cavium test, histopathology. Coming to histopathology, aggregates of granulomas are seen in the lower dermis, and these are the circumscribed granulomas, and the asteroid body seen in the center of the granuloma. And the cavium test is an intradermal test to diagnose sarcoidosis. And treatment is same as the other systemic diseases. But other than that, topical and intralesional corticosteroids, topical tacrolimus, phototherapy, and laser treatments are different in skin. These are the various manifestations. Common of them are the papillar, block, lupus pernio, scar sarcoidosis, and others are uncommon, are annular, lichenoid, atrophic, etc. Rare are alopecia, nail involvement, erythrodermic, ichthyodermic forms, and non-specific and common is erythema nodosum.
Thank you very much. I think all types of phenotypes have been described here, and fortunately, as a dermatologist, you are well placed as compared to others. We don't see, whereas you can see, you can follow till the end, till it heals or not heals. So you have a great advantage of a biopsy, when the moment you suspect something like a tuberculosis, we often do for tuberculosis. Thank you very much. Thank you. With this, we'll go on to the interesting cases. Dr. Madhuri will tell who is going to be the first one.
We are now happy to announce that we have a few interesting case presentations. We thank the speakers for their participation. First, I would like to invite Dr. Sri Harsha, DNB Resident Rheumatology from KIMS, to start off with his first case. He will be followed by Dr. Ramya Pulugari, and then General Medicine Resident, Dr. Sunandini from Care Hospitals, will be presenting their cases in serial order.
Minutes each.
Good afternoon, one and all. This is Dr. Sri Harsha, DNB resident in the Department of Rheumatology, KIMS, Secunderabad. I'm going to discuss a case with sarcoidosis with neurological involvement. This is about a 61-year-old female, a lawyer by occupation from Hyderabad, presented with complaints of fever for 2 months, joint pains for 2 months, a band-like sensation over the chest for the last 2 months, dryness of the mouth and eyes for 1 month, and painful red nodules over the legs and forearms for the last 15 days. To start with, the fever was low grade with 1 to 2 spikes per day, intermittent in nature and not associated with chills and rigor. The joint pains had an acute onset involving both wrists and ankles, later involving the small joints of the hands, associated with early morning stiffness of more than an hour, but there was no history of joint swellings. She also had a band-like tightness over the chest since the last 2 months, which was insidious in onset and was gradually progressive. She described it as constricting in nature with reduced sensation over the area, where she could not feel her clothes over the chest, and also she reported that the hot and cold sensation could not be well appreciated. She had history of oral and ocular sicca, and also painful red skin nodules over the legs and forearms in the last 2 weeks, which were about 2 centimeters in size, non-pruritic, and not associated with any overlying ulcerations. By the time she presented to us, these lesions have become hyperpigmented and healed because of the use of NSAIDs. All these symptoms had happened in the background of constitutional symptoms in the form of unintentional weight loss of 5 kgs, reduced appetite, and fatigue. There was no history of proximal muscle weakness, no history of neck pain, back pain, or preceding trauma, no history of headache, seizures, loss of consciousness, or symptoms suggestive of cranial nerve involvement. At that point of time, she did not have any bowel and bladder incontinence. There was no shock-like sensations over the back, no tingling sensations over the extremities, no oral ulcers, skin rash, photosensitivity, or Raynaud's phenomenon, and there was no history of contact with TB. With these symptoms, she got admitted with us, and 4 days past admission, she suddenly developed urinary frequency, urgency, and incontinence along with constipation. She also had weakness in both lower limbs with inability to walk without the assistance of at least 2 people for support. There was no weakness in the upper limbs, and there was no diurnal variation with weakness. So here we are dealing with a 61-year-old female with low-grade fever, inflammatory arthritis, sicca symptoms, erythema nodosum-like lesions, acute paraparesis with bowel and bladder involvement, and a girdle-like sensation with decreased sensation over the chest and mid-back. So probably we were thinking that we were dealing with an infectious process like TB, connective tissue diseases like SLE and Sjogren's syndrome, granulomatous inflammatory disorders like sarcoidosis, or it could be a demyelinating neurological illness like multiple sclerosis or neuromyelitis optica. The general examination was unremarkable. On the skin, there were a few tender reddish brown nodules over the bilateral shins, forearms, and arms. Joint examination revealed tenderness over the bilateral MCPs, both wrists, ankles, and elbows, but there was no evidence of deformities or joint swellings. The cardiovascular and respiratory system examination was unremarkable, and so was the abdominal examination. In the CNS examination, higher mental functions and cranial nerve examination was normal. The fundus examination was normal, and motor examination revealed decreased tone in the lower limb muscles and also weakness in the lower limb group of muscles surrounding the hip, knee, and ankle joints. The abdominal reflex was absent on both sides. While the deep tendon reflexes were present in the upper limbs, they were absent in the lower limbs. The sensory examination revealed absent touch, pain, temperature, and vibratory sensations over the anterior chest and mid-back from T4 to T6 dermatomal level, while these sensations were only reduced below the level of T6. Sacral sensation was notably absent. There was no local vertebral tenderness or gibbous deformity, nor any signs of meningeal irritation. So coming back to the problem list, we are dealing with a patient who has acute flaccid paraparesis with bowel and bladder involvement, sensory impairment with a sensory level localized to T4 level, suggestive of non-compressive myelopathy, probably acute transverse myelitis. This happened in the background of extraneurological symptoms like fever, inflammatory polyarthritis, sicca symptoms, erythema nodosum, and weight loss. Her routine biochemistries were normal. The serum calcium was 9.2, serum ACE levels were normal. Viral screening was negative, MON2 was negative, and so was the sputum AFP. Immunological workup was done. Her ANA and RF returned negative. ANA profile was negative. Anti-TS DNA by ELISA was negative, and her serum complement levels were normal. Prominent right hilum was noted on her chest X-ray. We proceeded with neurological imaging with MRI of spine and brain, in which the MRI of the spine showed punctate T2 hyperintense foci in the left hemichord at the level of D1 and a similar lesion at conus with mild enhancement in the post-contrast study. However, the brain imaging was normal, so the impression was longitudinally extensive myelitis. The CSF showed 20 cells with predominance of lymphocytes. The protein was mildly elevated. However, there were no microorganisms that grew on culture, and oligoclonal bands were negative, and so was the TB-PCR. Meanwhile, we sent for serum emoji antibodies and serum aquaporin 4 antibodies, which were negative. The VAP also returned normal. So considering the multisystem nature of her illness, we proceeded with PET-CT, which showed indeed the presence of multiple hypermetabolic pretracheal, paratracheal, hilar, and mediastinal nodes. Along with this, there was also bilateral parotoid enlargement with significant uptake. In the meantime, over the next 3 days in the ward, she continued to deteriorate neurologically with worsening motor weakness and urinary incontinence. Her repeat creatinine rose up to 2.1 and the repeat calcium rose up to 12.5. However, the repeat serum ACE levels were normal. So we proceeded with an aim of obtaining a tissue biopsy with endoscopic ultrasound guided FNAC and biopsy from the mediastinal nodes, which on cell block section showed the evidence of presence of multiple epithelial cell granulomas with lymphocytes and plasma cells. No necrotic foci were found, and so a diagnosis of granulomatous inflammation was made. Special stains like AFB stain was negative on this tissue biopsy, and so was the gene expert. So having a problem list of longitudinally extensive myelitis, erythema nodosum, sicca symptoms with parotoid involvement on imaging, constitutional features, arthritis, hypercalcemia leading to acute kidney injury, mediastinal lymphadenopathy, which on biopsy showed the presence of non-caseating epithelioid granulomas, we reached a diagnosis of sarcoidosis. She was managed with IV pulse methylprednisolone 1 gram per day for 5 days, followed which she was started on oral steroids at the rate of 1 mg per kg. IV fluids were given for acute kidney injury and hypercalcemia. By the time of discharge, the paraparesis improved and she was able to walk independently. Her renal function also normalized and she was started on weekly methotrexate. The bladder urgency slowly, steadily improved over the next 2 months. So as discussed in the previous slides, neurosarcoidosis is about 5 to 10% in prevalence, predominantly involving most commonly having cranial nerve palsies as one of the manifestations. Facial and optic nerve are the most commonly affected.
You can come back to conclusion because neurosarcoid extensive session was already over. We just come back. What is the message?
Yeah. So conclusion is the myelopathy has an unfavorable prognosis unless early aggressive therapy is initiated, and imaging should be a part of the workup.
Thank you very much. I think this appears to be one of the cases of a disseminated sarcoidosis, and ultimately the message is that you will get somewhere something to biopsy, it appears like that, by that's the only way one can diagnose histopathology.
Thank you.
I think sarcoidosis is repeatedly reminding us to connect the dots. Do not, overlook any simple skin lesions, looks like a run-of-the-mill kind of thing. So this is a classical example. If you put all of them together, I like that problem list slide which you put up. I think that makes it look very easy, but you have the patient in front of you, probably needs a little wider range of vision to come to the diagnosis. So thank you, Dr. Harsha. We'll move on to the next case.
Good afternoon. I'm Dr. Ramya, a fellowship resident, second year from KIMS Hospital, Secunderabad as well. So a difficult case to say. A 45 years old male, an electrician from Hyderabad, had complaints of low-grade fever associated with night sweats, non-productive cough, unintentional weight loss of more than 15 kgs associated with neck swellings for 14 months of duration, increased thirst, dryness of mouth, excessive fatigability for 2 years. He had past history of recurrent renal calculi requiring multiple admissions for 6 years. Prior to his visit to KIMS Hospital, he was evaluated elsewhere for the problem list of generalized lymphadenopathy, hepatosplenomegaly, anemia, thrombocytopenia, and anasarca. His CBP showed thrombocytopenia and mild anemia. His ESR was elevated, 118. His creatinine was 1.74, uric acid was 11, serum calcium was 13, and his LFT showed mild hypoalbuminemia. His ultrasound neck was suggestive of left cervical lymphadenopathy. Abdomen and pelvis showed multiple enlarged lymph nodes with altered echo texture, splenomegaly with heterogeneous echo texture, with diffuse small hypoechoic lesions, likely granulomatous etiology, and bilateral tiny renal calculi. Lymph node biopsy was attempted twice. One was of cervical lymph node and the second time was of mesenteric lymph node in right iliac fossa. Both the times, the biopsy showed granulomas, which was composed of epithelioid histiocytes, lymphocytes, and plasma cells. AFB stains being negative, gene expert MTB being negative, and fungal stains as well being negative. So he was diagnosed as tuberculosis and was on ATT from July to November 2021. In spite of on ATT, there was no significant improvement in his fever spikes and lymphadenopathy, which was persistent. In view of suspicion of malignancy, he was referred to an oncologist. Here with the oncologist, CECT abdomen was done, which suggested hepatosplenomegaly with multiple retroperitoneal, pre and para-aortic, pre and para and retrocaval lymph nodes displacing aorta and IVC. Bone marrow biopsy showed scattered with few blasts, more towards myeloid progenitor. Even this bone marrow biopsy was attempted twice, 2 months apart. Whole body PET-CT was done, which was also suggestive of hypermetabolic lymph nodes above and below the diaphragm, metabolically active mild splenomegaly and splenic and hepatic lesions, bilateral pleural effusion, and a specific active ill-defined ulcerative lesion on tongue, which was metabolically active, and they have mentioned it as likely inflammatory. So liver biopsy was attempted, and the third time he underwent lymph node biopsy. But here, there was no evidence of any granulomas or malignancy. So with the oncologist, he was conveyed by a pathologist that it all looks like MDS. So he was treated with azacitidine 2 cycles before even the cytogenetics reports were awaited. After 2 cycles of azacitidine, his flow cytometry reports have come negative. Even for advanced leukemia panel, it was negative. Now he has seen a nephrologist, and in view of AKI and hypercalcemia, he was referred to a rheumatologist to us at KIMS. On examination, he had pallor, bipedal edema, he was febrile, palpable cervical lymph nodes, hepatosplenomegaly, and bilateral decreased air entry in infraaxillary and infrascapular areas. There was mild anemia, ESR was 96, creatinine was 1.8, calcium was very much elevated, 13, his serum ACE levels were 161, LFT being normal at this point. Sherman's test was suggestive of severe dry eyes, MON2 was negative. So keeping in mind his prolonged history of lymphadenopathy, constitutional symptoms, bilateral renal calculi, and even malignancy being negative, PET-CT suggestive of lymphadenopathy, ultimately we decided to treat him as sarcoidosis. Initiated him on oral steroid 0.5 milligram per kg body weight and methotrexate 15 mg weekly. So 2 weeks later, 2 doses apart of methotrexate, he presented again with high-grade fever, polyuria, polydipsia, hematuria for 4 days. Here, his investigation showed further drop in hemoglobin from 10 to 8. There was thrombocytopenia, 52,000 of platelets. ESR was same, 112. Creatinine shooted up from 1.8 to 3.2. Uric acid was elevated, calcium being the same. LFT total, which was normal prior initiation of methotrexate, now it was hyperbilirubinemia with the total bilirubin of 11. Mild ALP elevation of 361, enzymes being normal. His fibrinogen was 428, mildly elevated, and ferritin was very high, 14,700. Here, probably we thought it could be disease activity or idiosyncratic reaction to methotrexate. So methotrexate was stopped and supportive management was given. While waiting in the ward a week apart, we re-repeated the in workup. Ultrasound abdomen was the same with hepatomegaly and mild ascites and effusion. Infective workup extensive was negative. His labs showed further rise in bilirubin and ferritin rose up again to 17,000, creatinine worsening with thrombocytopenia and anemia. And there were suspecting query macrophage activating syndrome complicating sarcoidosis. A decision was to made to treat him with solumetrol 500 mg for 3 days. He required multiple PRBC SDP transfusions. Hypercalcemia management was given rigorously. And keeping in view that he underwent 2 cycles of azacitidine and there was adequate immunosuppression by then, we had planned to choose Influximab but with a less dose, only 100 mg IV. So after a week, he was discharged on steroid 0.5 milligram per kg body weight with significant improvement in his lab parameters. Bilirubin became normal 1.24, uric acid, calcium and even ferritin dropped down to 2,830. 10 days later, again fever with chills, yellowish discoloration of eyes and skin for 4 days. There was pallor, he was febrile, tachycardia, and there was tenderness in right hypochondrium and hepatosplenomegaly. Hemoglobin further dropped to 6.2. For the first time, there was leukopenia in his reports. ESR was 80, CRP was 22, creatinine again back to 3.72, LFT bilirubin raised, but procalcitonin was elevated 10. His blood cultures were sterile, but urine culture had Candida tropicalis. Chest X-ray being normal, 2D echo good biventricular function, ultrasound abdomen the same findings. Oral steroids was changed to hydrocort 50 mg IV BD, even IVIG was given. With no improvement in leukopenia in spite of 2 doses of GCSF, filgrastim. Repeated bone marrow biopsy for the 3rd time at KIMS was done, which for the first time showed reduced cellularity, 30% cellularity. Procalcitonin rose up again from 10 to 48. In spite of high-end antibiotics and antifungals, chest X-ray had new findings of new consolidations and galactomannan was strongly positive. So we started him on voriconazole. His oxygen requirements rapidly increased. He developed an episode of GTCS. ABG was suggestive of severe metabolic acidosis. And he was placed on mechanical ventilation. And in spite of best medical efforts, we couldn't save the patient. He succumbed to his illness. Thank you. So the message here is, if the patient was directly referred from the general physician to rheumatologist, keeping in mind there were many pointers which were missed showing sarcoid was, he had recurrent renal calculi, constitutional symptoms, lymphadenopathy, calcium was always high twice. I don't know why ACE was not repeated, but whatever, with lot of efforts we couldn't save the patient. We feel bad for him. Thank you.
Thank you very much. And then, but first of all, I don't think there is any hepatic is a primary thing here. You know, liver biopsy was normal.
Yes, sir.
And his ALT, AST have always been normal. Only bilirubin. I think subsequent involvement of the liver is because of HLS or other fungal other things,
Probably.
not because of a primary involvement of the liver. But it's a very, very interesting. I think you must have undergone a lot of ups and downs during your triglycerides. What was the triglycerides?
It was 326.
Yeah, I think typical case, multiple therapeutic and diagnostic dilemmas at different stages. Yeah, but I think by the time the patient came to you, you are more grappling with the complications of of the problems of secondary infection and stuff like that. I think there was extensive discussion yesterday about balance between immunosuppression for the disease and opportunistic infections. Thank you.
Thank you.
Good afternoon, everybody. I am Dr. Sunandini, Junior Resident, Department of General Medicine, on behalf of Department of Neurology. Today, I am going to be presenting an interesting case discussion on sarcoidosis. So here is the story of a 32-year-old male who presented to us with complaints of headache since 1 year, dizziness and unsteadiness of gait for 7 days duration. The history actually dates long. It's a 1 year long story. The patient actually had presented to us in July of 2022, but his story dates back to June 2021 when all his symptoms started. He actually had complaints of right eye painless vision loss, for which he had considered going to a neurologist where he was examined and MRI brain was done, which showed right optic neuritis, and it was managed with steroids and symptoms had resolved. In September of 2021, 4 months later, the patient had again presented, but this time with complaints of right eye ptosis associated with headache, which was right-sided, temporal and periorbital, initially intermittent for the starting 10 months, but for since past 1 month, it had become continuous. It was a dull aching pain with no radiation, no photophonophobia or vomitings. His right eye ptosis and headache was then diagnosed to be ophthalmoplegic migraine, and it was treated with pain medications and anti-migraine therapy. Soon, in early of February 2022, his disease relapsed, and then this time he had presented with left eye painless vision loss, which again was treated with steroid, but later on discontinued after resolution of his symptoms. In April of 2022, this patient had presented with left eye ptosis, but this time, because of this relapsing disease, had decided not to go and seek any treatment. To us, he has presented in July of 2022 with complaints of left eye ptosis, which was persistent, headache, and unsteadiness of gait of 7 days duration. On examination and further history, there was no history suggestive of any seizures, fever, any constitutional symptoms. His systemic examination was also normal, and no significant past medical or surgical history. His personal history was not suggestive of any alcoholism or smoking. On physical examination, he was a well-built and nourished individual, conscious, cooperative. His GCS was 15/15. Vitals were stable. He had no pallor, icterus, cyanosis, or lymphadenopathy. His other system examination was normal, including the skin and eyes. Cranial nerve examination showed that on extraocular movements, there was a horizontal nystagmus with torsional component, the fast beating component to right side. Pupils were bilaterally normal size reactive to light, no facial asymmetry, but right-sided vestibular signs were present as star walk and march test was positive. Motor system examination was normal and sensory system examination was also normal. On cerebellar system examination, his tandem gait was impaired as he was persistently swaying to his right side. Meningeal signs were absent. Summarizing all of the issues, our patient actually had a relapsing neurological deficit, bilateral optic neuritis, which initially started with right eye involvement and later on involving the left eye as well. He had partial third nerve palsy, which was also bilateral. He had right vestibular pathology as he was having unsteadiness of gait, which was also tested positive with vestibular testis. Then it was a steroid responsive disease early in the course of illness, and there was a localized headache. With all these background history, we had further started investigating him. The basic hemogram, RFT and LFT were normal. His ANA profile as well as ANA screening along with serum IgG4 was normal. CSF evaluation was also normal. The likely possibilities at this stage were a IgG4 related disease, neurolymphomatosis, connective tissue disease. Because India is an endemic country and we have such a prevalence of tuberculosis, even that was considered for one of the differential diagnoses. Sarcoidosis and carcinomatous meningitis. But due to carcinomatous meningitis comes way down the list because of the indolent course and long duration of his history. We decided to go ahead with a MRI brain plain and contrast, of which the DWI axial cuts, the flare axial and T1 axial images were normal. But on flare contrast imaging, there were bilateral patchy dural thickening which were seen, and they were better seen on a T1 contrast where we can see that there was a bilateral thickening of the dura mater both sides, but much more better appreciated on the right side. The MRI spine, including the cervical spine, dorsal spine and the lumbar spine were normal. The whole body PET CT was also done, but it was done at an outside center and we could not procure the images. But the reports were suggestive of bilateral tiny hilar lymphadenopathy. Increased uptake was seen. And they were actually so tiny that they could not be biopsied. And hence we went ahead with a dural biopsy. The dural biopsy, in the first low power image, we can see a non-caseous granuloma surrounded by meningoepithelial cells. The second and the third image show the predominance of epithelioid cells, and the fourth image shows calcification. The ZN staining showed no AFB. In the second and third image, there was no plasmocytosis or fibrosis as well. And the last image with the GMS staining shows no fungal elements. So further in the course of this disease, we had decided that this patient has to be treated with oral steroids. We had started him on prednisolone, 0.75 mg per kg body weight, and on weekly methotrexate. Steroids had been tapered slowly and then methotrexate was continued. Patient's symptoms had resolved by this time and is still under follow-up with us. So the take-home message is that neurosarcoidosis should be considered in differential diagnosis when pachymeninges are involved and in a scenario where multiple cranial nerve palsies are also one of the presentations. Thank you.
Thank you, Dr. Ramya. Very interesting, again, challenging case, and I should congratulate the primary consultant to have taken up the challenge of a dural biopsy to establish a diagnosis. And since this patient already had received steroids earlier, how long do you plan to give the steroids? Because had multiple relapsing, that's one thing you need to. Any comment from Dr. Murli?
Just 3-4 days ago, sir, we were actually tapering the steroids now. Patient was doing well, but unfortunately he lost hearing in his right ear. That was not very obvious at the time of the initial presentation, but there were no relapses.
Thank you.
Thank you.
I think we have to, people are thinking, we have to go into the proteomics, all the omics, that's the only way for further for making a diagnosis. It appears like that. Otherwise, high index of suspicion and histopathology of any targeted possible lesion ultimately is going to. Another is, of course, the stress hormone always comes in to help with the distressed physician. Thank you very much.
I have the present duty to distribute certificates to our case presenters. I request Dr. Narasimhan to give away the certificate.
you again to all our speakers, especially Professor P.N. Rao sir and Dr. Dinakar. With this, we conclude the pre-lunch session and the multidisciplinary part. We'll have a short lunch break and we will resume our sessions at 2 p.m. And the topic for that will be TB versus sarcoid. Please join us at 2 o'clock. Thank you, everyone. Lunch is being served just outside. Please join us for lunch.
Friends, if we could assemble back in the hall. I didn't notice this. This is probably one of the most important million-dollar question, paucibacillary tuberculosis with exuberant reaction versus tuberculosis. So unfortunately, it has come as a postprandial state. I think, Praveen, you need to work hard to keep the whole group awake. And we'll get started with the first talk by Dr. Professor Alladi Mohan. He unfortunately had a tragedy in the family and he is not able to join us in person. And we'll have his talk. And Dr. Vikas Agarwal should be joining us. And has he joined?
Yeah, I'm very much here.
Oh, Dr. Agarwal, thank you so much. I didn't see you. I am sorry. Welcome, and we miss you. We should have been here in person. Nevertheless, welcome to AIG, and we'll get started with the first talk by Dr. Professor Alladi Mohan.
Yeah.
The way it has been structured is we have tuberculosis versus sarcoidosis. What are the problems as faced by a pulmonologist than a cardiologist? So different perspectives. Can you play Dr. Mohan's talk first?
Very good afternoon, ladies and gentlemen. I am Alladi Mohan. I am from Tirupati. Today I will be presenting the pulmonary perspective in the TB versus sarcoidosis debate. I have not received any funding for this talk and I have no conflicts of interest to declare. The debate of TB versus sarcoidosis has been ongoing for several decades. Experts have argued whether these two constitute being the same disease with different manifestations, or these are actually different diseases with similar manifestations, or the TB sarcoid conundrum is a coincidence, coexistence, or a myth. In the next 15 minutes or so allocated to me, I will take you through the differentiation of TB from sarcoid or sarcoid from TB from the epidemiological, clinical, imaging, histopathological, cytopathological, and so on methods. If you look at the Global TB Report 2021, which is the latest, the new one is yet to come out in 2022, you would obviously see that India is a high TB burden country. If you look at the world map towards your left hand side, India is represented by the dark close circle, which indicates the proportion of patients with sarcoidosis is less than 20 per 100,000 population. This is same for several other parts of the world, wherein wherever TB is widely prevalent, sarcoidosis is relatively uncommon in the documentation from there. Whether it is a misdiagnosis or lack of awareness and non-reporting, or whether it is really a low occurrence of sarcoidosis, again is a matter of debate. But broadly speaking, where TB is highly prevalent, sarcoidosis is not that commonly evident. If you look at the clinical presentation of sarcoidosis, sarcoidosis is predominantly a disease of adults and it seldom seems to affect children. Whereas tuberculosis affects all age groups. In India, childhood sarcoidosis is 2% or less in the various series reported from India. The clinical presentation of sarcoidosis in India is late in onset by nearly a decade, and contrary to the observations from the West, a male preponderance has been noted. Such age of onset or gender preponderance is not evident in tuberculosis. If you look at the various manifestations of sarcoidosis, as has been shown in this significantly important publication, which includes several of the series that have been published from India, it is evident that sarcoidosis involves all the body systems, as does TB. If you look at the involvement of TB by organ system in HIV seropositive and HIV seronegative individuals, it would be obvious that among the HIV seropositive individuals, the pulmonary involvement is seen in about 30%, whereas in HIV seronegative individuals, the involvement is to the tune of 80%. But if you look at the site of involvement in sarcoidosis, pulmonary involvement is the most common site which is involved, seen in almost 90% of the patients. The typical pulmonary manifestations include breathlessness, cough, which is often dry, chest pain, hemoptysis, evidence of clubbing or chest signs, seasonal breathlessness with wheezing or dry cough, mimicking bronchial asthma, and with evidence of reversible airflow obstruction in response to bronchodilator therapy has been documented in pulmonary sarcoidosis. There are some uncommon manifestations of thoracic sarcoidosis in various observations reported from India, including our publication. If you look at these manifestations, they include superior vena caval obstruction, transient paralysis of the phrenic nerve and recurrent laryngeal nerves, occurrence of chronic respiratory failure, narrowing of the main bronchi, a fixed upper airways obstruction, a clinical presentation mimicking bronchial asthma with seasonal exacerbations like I have described earlier, pleural effusion, nodules, and pneumothorax, which may be bilateral, recurrent, sequential, or concurrent. And bullous lung disease has also been described in pulmonary sarcoidosis. These manifestations are relatively uncommon, other than pleural effusion, pneumothorax, and these are seen in TB also. The odd uncommon manifestations seem unique for sarcoidosis. It is important to consider the evidence of TB infection. In olden days, it used to be referred to as latent TB infection. For the last year or so, it has been referred to as TBI, not LTBI, but TBI, TB infection, because an infection cannot remain latent till kingdom comes. The technology available to look at TB infection today are twofold. One is the tuberculin skin test. The other is the interferon gamma release assays. A huge body of data exists with regard to tuberculin skin test in patients with sarcoidosis. So I will be focusing more on this. The IGRA's performance in sarcoidosis is still being investigated. Since there is no difference in the yield as far as a high TB burden country like India is concerned between a tuberculin skin test and the IGRA, except for the cost, I will deal with the utility of the TST. The published data from high sarcoid burden countries suggest that tuberculin energy, that is a negative tuberculin skin test, is common in patients with sarcoidosis. In areas where TB is highly endemic like India, patients with sarcoidosis can develop TB disease. A positive TST in a patient suspected to suffer from sarcoidosis should therefore be an absolute indication for a thorough workup for active TB disease. Where are the data for this? This is Professor S.K. Sharma's paper on the study of patients with sarcoidosis alone vis-a-vis those with sarcoidosis and active TB. This consisted of 125 individuals with sarcoidosis alone, almost equal distribution of stage 1, stage 2 sarcoid. What are the stages? I will enumerate a little later. The site of biopsy where the tissue diagnosis was established is listed here. And when you look at the parameters for TST greater than or equal to 10 mm, in all the patients put together, the sensitivity was 18.8%, specificity was 97.6%, with some variation across the stages of sarcoidosis, stage 1, stage 2. Now, this is the publication. What is the take-home message? As such, while a TST negative result in the general population is a sensitive test for sarcoid, because in India, an immunocompetent adult individual is tuberculin skin test positive. If an immunocompetent adult in India with no other reasons for tuberculin allergy tests negative on a tuberculin skin test, which is usually done by Mantoux method, this is a strong pointer to sarcoidosis as a differential diagnosis. A positive tuberculin skin test in a patient with sarcoidosis is a specific indication for workup for active TB. The diagnosis of sarcoidosis is picked up with some other investigations. Also, one is the serum ACE levels in pulmonary sarcoid. Though not always serum ACE levels are elevated, but caution that should be kept in mind is differences in the protocols followed, lack of uniform laboratory standards for assessing the serum angiotensin converting enzyme levels are all caveats in using this as a tool to label an individual as sarcoid and not TB. Gallium-67 scanning has been helpful in some situations, like in this patient. If you see the gallium-67 scanning, this is the classical panda sign, but you see the arrows which indicate involvement of lacrimal gland. If you have lymph node enlargement with increased uptake on gallium-67 scanning with lacrimal gland involvement, lacrimal gland involvement is not at all common in TB, and this favors the diagnosis of sarcoidosis. When you look at the imaging in the diagnosis of sarcoidosis, these upper panel chest X-rays look identical. There is a miliary pattern. In the panel to your left side, you have a intrathoracic lymph node enlargement, which is marked by an arrow, and an image-guided lymph node biopsy confirm the diagnosis of sarcoidosis. In this patient, the intrathoracic lymph nodes were not widely or easily accessible, nor was there evidence of peripheral lymphadenopathy, and here the bone marrow biopsy suggested the diagnosis of miliarity. If you look little more closer, The intrathoracic lymph node enlargement in sarcoidosis is typically bilateral, bihilar, symmetrical, and then there is smooth, discrete, solid-looking lymph nodes. The lymph nodes of TB are asymmetrical. They are large, can be conglomerate with central areas of hypodensity, indicating caseation necrosis. Extrathoracic lymph node enlargement can be seen in any body site in up to 10 to 15% of patients. Sarcoidosis, this can yield the diagnosis in these patients. The involvement of cervical and axillary is common in. If we do a high resolution scan of the lungs, there is peribronchovascular distribution of the lesions, which is also called lymphangitic distribution. There is a random distribution with a tree in bud appearance in tuberculosis. So, which procedure will yield the diagnosis in favor of sarcoidosis? The bronchoscopic procedures, transbronchial lung biopsy, transbronchial needle aspiration, bronchoalveolar lavage and the lavage fluid examination, video-assisted thoracoscopic biopsy and sampling of the lung and lymph nodes, and available peripheral lymph node biopsy, CT-guided intrathoracic lymph node biopsy, all these, and bone marrow biopsy. For example, these yield tissue for testing. In sarcoidosis, as described earlier, the lesions are lymphangitic in distribution, that is along the peribronchovascular bundle. So the yield is higher with a transbronchial lung biopsy. In addition to the conventional cytopathology and histopathology, today there is a rule-in test, not a rule-in test for sarcoid, rule-in test for TB, which is expert MTB or the gene expert. On histopathology, we have found that the important differentiating feature between the TB granuloma and sarcoid granuloma is important to discern with. In TB, the granulomas are classically necrotizing or caseating. In sarcoidosis, the granulomas are classically non-necrotizing or non-caseating. However, if you have seen enough patients, it is fairly common to have TB granulomas without caseation and sarcoid granulomas with caseation. How do we go about that? We found in our experience, this is always told by Professor Sharma and Professor Siddharth Datta Gupta, former head of pathology, All India Institute of Medical Sciences, New Delhi, that if we do reticulin staining, it is pretty much useful practically to distinguish a TB granuloma from a sarcoid granuloma. TB granulomas are reticulin poor, whereas sarcoid granulomas are reticulin rich. It is not proof of the pudding, but practically in real life, it is a very useful tool which we have found in our practice over the last 3 decades. There have been some studies which evaluated the role of expert MTB risk in differentiating TB from sarcoid in patients with mediastinal lymphadenopathy who underwent the EBUS and transbronchial needle aspiration. These data suggest that if you have a composite battery of a positive expert MTB result, a positive TST with an induration of 10 mm or more, or the presence of a heterogeneous echo texture or coagulation necrosis sign on imaging, the sensitivity is above 80%, specificity is above 70%, with a good positive and negative predictive values differentiate tuberculosis from sarcoidosis. In another study, the sonographic characteristics of the lymph nodes on endobronchial ultrasonography were evaluated in differentiating TB from sarcoidosis. It was observed that a heterogeneous echo texture or a coagulation necrosis sign and a positive TST together has a sensitivity around 43%, good specificity of 98%, together with a decent positive and negative predictive values in differentiating TB from sarcoidosis. So there is also some work going on using the NGS for the next generation sequencing. This recent publication has shown that using a depth more than 10 and a coverage more than 15% of the sequencing data, TB patients were identified via the next generation sequencing approach directly using the pathological biopsy specimens without any critical pre-treatment if they were treatment naive. The sensitivity and specificity and concordance of the next generation sequencing method were 82%, 96%, and 89% respectively, with a kappa value of 0.78. The study established that an improved next generation sequencing strategy for rapidly distinguishing patients with TB from those with sarcoidosis has potential clinical benefits. As on date, this is a research tool, but is yet to become the standard of practice. I would like to conclude my presentation at this point in time, mentioning that it is not easy to distinguish TB from sarcoidosis. You go by whether it is a high TB burden country or whether it is a high sarcoid burden country, the age group in which you are diagnosing TB or sarcoid, then the imaging, the clinical presentation with associated extra pulmonary features, because pulmonary
Dr. Mohan, is Dr. Mohan available for Q&A? If he is not available, I think we'll go on to the next speaker, who is Dr. Vijay Shekhar. May I request Professor Vikas Agarwal, who yesterday gave tremendous insights into the problems of immunosuppression in a country like India, the problems of compliance, the problems of loss of follow-up and toxicity infections. So I think we'll have his insight after we finish all the talks. Dr. Vijay Shekhar is a colleague of mine. He's a practicing electrophysiologist. He'll be talking to us about this problem from cardiologist perspective. Vijay.
Thank you, sir. Good afternoon, all. So I think we have been treated with an academic feast for almost a day of sarcoidosis. So my job here through the next 15 minutes will be to discuss about the diagnostic and therapeutic challenges with respect to cardiac manifestations of sarcoid. I think the previous speaker, Dr. Mohan sir, has given a lot of facts which has made my talk a little more easier. So I'll just start with a brief introduction of what cardiac sarcoid means. So we have been seeing that the etiology is still unclear, but in contrary to the most common organ involvement, that is the pulmonary involvement, which is seen in 90% of cases, cardiac involvement in established cases of sarcoid is seen about in 5% of cases. It may be slightly higher in probably the Japanese population, but overall, even if you take subclinical or asymptomatic cases, it is as at around somewhere between 20 to 25%. So this makes data collection with respect to cardiac sarcoid and the overlapping tuberculosis even more difficult. Even with pulmonary involvement of 90%, there is a huge data, but still we are unclear about the coexistence. And when it comes to cardiac, data is still more scant. But why is it more important? Why are we discussing cardiological aspects as a separate topic? Is because Whenever there is a cardiac involvement in an established patient with sarcoid, it carries a very poor prognosis. The morbidity, yesterday we have seen, can be as high as 90% and mortality can be as high as 30%. So the among many unknowns, the etiology remains again unknown. One of the important coexistence or how it is associated with sarcoid is Mycobacterium tuberculosis. So the previous speaker, Dr. Mohan sir, has extensively elaborated how there is so much data supporting the association of these two entities. So this is not something new. It has been known from almost 3-4 decades. And in fact, the earliest, the terminology of tuberculous sarcoidosis was provided by Scadding as early as 1970. So since then, there has been a series of case reports, data, right from epidemiological autopsy series data, various pathogenic mechanisms that link tuberculosis to sarcoid, clinical data, imaging which sir has highlighted, and again molecular analysis as well. So there is somewhere an overlap between these two entities, and most of these data are derived from extracardiac sarcoid and predominantly from pulmonary involvement. Whereas when it comes to cardiac perspective, data is really very scant. So this is one data from the Sarcoid Vascular Journal, where they looked at what is the percentage of latent TB infection. For diagnosing latent TB infection, they used the interferon gamma assay and the tuberculin skin test. And in this subset of patients, they found it was close to 7%. This is the only data that is currently available with respect to cardiac involvement in sarcoid. So to make things more clear and how important an issue is, I'll just present a small case scenario. So this is a 32-year-old male who presents with recurrent palpitations and syncope, and this is the ECG of the patient at presentation. The patient is running an incessant ventricular tachycardia. So young male, incessant tachycardia with coronary artery disease being ruled out. Cardiac sarcoid is high on the possibilities. So this patient subsequently underwent an FTG PET. Here you can see the FTG PET shows an active uptake involving the interventricular septum that seems to be the source of the ventricular tachycardia. And again, it is confirmed by the late gadolinium enhancement on the MRI. So also the patient has a significant uptake, a mediastinal lymph node that is highlighted here in the FTG PET images. And one of these lymph nodes were biopsied, and you can see a granulomatous inflammation pattern. So far it looks very straightforward. A young male with ventricular tachycardia, mediastinal lymph nodes, uptake on the myocardium, and granulomatous inflammation on the biopsy. So everything looks like cardiac sarcoid. So cardiac sarcoid now, over the few years, a lot of diagnostic criteria have evolved. The HRS criteria is there, and the Japanese criteria is there. And so coming back to our patient, so it is clear this patient has a histological diagnosis of an extracardiac sarcoid from the lymph node. The patient has presented with a ventricular tachycardia. He has significant PET uptake and also late gadolinium enhancement on MRI. So clearly this falls into a category of probable sarcoid. But now the problem comes here. So when you evaluate the patient further, there is no evidence of other organ system involvement. The blood workup is essentially normal. Serum ACE levels are again normal. Again, in patients with cardiac sarcoid, only in 10%, probably in less than 10% of patients, you have elevated serum ACE levels. So not a very reliable serological marker in patients with cardiac involvement. But now you can see that the interferon gamma assay is positive. The TST, tuberculin skin test, is positive. And then the PCR from the biopsy sample is also positive for Mycobacterium tuberculosis. Now, this leaves us with more questions than answers. Now, how will you treat this patient? Now, will you still consider this patient is only a sarcoid patient? Or what significance will you attach to the presence of evidence of tuberculosis? The TST is positive, the TB PCR is positive, the interferon gamma assay is positive. Will you consider it to be an active tuberculosis infection in this patient, or maybe a remote or a latent tuberculosis infection? Or will you just pass away saying that India is an endemic country, so this could be just an incidental finding? So what implications will this have on treating the patient? So these are the questions we have when we look at this patient. So to find out the answers, we looked at our own data from the registry of granulomatous myocarditis. It was published, it was presented at the Heart Rhythm Society recently. So for the sake of categorization and for treatment clarity, we divided patients into three important categories. On the extreme left, you can see patient with cardiac sarcoid, where they have histological diagnosis of non-caseating granulomas, but absolutely no evidence of tuberculosis. So here, once they fit into this category, they are directly treated with steroids or steroid sparing regimens. Whereas on the other end of the spectrum, you have caseating granulomas with evidence of tuberculosis, that is active tuberculosis in the form of positive TB cultures. So here this patient gets labeled as cardiac tuberculosis, and then this patient is hit with anti-tubercular therapy. But somewhere in between there is a gray area where patients have overlap features of both, and that is the entity now we are going to discuss about. So we divided this patient. We did not consider caseation and non-caseation as a differentiating factor, which I will subsequently explain why. So any patient with a granulomatous inflammation on cardiac or extracardiac biopsy and clinical features of heart failure or arrhythmias were included for the study, and they were categorized into three groups based on the definitions that were already discussed. So of the total 190 patients we had with granulomatous myocarditis, 92 were pure cardiac sarcoid, 18 were cardiac tuberculosis, and a good number of people, close to 80 patients, had overlap features of both sarcoidosis and some evidence of tuberculosis. So this is how we kind of defined these patients with these overlap features. So they fit into the criteria of cardiac sarcoid, like as in our patient, but they have evidence of a latent tuberculous infection, either in the form of a skin test positivity or a TB PCR positivity. So these were the definitions criteria that were used. Now, as we look at the results, so the pattern of latent TB in our patient, out of the 80 patients, most of them had a tuberculous skin test positivity, close to 69 out of the 80. And another 10 people had both TB PCR and TST positivity. And this again, the other observation that was really interesting was the pattern of granulomas. So here you can see an equal number of patients having caseation, that is necrosis, and a good and another 48% of patients without any necrosis. So now why does this happen is that traditionally we have been believing that sarcoid means non-caseating granulomas and TB means caseating granuloma. So it is not the inciting agent or the antigen that determines what is the outcome of the granuloma, but it is the tissue response. This again is the work that was published in 2018, where you can see that the same mycobacterial antigen, but can result something from a fibrocalcific granuloma to anywhere like a cavitatory granuloma. So it is the tissue response that determines what is the granuloma rather than the inciting agent. So that explains why our patients had both a mixture of necrosis as well as non-necrosis. So for treatment purpose, all these patients who fell into this overlap syndrome, we labeled them as cardiac tuberculosarcoid, and we treated them with this treatment regimen of a combination of ATT and steroid. The ATT was continued for a period of 6 months and the low dose steroids for a period of 3 months, after which a clinical and imaging response would be assessed, and then based upon the response, the treatment would be tapered. So what we found at the end of 6 months was these patients in this overlap, they had a good clinical response to this combination regimen of ATT and steroids. 70% had a good clinical response, and close to 80% had a good imaging response. In most cases, the imaging response was resolution of the metabolic activity in the PET scan. So what it tells us is that, in contrary to the previous publication, where close to 7% of people had latent tuberculous infection, in our study we found a significantly higher number. 42% had evidence of latent tuberculous infection, and a combination of ATT plus steroids seemed to be working well in this subgroup of patients. So this good treatment outcome probably tells you that that there are two possible explanations why it worked. One is like any other latent tuberculous infection, when you start the patient on immunosuppressants, there could be a flare of the underlying tuberculosis. And when you give an ATT cover, there is no flare, and hence this patient responds better. The other possibility is that mycobacterial antigens per se are the inciting agent which elicit this tissue response that has been previously described. Like they go through this phase of antigen presenting cells, macrophages, and this polarized Th1 response, which results in the granuloma formation. So there are two ways of looking at it. We still don't have an answer why exactly the combination works, but we have seen that the treatment response works. So this leaves us at the concluding remark that this entity of this overlap syndrome, where patients have evidence of latent tuberculous infection in an established case of sarcoid, there are a lot of unknowns because they have a lot of clinical and radiological similarities, just like in pulmonary involvement patients. And how do you consider treating these patients is something that we have to look at. So there is a lot of scope to look into the etiopathogenesis, the treatment regimens, and so on. So thank you all. So thank you for your patience.
Thank you, Dr. Vijay Shekhar, for your excellent insights. I think there will be a lot of questions on this kind of overlap variant by a lot of audience here actually. We'll move on to the next talk and we'll take the questions at the end of this entire session. The next talk is by Dr. Bhavin Jankaria from Mumbai. He's a well-known radiologist from Mumbai, and he's the most common faculty in most of the radiology conferences. He speaks extensively on interstitial lung diseases. Do we have him online? So I think we'll have a pre-recorded session from Dr. Bhavin Jankaria. Can I request the AV team to start his talk?
Hi, thank you for the invitation to speak in this meeting. I'd like to thank Dr. Narasimhan and the rest of his colleagues for this invitation, and I wish you a great conference. Today's topic for me is the radiological features of tuberculosis and sarcoidosis and how to differentiate between them. So the plan is to talk about nodes, then nodes and lungs, and then the sarcoid TB overlap syndrome or the complex. Let's look at lymph nodes. The typical pattern in sarcoid is the presence of non-necrotic, bilateral, symmetric hilar and subcarinal adenopathy. If we look at the difference between sarcoid and TB, in TB we get necrotic nodes. Sarcoid is usually symmetric, TB is usually asymmetric. Necrosis is the hallmark in TB, very, very rare in sarcoid. And in long-standing cases, you may see calcification, including eggshell calcification, which is not common in TB. You just get regular coarse areas of calcification. So here is a patient with TB who has necrotic enlarged lymph nodes. Typically, we define necrosis as hypodensity in a contrast study involving more than 75% of the nodal volume. And in the correct clinical setting and in a patient above the age of 35, this is usually suggestive of tuberculosis. Sarcoid can be asymmetric. So here we have a patient who was proven to be sarcoid and has large, bulky subcarinal and hilar lymph nodes. And in fact, here your concern would be to rule out lymphoma rather than tuberculosis. This is a patient with tuberculosis, large necrotic lymph nodes rupturing into the lungs, as we see here, and the X-ray show the same thing, and that occurs in severe forms of the disease. Necrotic adenopathy is highly unusual in sarcoid, but the reverse is not true. And so when we see a patient like this who has bilateral hilar subcarinal adenopathy, non-necrotic, the question asked is, yes, this looks like sarcoid, but can this be tuberculosis? And the obvious answer is yes. Tuberculosis can present with both necrotic and non-necrotic lymphadenopathy, whereas sarcoid rarely presents with necrotic adenopathy. So the moment we see necrotic or non-necrotic adenopathy, the next step is to carefully look at the lungs. And the lungs may show associated disease that might help us clinch the diagnosis. So for example, here we have a patient with classic non-necrotic lymphadenopathy, and the patient has these periphyseal and perivascular nodules. So we see the perivascular beading here. You can see the fissural nodules on the coronal scan. The two things together give us even more confidence that this patient has sarcoid. On the other hand, we have a patient with necrotic lymphadenopathy who has clustered centrilobular nodules creating a tree and bud appearance, which is very typical of tuberculosis. And so if we look at the differences between sarcoid and TB, both of them can present with small nodules, which are fissural perivascular in sarcoid, branching centrilobular in TB. They coalesce in sarcoid, you get the tree and bud appearance in TB. The galaxy cluster reverse halo signs are common in sarcoid. They may rarely be seen with TB. Both can present with large nodules, but cavities are very rare in sarcoid, and cavities are not uncommon with tuberculosis. Ground glass can occur in patients with sarcoid, which is very rare in patients with tuberculosis. So that is the classic presentation of sarcoid with perivascular and fissural nodules with or without lymphadenopathy, depending on which stage the disease is. So here's a magnified version showing the perivascular beading. This is the same patient I showed earlier with perivascular nodularity and fissural nodules. And these are the galaxy and the cluster sign that we see here. They're coalescent nodules in different forms, described variably in 2002 and 2009. And here is the lymphadenopathy in the same patient. On the other hand, tuberculosis presents with these bronchocentric and centrilobular nodules that are branching, and which is why the tree and bud appearance. And here we have consolidation with cavitation, which again is a hallmark of tuberculosis. This is a patient who shows the galaxy and cluster signs. They're nodular here. And this, at first instance, seemed to be sarcoid, but was a sputum-positive patient with tuberculosis who then eventually improved on anti-tuberculous treatment. It's not just TB that we have to worry about when we see nodules. And so here is a snapshot of the other differentials that can simulate both sarcoid and TB. One is silicosis, where we can see these coalescent nodules of varying sizes. Miliary TB, where we see 2 to 3 millimeter sized nodules that are randomly distributed. Tropical eosinophilia, where we see ill-defined nodules along with septal thickening, again of varying sizes. Hypersensitivity pneumonitis that presents with ill-defined bronchocentric nodules carpeting the lung parenchyma. And here is tuberculosis with the tree and bud appearance. And I'll leave this on for another few seconds just so that you understand the various diseases that can superficially simulate each other. So let's say now that we've looked at the nodes, we've looked at the lungs, and we still are clueless. What do we do next? For example, in a patient like this who also does not have lung lesions, the next step is a biopsy. And while there is a lot of talk about EBIS and transbronchial, let's not forget the fact that ultrasound and CT-guided biopsies are still very efficient ways of reaching a diagnosis. As for example, in this patient who has a large right paratracheal non-necrotic lymph node, there is a lung lesion that does not look like sarcoid, looks more like TB. And using an extrapleural approach, I was able to biopsy this. It showed granulomatous disease. It was MTB positive, and the patient was treated for tuberculosis. When we have supraclavicular enlarged lymph nodes, then these can be targeted with ultrasound, and the morbidity associated with these procedures, I would assume, would be far less than other invasive procedures. Lastly, we come to fibrosis. Fibrosis in sarcoid does have a typical appearance. There's upper and mid-zone predominance and usually associated with some residue of the fissural and perivascular nodularity, as we see here. There will be volume loss. And often we see signs of an interstitial lung disease with honeycombing, traction bronchiectasis, albeit with upper and mid-zone predominance. Usually, sometimes you also have a lower lobe predominance. Sometimes we get a progressive massive fibrosis-like appearance, and here is that typical eggshell calcification that can also happen in patients with sarcoid. On the other hand, tuberculosis presents with these areas of parasecretional bronchiectasis, cavities, cystic areas, calcific lesions, and volume loss. And when we see this, as in this patient, we're quite sure that this patient has had tuberculosis in the past. In fact, the problem that often arises is if the patient becomes symptomatic, whether or not there is reactivation within these lesions, and that can be extremely difficult to discern. And the other pattern is when there's been a lot of disease, eventually the lung gets destroyed like this. And these are patterns you don't see in sarcoid in later stages, and so these become quite easy to differentiate. Another peculiar issue with sarcoid is its slow burn. Now here is a 41-year-old in 2005 who had biopsy proven sarcoid. I had biopsied this focal area of consolidation, and you can see the lymphadenopathy here, and we've had serial CTs and X-rays, but I'll just show you a couple of them here. In 2006, the patient had a regression of the lymph nodes and the nodules had partly improved. But in 2020, now the patient has presented with a fibrosing ILD that superficially looks like fibrotic hypersensitivity pneumonitis. And it's only because we knew that this patient had sarcoid and had all of these old CT scans and was following up regularly that we could make the diagnosis. This pattern of progression is very, very unusual in tuberculosis. Lastly, we know that both of them can occur together or overlap. Here is a patient who had asymmetric non-necrotic lymphadenopathy and had cardiac involvement. Biopsy showed non-caseating granulomatous disease. The patient responded to steroids, but at the same time landed up with lung disease and so contracted tuberculosis later. And we can see the stigmata of treated tuberculosis here with pleural involvement and collapse of the right upper lobe, better appreciated on the lung windows. The lungs were absolutely normal to begin with. As the sarcoid responded, the TB came up, and then eventually there were post-infectious changes as we see here. And these can be difficult. In this case, it wasn't because the pattern presented itself reasonably well, and it was easy to make the diagnosis. But there are situations where they sometimes occur together, and it can be very difficult to tease that out. So most of the times in practice, the diagnosis is straightforward. If we look at everything, the nodes, the lungs, the pattern of presentation, obviously the clinical situation, etc. Even if straightforward, we may still need to biopsy for a variety of reasons to prove the diagnosis, to get material for culture sensitivity, etc. But obviously, if you're not sure, then a biopsy is a must to get to the diagnosis. And then we can differentiate not just between TB and sarcoid, but with all the other pathologies that I've already talked about. So the idea was to talk about nodes and lungs, and the sarcoid TB complex. Many of these cases I've put up at www.ctchestreview.com. You're welcome to go and check them out. I usually post one new case every 7 to 10 days. Thank you so much for listening to me, and again, have a great meeting. And I hope to see many of you in person in the years to come. Take care. Bye-bye.
That was a very nice lecture on the radiological imaging. We often have a confusion about the pattern of involvement in the lungs and in the mediastinum. So we would go on to the next talk. The next talk would be on ocular sarcoidosis. Dr. Soumya Basu would be speaking on this. She's a senior consultant ophthalmologist at LV Prasad Hospitals, and she works in the Uvia unit of LV Prasad Hospitals. Can I request the AV team to start the talk?
Thank you for this opportunity to speak at this wonderful symposium here. Since I'm probably the only ophthalmologist speaking at this symposium, I thought let me use this opportunity to give you a brief glimpse of sarcoidosis rather than presenting a single case. I'm Soumya Basu from Ilvitsada Institute. So, sarcoidosis consists of a wide spectrum of disorders. In most places, it would account for about 30 to 60% of all cases of systemic sarcoidosis, but in places like Japan, it could be up to 94% of all systemic sarcoidosis. In general, the ocular involvement consists of bilateral granulomatous intraocular inflammation, pretty much like what happens in the rest of the body. Now, the spectrum is very wide and it involves nearly every tissue of the eye, from the eyelids to the conjunctiva, cornea, iris, lens. But here we are mostly going to talk about what is involving the uveal tract, that is the iris, the ciliary body, and the choroid. Now, here are some of the pictures that are showing ocular sarcoidosis. The first picture, you can see these nodules out here on the iris, which are very characteristic of the granulomatous inflammation in sarcoidosis. Then the picture to the right, you see these mutton fat keratic precipitates, which are again very classic of ocular sarcoidosis, though they may happen in other conditions as well. Now, this is a picture which shows choroidal nodules. You will see these faint white nodules in all across the fundus, mainly the right eye, which is on the left side of the picture, and fewer nodules in the left eye, which is on the right side picture. Now, these nodules are very faint because they are seated very deep within the choroid, and they are usually better imaged by this test called as indocyanine green angiography. So this is one of the luxuries that we ophthalmologists have in imaging the ocular tissues, especially the deep ocular tissues, by giving these dyes which stain different parts of the retina or the choroid. Now, here's another picture. You see the vitreous snowballs in the inferior vitreous cavity. These are granulomas forming within the vitreous, and on the right side, you see these very florid perivascular infiltrates, which are called as candle wax strippings in ophthalmic literature. So the challenges in the diagnosis of ocular sarcoidosis are the improbability of a biopsy diagnosis, which is the standard of care in all other forms of sarcoidosis. Because if we perform a biopsy in all the cases that I just showed you, there's a very high risk of vision loss. Also, most of these clinical signs that I discussed, they overlap with a lot of other clinical entities, in particular with tuberculosis, and that makes it very difficult in a TB endemic condition country. And then what might be described for sarcoid in one part of the world, say the United States, may not apply to India or, for example, in Japan as well. So there are variations in different populations, and I'm sure you see similar variations in systemic sarcoidosis as well. So the way we go about diagnosing sarcoid is by by drawing up some diagnostic criteria, which is a big list of conditions, mainly consisting of the clinical signs, the lab tests, and combining them together to call something as, so these are the lab tests, and you know, depending on how much of them you get, you can call them as definite ocular sarcoidosis, presumed, probable, and possible, though the relevance of this kind of a classification has gone down significantly in recent years. So in 2018, there was an attempt to revise this classification into where we included the CD4 CD8 ratio from the vitreous samples as one of the diagnostic criteria, and also included the lymphopenia in the blood and the parenchymal lung changes as criteria for diagnosis of ocular sarcoidosis. Now, let's see what kind of systemic associations we ophthalmologists look for when we see a patient with ocular sarcoidosis. The most common, obviously, is the lung parenchymal involvement. More than 50% of these patients would have this, and this is data from a retrospective study across UK and New Zealand. So the other forms apart from the lung involvement are the cutaneous sarcoid, arthritis, liver involvement, neurosarcoid, and very rarely cardiac sarcoid, though I'm sure it must be very much underdiagnosed in our population because of lack of awareness about this condition. Now, to look at it from the different side is, suppose you get a patient with a biopsy-proven systemic sarcoidosis, how likely is that patient to have an ocular disease even if there are no ocular symptoms? So in this situation, it has been seen that majority of these patients do not have any ocular disease if they do not have any ocular symptoms. So there is no real need to get your patient screened for ocular disease. For example, what you might be doing in patients with JIA, where screening is of paramount importance. Here, screening is not so important, and only if they have any ocular symptoms you would want to get them tested by an ophthalmologist. Now, the last part I'm covering is the difficulty in diagnosing TB versus sarcoidosis, especially because we do not have biopsy evidence from the ocular tissues, and also the clinical signs of TB and sarcoid are very similar in the ocular tissues, which makes diagnosis very difficult. So some of the signs that are more suggestive of sarcoid as against TB are the presence of anterior uveitis alone, the presence of panuveitis, which is involving all sections of the eye, iris nodules, and what we have specifically seen as peripheral anterior synechia within the iris. So the peripheral part of the iris is stuck to the cornea, which is called as peripheral anterior synechia, and these are very characteristic of sarcoid. The very interesting finding that has been shown in one of our studies from India, published by Dr. Kalpana Babu, is that patients who have dry eyes, where the Schirmer test, which is used for measuring dry eyes, is is very, very low, those are the people who are more likely to be affected by sarcoid as against TB, because sarcoid also affects the lacrimal glands, and therefore we get these dry eyes in patients with sarcoidosis. There are other clinical findings also which are suggestive of sarcoid, like deep pigmented chorioretinal scars, candle wax drippings around the retinal vessels, like I just showed you, and the presence of optic nerve granuloma and the vitreous snowballs, which are also I showed you a little while ago. Now, these are some clinical signs which might be suggestive of TB as against sarcoidosis, and we published this a couple of years ago. You see these retinitis lesions lying over the blood vessels in figure A, where it is active, and B, where it is healed. These are very suggestive of TB in a TB endemic country when associated with retinal vasculitis. Similarly, we reported a new clinical sign which we called as focal vascular tortuosity, which is seen here in this picture and figure C, where there is tortuosity of the vessel within the area of perivascular infiltrate, which is again suggestive of TB. And again, occlusive vasculitis, as seen in figure E and F, are also suggestive of tuberculosis as against sarcoidosis. So the last thing is about elevated ESR, which was seen more commonly in sarcoid, and of course the negative Montu test, which we see more often in sarcoid, but we do have several patients with ocular sarcoidosis who test positive for the Monto test as well. Right. So these are the last points, and these are very familiar to all of you: mediastinal lymphadenopathy, pulmonary nodules, fissure nodules, all of which are very suggestive of sarcoidosis as against TB. So this is how we go about making our diagnosis of ocular sarcoid, since we do not have the evidence of biopsy from the ocular tissues. Last point about drug-induced sarcoidosis. So uveitis may be a presenting symptom with several drugs such as etanercept, then the hepatitis C treatment and immune checkpoint inhibitors, and many of the clinical signs may mimic those of sarcoidosis, so we need to be a bit aware about that. To conclude, sarcoid in the eye has a wide range of ocular manifestations. We work by using diagnostic criteria, and these are evolving over time since we do not have a biopsy diagnosis. There are ocular signs which will help you to distinguish between TB and sarcoid, but there is limited role of screening sarcoid patients, especially if they do not have any ocular symptoms. Thank you again for your attention.
So that's an important point actually. Often in the hope of finding some ocular findings, even though the patient is asymptomatic, we often refer these patients for ocular screening. From his talk, it's very clear that only if the patient is symptomatic, then refer them for screening of ocular involvement. Or else, suppose if you have a difficult case where you're not able to make a diagnosis, maybe screening might give you some. That is one thing clinically we found useful. We'll go on to the next talk. The next talk, I have the pleasure of introducing Dr. Praveen, who's an infectious disease specialist at AIG. He has done his internal medicine and infectious disease super specialty at All India Institute of Medical Sciences and has joined us pretty recently. We have the pleasure of interacting with him every day. He is quite knowledgeable. With this in mind, I would request Dr. Praveen to stick on to time, because I know that if you give him a topic, he would go on extensively.
Thank you. Sorry. Thank you, sir. Very good afternoon. So this is how it is. ID will come at the last, even if you have a dilemma of tuberculosis and sarcoidosis. And you can see that most of the multidisciplinary teams don't have ID. Okay. So I have been given a humongous task of differentiating TB from sarcoid within 15 minutes, which is not possible. But what I have observed is for the past 2 days, we are discussing the same thing, whether it is TB or sarcoid. So I don't want to be really sounding dogmatic. At the end, I'm going to tell you that in some cases, at least, we won't be able to differentiate whether it is TB or sarcoid, whether it is an overlap. But I will take you through some of the pointers which will actually help us in actually deciding treatment, because empirically giving ATT is also not safe. At the same time, you cannot treat anything empirically with immunosuppressants. So at the outline, I'll be discussing some of the clinical pointers, and also I discuss a little bit about what is latent TB and why it is difficult, because they share the same clinical, radiological, histopathological findings. And at the end of the day, our microbiological diagnosis of tuberculosis is not perfect. We are going to miss at least 40% of the cases, irrespective of what the test you are going to do, especially in extrapulmonary TB. Another thing is treatment of sarcoidosis can worsen TB, that we know. If you are giving immunosuppressants in a patient with TB, he will worsen. But at the same time, treatment of TB sometimes can lead to worsening of sarcoidosis because of the enzyme interaction. You can see that in UpToDate, you can see that up to 80% of prednisolone can be knocked out by rifampicin. So if you are treating latent tuberculosis in patient with sarcoid with HR regimen, that is including rifampicin, be a little cautious about the doses of steroids you are using. So there are three possibilities always when you have the confusion of TB versus sarcoid. Either it is TB or it is sarcoid, or it is the overlap of TB or sarcoid. And I hope that it is not some lymphoma and histoplasmosis. Okay. So in some cases, it is very likely to be TB. These are the cases where you should not be considering sarcoidosis upfront. Example, the background. Look at the background of a patient. If someone is HIV positive, presenting with whether caseating or non-caseating granulomas, presenting first time with a CD4 of 20 or 30, I won't be thinking about sarcoidosis. At the same time, someone is solid organ transplantation, already on immunosuppression, where he is developing new onset of symptoms. So this is unlikely to be sarcoidosis. The case of rheumatoid arthritis on tofacitinib. Tofacitinib is known to, we have seen that it is used as a third line treatment for sarcoid, right? So someone developing a granuloma, probably it is not sarcoid. But at the same time, we have to be a little bit careful. There are some of the drugs which can precipitate sarcoidosis. For example, we used to use a lot of interferons for the treatment of hepatitis, where patient used to have sarcoid-like granulomas. There are some reports of anti-TNF precipitating sarcoidosis, which is very crazy. And in patients with HIV, when you are treating, patient can have iris-like reaction, where you might see a sarcoid-like granulomas, new onset. And at the same time, the new chemotherapeutic agents like PD-1 or PD-L1 blockers, they are very well known to cause a sarcoid-like granulomas. Some of the clinical features are little bit rare. I'm not saying that they are not possible, because we are discussing about the rare manifestations of sarcoid for the past one day. We might think it's very common, but most of the cases, if patient is presenting with effusions, little unlikely to be sarcoid. And if the patient is having only isolated involvement of peritoneum, it is very, very rarely reported in the sarcoid. And even in the GI involvement, the sarcoid tends to involve little above and below the stomach along with stomach. So that is duodenum, esophagus, stomach. But if you are seeing something like ileal thickening or colonic involvement, it is less likely to be sarcoid. But the problem there is IBD versus tuberculosis. So we have IBD versus tuberculosis, lymphoma versus tuberculosis, and everything versus tuberculosis, right? So TB can cause everything except pregnancy. So that is something which we have to remember. So if you are getting necrotizing granulomas in histopathology, again, it is more towards tuberculosis. We have seen one of the reports shown by Dr. Karan Madansa that 15% of sarcoidosis patients also have necrotizing granulomas, but I am sure that all of them have been treated for TB as well. So if you see a case of TB versus sarcoid and you thought it is probably TB, but you have sarcoid in your background and you started treating for TB and the patient is not responding. So the immediate thought you get is probably it is sarcoid, I was treating like TB, and change the diagnosis. Now the problem is, you can see the NDRS India 2022 report. Approximately 10% of cases are MDR, 7% are INH monoresistance, and even in MDR patients, 20% are fluoroquinolone resistance. And 2 to 20%, depending upon the host, sometimes it's up to 50% of TB cases will develop iris. For example, a cardiac TB diagnosed with a culture positive tuberculosis, then you started him on ATT, he might worsen at the end of 1 or 2 months because of iris, right? So any TB that is not responding to treatment, don't jump into the conclusion that it could be sarcoid. There are 100 other reasons why a TB might not respond. So that is the reason why when we are evaluating, it is the first presentation of the patient where you have to be very, very sure what you are treating is TB. Can you explore sarcoidosis in patients with TB? Not possible. Some of the clinical, radiological, and as well as histopathological findings will tell you that it is sarcoidosis. Our radiologists are good. Sometimes our pulmonologists will have 1, 2, 3 diagnoses of sarcoid, and fourth will be probably TB. So these are the patients where we are a little bit sure about sarcoidosis, but again, we want to rule out latent TB. Now, it is very important to understand what is latent TB. Latent TB is not a distant immunological memory of past TB infection. Latent TB is an active TB infection. You have an active AFB inside your body which is living, which is trying to proliferate, but your immunity is able to control that. So you have active TB bacilli inside and you can actually treat latent TB. What we give is not prophylaxis for latent TB, it is the treatment of latent TB. That is exactly why the term latent TB is changed into tuberculosis infection, right? So now you wanted to know whether this latent TB can get reactivated because of whatever immunosuppression we are giving. Then you wanted to do a test for latent tuberculosis, that is either TST as well as IGRA. As Dr. Alladi Mohan sir has already mentioned that IGRA is not validated particularly in sarcoidosis, but you see, if you see the data from other immunological disorders like IBD, or rheumatological disorders, where IGRA has slight advantage of TB in few of the conditions. Okay, so there are 2 types of commercially available IGRA. One is TB quantiferon gold plus, which is the 4th generation of TB quantiferon gold, and you have TB spot where you can get 3 different results. One is positive, one is negative, and third one is indeterminate. When it is indeterminate, probably you have to repeat the test. Again, if it is indeterminate, take a clinical decision, right? So there are some advantages of IGRA. If the patient is exposed to recently exposed to BCG, IGRA will be more specific, and there is no cross reactivity with most of the NTMs except few of the exceptions like Mycobacterium marinum, Kansasi, and Sulgai. And the results are a little bit fast. You need a single visit. Patient don't have to come after 48 hours, and there is no inter-individual variations. What happens is most of the times when you are asking for a MON2 test, the nurse might give more than 0.1 ml, and you see a giant MON2 reaction, and you'll be thinking it is TB. Now the thing is, once you have a case of sarcoidosis, everything is said, but you got a MON2 test that is positive. The question is whether it is TB or it is latent TB. Latent TB you only treat with 1 or 2 drugs. That is either INH or INH plus rifampicin and rifampicin if it is available, which is not available right now in India. So if the patient is sarcoid, your MON2 is positive. Now you have to know whether it is actually latent TB or active TB, which is a very, very difficult thing. What happens is, you can see that one of the study from Sharma sir et al. So the number of patients, approximately 50% of the patients who had MON2 positive had active TB. Now the problem is not treating active TB. You can easily combine ATT with steroids and treat both sarcoid and TB. But if you are very sure that it is not TB, I think it is latent TB. That is where the problem is. So if you misdiagnose the active TB as latent TB and give one of the regimens which is given for latent TB, that is INH or INH plus rifampicin, what you are going to see after 2 months is MDR tuberculosis or TB that is resistant. Now that is what I don't want. I don't want patients to treat MDR TB, which is because it is little bit difficult. There are long regimens with lot of side effects. I can quote one more paper which is a systematic review and meta-analysis from Dr. KD et al. And this is done in IBD patients. So when they are trying to give TNF inhibitors in these IBD patients, they screened everyone for latent TB, and 70% of the people subsequently had active TB. They didn't have any either MON2 or IGRA test positive, which means even though if you do a MON2 test, if it is negative, you cannot exclude a possibility of tuberculosis in your patient, because MON2 can be false negative in a lot of tuberculosis cases. Now that comes down to a single point. If you are able to diagnose the TB based on microbiological evidence, it is active TB. If you are not able to do it, then probably it is sarcoid or probably it is an overlap. Even if it is TB, you cannot exclude a possibility of sarcoid. It's a little bit confusing. But what I want to say is, when you're evaluating for TB, evaluate it properly. There are a lot of investigations which you can do for the confirmation of TB, unlike a decade before. The treatment of TB has evolved, and the investigation which we can do for TB also have evolved. So Gene Expert Ultra is of a particular interest. It is little bit different than Gene Expert, which only looks at RPOB gene. Gene Expert Ultra also looks at 2 insertion sequences, which increases the sensitivity of Gene Expert Ultra by at least 20% in extrapulmonary TB. And despite of that, you might still miss 40% of cases. But this is the test we should be doing for any evaluation of any extrapulmonary tuberculosis. So what is the bad logic? Bad logic is not sending cultures because Gene Expert is negative. See, if your Gene Expert is positive and your cultures are negative, probably it is a dead bacilli which you are picking up. That could be because of old TB or recent TB which you are already treating, which gives a lot of information. And the number of viable bacilli required for the culture to be positive are just 5, whereas your limit of detection for Gene Expert is 130 and limit of detection for Gene Expert Ultra is around 16. So the culture is again the gold standard. Always we have to send cultures. Don't do in-house TB PCRs. In-house TB PCRs are not closed systems like Gene Expert or Gene Expert Ultra. They are prone to contamination, lab contamination. They use different primers. Some of them use insertion sequences and other genes, unlike RPOB gene, which we use in Gene Expert and Gene Expert Ultra. And Gene Expert and Expert Ultra gives a very, very crucial information about the possible rifampicin resistance, which is very, very important because of 10% of our cases of TB are MDR TB. Okay. And once you have culture reports, or once you have Gene Expert report, which is positive, or AFB report, which is positive, to know about INH resistance or INH or quinolone resistance or INH or quinolone or ethinomide resistance, we have other tests like first line and second line LPS, as well as expert XDR. We are doing expert XDR in our hospital also. And once you see the report, you will have that happy tears, because you already know whether the patient will respond to your ATT regimen or not. To summarize, 50% of sarcoid cases which are TST positive are active TB. So don't treat them like a latent TB unless you're very, very sure. Which will definitely increase the risk of MDR. And good number of TB reactivated cases after treating for sarcoid or any immunosuppression, they don't have MON2 positivity or IGRA positivity to start with. So I'll make a simple flow chart where I will summarize whole thing. So if you have a sarcoid versus TB, provided histoplasma and lymphoma are out. So if it is likely TB, treat it as TB. When it is likely TB, you'll have gene expert and culture positive. If it is likely sarcoidosis, you still want to look for latent TB. And if latent TB is negative, it is sarcoidosis, treat it as sarcoidosis. If latent TB is positive, then you have to really rule out active TB, where you might consider biopsying the tissues from different sites rather than doing a single biopsy and relying on that. And most of the times we cannot differentiate, like a few of the cases which were initially presented here. In that case, it is all good to treat both TB with sarcoidosis, but still work up for TB, because it is not just TB versus sarcoid, it is also TB versus a drug-resistant TB. So different latent TB regimens, but personally I prefer INH monotherapy for 6 months rather than using INH with rifampicin. Reason, rifampicin has a lot of drug interactions. Second reason, if the patient is active TB by any chance and you are going to induce MDR. So I will be happy to lose INH only rather than losing with both INH and rifampicin. So as I said earlier, it is not possible to TB and sarcoid differentiate TB sarcoid always, but at the same time you have to involve infectious disease at the stage of workup rather than at the stage of treatment, where we cannot differentiate TB with sarcoid because finally we are ID physicians, not gene expert. Thank you.
Thank you, Dr. Praveen, for throwing a lot of insights, and we have had the fortune of listening to him a lot of times in our board meets, actually, intra-departmental discussions. He's a part of our intra-departmental discussion. For most of things, he speaks like infectious disease language, all our things, and also gives us good insights about different things. So we'll have Q&A in the next talk, after the next talk. The next talk is by Dr. Professor Amanjit Bal. She's joined us online from PGI Chandigarh, and she would be speaking on the pathology perspective. And I've had the fortune of working with her at PGI Chandigarh, and she was the one important person who has started the pulmonary pathology rounds there, and we used to have a lot of interaction during our meetings within the pulmonary pathology round. Ma'am, we are very happy to have you here. I request the AV team to start the talk.
Good afternoon all. So I'll be presenting pathologist's perspective on tuberculosis versus sarcoidosis. So as we know, both tuberculosis and sarcoidosis presents as granulomatous inflammation, and there is a long list of etiologies of granulomas in lung biopsy or any other biopsy. In addition to tuberculosis, we have other infectious agents also, and in addition to sarcoidosis, we have other non-infectious etiologies also. So whenever we evaluate the granulomas in lung biopsy, we take into account the morphology and location of granulomas. In morphology, we look whether it's necrotizing epithelial cell granulomas or non-necrotizing. And if necrosis is present, the nature of necrosis, whether it's eosinophilic granular with nuclear debris, or it's showing central neutrophilic infiltrate, which are suppurative granulomas, or the necrosis is of fibrinoid type. We also look for whether the granulomas are well-formed or ill-formed, or they are small or large granulomas. For location, we look whether they are interstitial or perilymphatic in location, or they are involving the ear space, or they are centrilobular in location, and whether they are perivascular or not. So keeping in mind these two major features, that's morphology and location, we evaluate whether the granulomas are more like infective or non-infective in etiology. Tubercular granulomas are not showing any classical location, but it has been seen that they usually involve ear space. They also involve the bronchioles whenever there is endobronchial spread, and they can also involve the blood vessel whenever they present as a scanty vasculitis in lung biopsies. The morphology of granulomas is of necrotizing epithelioid cell granulomas with multinucleated giant cells, and necrosis is eosinophilic amorphous granular with presence of nuclear debris. As these granulomas age, they become hyalinized, however, they still have a residual necrotic centers in them. This is photograph which is showing numerous epithelioid cell granulomas with multinucleated giant cells and central necrosis, and there is lot of background lymphomononuclear infiltrate in the lung parenchyma, and also these granulomas are destroying the underlying lung architecture. This is a closer view to show eosinophilic granular necrosis with nuclear debris in tubercular granuloma. Sometimes necrosis is not that obvious, so we have to look for microscopic foci of necrosis under higher magnification. For confirmation, there is a need to demonstrate microbacteria. We use Ziehl-Nielsen acid-fast stain, and some of the labs are also using auromin-rhodomin fluorescent stain, which is more sensitive in contrast to Redden stain. The bacilli are typically located at the border between the viable granuloma and necrotic central zone, and sometimes when granulomas are non-necrotizing and hyalinized, we may not find the organisms. This is example showing acid-fast bacilli in Redden stain, and this is photograph showing a single isolated bacilli in a auromin-rhodomin stain. Some of the labs are also using immunohistochemistry for demonstration of acid-fast bacilli. The antibodies against Mycobacterium tuberculosis are commercially available, and some research labs are also trying to look for acid-fast bacilli using fluorescence in situ hybridization. However, these are not commonly used in all pathology labs. Just like tuberculosis, the non-tubercular mycobacterial infections also have similar granulomas with necrotizing centers. However, and they both show presence of acid-fast bacilli, but histologically we cannot differentiate whether we are looking at Mycobacterium tuberculosis or non-tubercular mycobacteria. So in such cases, there is a need for culture examination, or there is need for polymerase chain reaction, which can be applied to formalin-fixed paraffin-embodied tissues also, because this has a therapeutic implication. This is example showing ill-formed macrophage collections within the air spaces, and when we did acid-fast bacilli, it was showing numerous acid-fast bacilli. However, we could not differentiate whether it's Mycobacterium tuberculosis or non-tubercular mycobacteria. So on polymerase chain reaction, you can differentiate whether it's M. tuberculosis or M. avium. So this case was positive for M. avium. In contrast to tubercular bacilli, for sarcoidosis, location of granulomas is important, as is the morphology of granulomas. In sarcoidosis, granulomas follow a lymphangiatic pattern, that is, they are seen along subpleural, interlobular septa, and around the bronchovascular regions. The granulomas are compact, circumscribed, non-necrotizing, composed of epithelioid cells as well as multinucleated giant cells, and these granulomas are linked by fibroblasts. So as the granulomas age or the disease progress, these granulomas become more fibrotic and hyalinized. This is photomicrograph which is showing the interstitial location of the granulomas. And here we can see these granulomas are very well circumscribed in contrast to tubercular granulomas, which had irregular boundaries, and they are present in the interstitial location, and they are seen here in the bronchovascular location also. This is the close-up view of granuloma, which is highlighting the peripheral rim of fibroblasts around each of these granulomas. So, in addition, there is a peculiar morphological feature which is known as granuloma in granuloma appearance. That means this is one large granuloma which is made up of multiple small granulomas. So, this is slightly favors, this type of morphology favors sarcoid granulomas over tubercular granulomas. Numerous types of cytoplasmic inclusion bodies have been reported in sarcoidosis, which includes asteroid bodies, Schaumann bodies, calcium oxalate crystals, and HW bodies. This is photograph which is showing asteroid body, which is just a reorganized microfilaments. When laminated calcium bodies, then we have calcium oxalate crystals, which is the most common inclusion noted in sarcoid, and then we have HW bodies, which are yellow oval bodies, which are seen in the draining lymph nodes of draining lymph nodes which are containing sarcoid-like granulomas, but none of these inclusion bodies are specific for diagnosis of sarcoidosis. So we should not base our diagnosis of sarcoid based on these inclusion bodies. These have been noted in other granulomatous inflammation also. Additional features which have been noted in sarcoid include a specific type of necrosis, which is fibrinoid necrosis. Small foci of fibrinoid necrosis can be seen in sarcoid granuloma. They can invade the blood vessels. And if we see, the background lung parenchyma does not show any inflammatory infiltrate. So there is minimal interstitial inflammation, and the background lung parenchyma appears clean as contrast to tubercle, which shows lot of inflammation. Two variants of sarcoidosis have been reported. One is nodular sarcoidosis and other is necrotizing sarcoid granulomatosis. Nodular sarcoidosis is nothing, just a confluent masses of granulomas which make it a mass-like lesion which simulates metastatic tumor. And necrotizing sarcoid granulomatosis has sarcoid-like granulomas, necrosis which varies from fibrinoid necrosis to large zones of infarct-like necrosis and presence of vasculitis. So these are photographs, which is upper photograph showing nodular sarcoidosis and the lower one which is showing necrotizing sarcoid granulomatosis, areas of necrosis and vasculitis with presence of sarcoid-like granulomas. But these two variants are extremely rare. For diagnosis of sarcoidosis, transbronchial lung biopsy is highly effective because of the location of the granulomas in perilymphatic distribution, and the yield can be up to 90% if we get 4 or 5 fragments of the lung biopsies. For necrotizing sarcoid granulomatosis, usually open lung biopsies or larger tissue segments are required. Some people are taking help of ancillary techniques for differentiating whether they are dealing with sarcoid granulomas or not, which includes reticulin stain. The sarcoid granulomas are retic rich in contrast to tubercular granulomas. CD4 and CD8 staining patterns, high CD4 counts have been noted in sarcoid granulomas. M1 and M2 macrophages, it's said that sarcoid granulomas are associated with M2 macrophages. So we did a small study, but we did not find any correlation of M1 or M2 macrophages with tubercular granuloma or sarcoid granuloma respectively. But we saw that the granulomas which were more fibrotic had more of M2 macrophages. And now people are trying to do immunohistochemistry to make a diagnosis of sarcoidosis. So sarcoid granulomas have differential diagnosis. The commonest one is infectious granulomas. So whenever we see necrosis, neutrophils and eosinophils, we should do special stains to rule out fungus or acid-fast bacilli. But there are certain non-infectious granulomatous inflammation also which come in a differential diagnosis of sarcoid, and these 4 are very common, which include chronic Borrelian disease, CVID, sarcoid-like granulomas in malignancies, and drugs. This is an example of chronic Borrelian disease where we find sarcoid-like granulomas. There is slight excess of lymphocytes in these granulomas. However, location and morphology is similar to sarcoid granulomas. And these have been seen in patients who are exposed to beryllium at workplace, especially the dental technicians who are dealing with dental processes. So such cases require occupational history, and if some of the labs can do, then beryllium lymphocyte transformation test is a confirmatory test for chronic beryllium disease. Common variable immunodeficiency, which is immunodeficiency syndrome characterized by hypogammaglobulinemia. Mostly the infectious complications are common in immunodeficiency. However, CVID shows a peculiar pattern of a granulomatous lung disease, which has been termed as granulomatous and lymphocytic interstitial lung disease, and it shows a morphological variation in granulomas. They can be small with lot of lymphocytic infiltration to very well formed granulomas, which are just like sarcoid granulomas. So mostly in pediatric age group, if we see sarcoid-like granulomas, so this differential should be considered. Tumor-associated sarcoid-like reaction is also very common, and it has been associated with Hodgkin's lymphoma and solid tumors like gastric, lung, and breast cancer. And this is one example of infiltrating duct carcinoma and breast parenchyma, and the draining lymph node showing sarcoid-like granuloma. So in this case, the differential diagnosis was whether it's a sarcoid-like granuloma in response to soluble tumor antigen, or it is coexisting tuberculosis, or coexisting sarcoidosis. So all these needs multiple ancillary testing and multidisciplinary discussion. In other organs, there is no difference in the location of the granulomas. However, the morphology of the granulomas is helpful in diagnosing sarcoidosis. This is one example where whole lymph node was replaced by granulomatous inflammation, and the morphology of granuloma is just like sarcoid granulomas we saw in lung parenchyma. So this is example in the lymph node. This is cutaneous sarcoidosis, numerous compact epithelioid granulomas seen in the dermis and in the periaxillary location, and these granulomas are retic rich. In kidney, sarcoid granulomas, again compact non-casing epithelioid cell granulomas. However, there are other differentials also in renal parenchyma. So this is one example where we see sarcoid-like granulomas in interstitium. And this patient was a hepatitis C positive patient as were taking these drugs. So there was a temporal correlation of this granulomatous inflammation with the drug intake, and the patient improved after stopping the drug. So we can also see tubercular granulomas, classical necrotizing granulomas with nuclear debris center in kidney also. This is example of sarcoidosis involving the liver parenchyma. Here we see compact granulomas with fibrous cup which are present in the portal tract. Granulomas can also be seen in a centrizonal area that is close to the central vein, and it's said that if the granulomas are seen in a centrizonal area, it gives us a diagnosis of sarcoid granulomatous inflammation over tuberculosis. And the last photograph is showing a classical tubercular granuloma with central necrosis. We have very limited experience of sarcoidosis involving the heart parenchyma. This is one autopsy case which was a case of a systemic sarcoidosis. We dissected the SA and AV nodes. We did not find any granulomatous inflammation. However, there was presence of metastatic calcification noted both in a SA and AV nodes. So whenever we see a granulomatous inflammation in lung parenchyma or in other organs, we try to approach where we correlate histological findings with clinical and radiological picture. So thank you very much.
Thank you very much, Dr. Amanjit. That was quite an exhaustive overview. I would like to first invite Dr. Vikas Agarwal, who's been Dr. Vikas.
Yeah, I'm very much here, sir.
Can we just, yes. First, we would like to take your comments before we proceed, because we really echo the sentiments that you mentioned yesterday about the serious side effects of steroids, which are more obvious in a developing country. And you have listened to the talks. We would like to have your comments first before we open it to the auditorium.
Excellent presentations, and in fact, Dr. Amanji's presentation was it has taught me so many things which we were actually unaware of. Everybody had discussed this issue, and yeah, as a clinician, we are always very suspectful of our diagnosis of sarcoidosis because we don't have a reliable test to identify with 100% surety that patient has got sarcoidosis or not. And many times we have been proven wrong, and so we are actually very nervous in diagnosing patients with sarcoidosis. Looking at all the speakers, I feel like there are soft pointers towards diagnosis of whether it is sarcoid or tuberculosis, but none of them can actually reliably give us a correct diagnosis. A lot of molecular work has already been done in this area for last almost a decade, and I'll just point out some of the things which are not discussed during today's discussion. There are techniques where people are actually likely to have some kind of a proteomic work or a gene array analysis in the whole blood. And one of the paper which has actually come up in 2015 has actually shown that there are, if you look at the whole then it is likely that you can identify differentially expressed genes varying between tuberculosis and sarcoidosis, and also various microRNAs which can differentiate between tuberculosis and sarcoidosis. And to name a few microRNAs like microRNA 182, 355, and 340 and 15 have been reported to be reliably differentiating between TB and sarcoid. And among the differentially expressed genes, genes like lipocalin, myeloperoxidase, KLF2, hypoxia-inducible factor 1A also has been reliably reported to be differentiating between TB and sarcoid. However, we do not have a ready-made test for available clinical usage in practice. Similarly, for applying proteomics for the diagnosis or differentiating between TB versus sarcoid, T7 is a phage, and phage display libraries are actually constructed to display a lot of proteins of interest on the surface of the phages. So people have used this technology and were able to identify phages which are displaying peptides which are very much likely to pick up cases of sarcoidosis. And why I wanted to mention this, that we don't think that sarcoid is an autoimmune disease, but actually this paper and this group of workers who are working on this T7 phage display library have actually proven us wrong. And they have very categorically demonstrated that some of the sera from sarcoid patients actually do contain a lot of antibodies against the cytoskeletal as well as lysosomal trafficking proteins, and can reliably differentiate between tuberculosis and sarcoidosis. So these are some of the things which are in research. No doubt they are not clinically available to us, but the audience should be aware of that there is a likelihood that we may have some kind of a test soon to differentiate between the two. We have done some work in this area also, though it was just by accident only. Being a rheumatologist, we have a lot of sera of sarcoid patients with us, and because they do come to us with a lot of musculoskeletal problems, and while sort of emptying our -80 refrigerators to deburden them, we wanted to just throw away the unused sera. So one of my residents actually asked me, why don't we do a metabolomics? Because we have a Center of Biomedical Research within the campus of Sanjay Gandhi PGI at Lucknow. So I asked one of the scientists there, and he agreed to do NMR spectroscopy on those sera. And what we found was that there are certain metabolites like acetate or 3-hydroxybutyrate, which very reliably showed that they are very much increased in sera of tuberculosis patients as compared to sarcoid. But when we looked closely, then we found that the ratio of glutamate to glutamine was almost, with the area under curve of almost 1, was able to differentiate between sarcoid and tuberculosis. So initially we were very skeptical of our data. We thought there may be some technical error. Then we replicate this same study in a prospective way in a sort of a validation cohort kind of a thing, and again we found the same results. So we are very reasonably sure that we can differentiate tuberculosis from sarcoidosis, and we do use these tests to us many times when we are in a clinical dilemma, and we are actually trying to talk to a vendor where we can make some kind of a very quick test for the ratio of glutamate to glutamine, so that it can be brought to the clinic, so that many more centers can actually evaluate this test for the diagnosis or differentiation between tuberculosis and sarcoidosis. So with this, I'd like to just end my comment here, that future is not as bleak as it sounds, and there is likelihood of having a test soon which can differentiate reliably between sarcoidosis and tuberculosis. Thank you.
Thank you so much for the valuable insight. There's a question to Dr. Amarjit. In situations where they don't get a well-defined granuloma, for example, cardiac granulomas are deep in the myocardium, people have used dendritic cell markers as a surrogate for sarcoid. Is there any work, or what do you think we should be doing?
I'm not aware of that work, dendritic cell markers for diagnosing sarcoidosis. So people have used CD4 and CD8 differential expressions, but I'm not aware of dendritic markers helping in diagnosing sarcoidosis.
That was a wonderful presentation, ma'am, actually. So I think you had showed in one of your slides that the anti-HCV drug, which is used for treatment, can cause granulomas. So everybody should be cognizant of the fact that drugs can cause sarcoidosis. In the absence of which we probably think that tuberculosis, then followed by sarcoidosis, are the only causes of granulomas, malignancies, drugs. All these things are also known causes of, described causes of granulomas. Thank you very much, ma'am.
Thank you. Thank you.
So in this session, we had very good insight regarding the value of tuberculin skin test and IGRA in differentiating patients with sarcoid versus tuberculosis, which was the work presented by Dr. Alladi Mohan, followed by this diagnostic conundrum which Vijay Shekhar presented of the overlap syndrome of tuberculosis and sarcoid and extremes of the spectrum. I would like to again point out what was highlighted by Praveen. Muthaiya has now this month's Journal of American College of Cardiology has presented the immune reactivation in cardiac tuberculosis. When we start them on rifampicin, there is a worsening of cardiac arrhythmias, which is seen in about 20 to 30% of our patients. So this is probably more something like type 2 lepra reaction that you see in tuberculoid leprosy. When you start on medications, they have worsening symptoms. And this is going to be published shortly in JACC-EP. Again, we had a wonderful talk about the radiological features, which was presented by Dr. Bhavan Zankeria. And unfortunately, we don't have a radiologist to kind of give us insights, but he made it appear quite simple, but I'm sure there are nuances to it. Ocular sarcoid, again, we have been ignoring this. Looking at the anterior chamber versus posterior uveitis is something which we can kind of use it to our advantage to make this distinction. And a very large series from Yalvi Prasad has contributed immensely to our understanding in this particular area. Of course, we had again revisited our pathology days with the wonderful slides and the value of, is there a threshold for reticulin staining? How much of reticulin is, can you quantify to say that this much is significant versus?
No, so there is no quantification. Only thing is if individual epithelioid cells are surrounded by reticulin stains, so we call them reticulin rich. So that's how we interpret. So if the center of the granulomas is not showing any reticulin stains, so probably it goes against sarcoidosis.
Okay. Thank you very much. I think we had a wonderful, go ahead.
Yeah. For the sake of the younger colleagues, actually I have a brief comment, and I would like to reiterate the fact what Dr. Praveen had mentioned. All efforts should be made to send all the tuberculosis tests, because a lot of times we see patients coming from other specialties. They have taken a biopsy but now sent gene export. Some people will not send cultures. So it should be in a common practice to send, in addition to your AFB stain, liquid cultures, which are the gold standard for making a diagnosis of tuberculosis, Gene Expert Ultra, which is again the new version of diagnostic PCR test, PCR based platform for tuberculosis, and also we have now XDR Gene Expert. All these tests have to be definitely sent. In spite of sending all these things, sometimes as we have all discussed yesterday and today, there is a subset of patients who have overlap of tuberculosis versus sarcoidosis. So my thing, which I want to just give a useful clinical pointer or a practice point for all the clinicians, is that if you have a clear-cut sarcoidosis, probably you would start with steroids. And if you have a case of tuberculosis, then you start with anti-tubercular treatment. But in case you have an overlap case where there are overlapping features, and that was the thing which was taught by Dr. Dheeraj Gupta, who is a sarcoidosis expert to us actually. Unless the sarcoidosis is life-threatening, do not initiate the patient directly on steroids. You initiate the patient on anti-tubercular treatment, and then after 2 to 3 months of therapy, you can start the patient on steroid as well. This is because if you're directly starting a steroid along with anti-tubercular treatment, as has been discussed earlier, one is rifampicin will increase the metabolism of prednisolone steroid, the bioavailability of the steroid will come down, and again there is a possibility that TB might flare up and lead to disseminated tuberculosis. If the tuberculosis sarcoidosis is not life-threatening, we would prefer to, especially in our setting in the pulmonary practice, most of the pulmonary thing would not be life-threatening unless it's an acute respiratory failure kind of thing. We would prefer to start with anti-tubercular treatment, then wait to start steroid, but that would be something slightly difficult maybe in the cardiac side, where you would prefer to start both. What is your experience on that?
Yeah, I think we fully agree with you. I don't know how relevant it is. Whenever a patient is suspected to have a life-threatening arrhythmia, MAN2, we repeat a MAN2 2 weeks apart. There have been some report of sensitization from the first MAN2. So if 2 MAN2 tests 3 weeks apart come as negative, that gives me a reasonable, IGRA is negative, 2 MAN2 is negative, there's nothing, gene expert is negative, nothing, then we are reasonably certain. We go take that extra step to rule out. If any of them there is an inkling that it's tuberculosis, we start anti-tuberculosis therapy with steroids. Here we don't stage it because when we start rifampicin, we have had patients where the VT storm happens after starting rifampicin. So we invariably start, it's like CNS tuberculosis. In closed space, small granulomas, when they expand, they cause some kind of effect, anatomical effect, and therefore we start both together.
So the analogy is similar, sir. Actually, in patients with occult adrenal involvement, if you start rifampicin, it is said that rifampicin increases the metabolism of endogenous steroids and lead to Edisonian crisis. Here also, maybe because of the increase in the endogenous steroid metabolism, it would lead to flare-up of sarcoidosis. And if anyone else has any comments, we would take, or else.
Kind of an overdose of TB and sarcoidosis. I would like to thank all the expert faculty. One we have from Dr. Sharat Chandra.
Sir, a wonderful conference. I enjoyed with my students. I think it should be, reachable to everyone. I think next time you publicize well so that everyone get benefit.
We will do that.
Congratulations.
Thank you so very much. Dr. Somraj's years of experience in clinical medicine and
anyway, I was under the impression it's at 3 o'clock, so I came late, sorry. Then, see, when you're talking about rifampicin and its exposure and problems, there are situations where in sepsis, for example, some of the organisms that we are supposed to treat, we start other antibiotics and add rifampicin later. What do you think of that type of strategy in this situation?
It's always a concern that it will have multi-drug resistant tuberculosis when you stage it and start. I'll have Praveen to talk.
Yes, sir. Thank you. Sir, in most of the cases where we use rifampicin, is usually prosthetic joint infections or infective endocarditis with prosthetic valves, where because if you rifampicin is the drug which acts on at the level of DNA, same are quinolones. So if you are giving it as a monotherapy, the bacteria or tuberculosis will develop rapid resistance. So in these cases, the idea is usually cover it with some other antibiotics, bring the bacterial load to lesser level, then start rifampicin. So that strategy in active sepsis or prosthetic valve infection or prosthetic joint infections is a little bit different here. Here we are using all the drugs up front. So we should not be starting rifampicin. It won't help in such cases, sir, in TB patients. To start
just starting everything together.
Yeah, yes, sir, yes. It won't make any difference even if we start after 2 days.
No, no. Dr. Sangraj's point was if you first give the other 3 drugs and then start rifampicin a week later, are we less likely to see IRIS?
Sir, iris, one thing is rifampicin, which we are calling, but iris is very common in any extrapulmonary tuberculosis, ranging from 20 to 50%. One of the thing is TB itself causes immunosuppression, and the moment we start treating TB, the immune activity is going to come up. So it will as you suggested that rifampicin can metabolize steroids, but even without rifampicin less regimens also iris is very much possible.
I think with this we would like to end the session, but before I close the session, I would like to thank the actual people who were behind the scenes, who are instrumental in putting this together. Especially Dr. Jugal Kishore Muttaya, who is, I don't know, he's not to be seen. I think he hasn't slept for the last couple of days. He has been the main person trying to put things together, and along with Dr. Madhuri and Dr. Vishwanath from this team. And we had wonderful support from the audiovisual from AIG Hospital and the administration and all my colleagues. Not but this is very, very important. Any meeting, the content is most important. Whether you have 2 people in the audience or 20 people or 200 people, the content you focus on. I am really happy that the content was very good. And I would like to thank all the faculty, both the international speakers and the national speakers and the local faculty, who have put in a tremendous effort to make this grand success. And we would like to thank all the participants, because there is a very active interaction throughout the meeting. And I would like to thank all the participants for making this a great event. Thank you all and have a good weekend. Thank you.
We have tea being served outside actually. All of you can join for the tea.